requiring the attention of everyone present in the auditorium. Can we please maintain a little silence? Our respected DPH sir is about to deliver the opening remarks. Over to sir.
Good morning. On behalf of the Directorate of Public Health and on behalf of Organizing Committee of Dphicon 2025, I warmly welcome all the distinguished delegates, experts, representatives from different organizations, and the esteemed speakers who have gathered here to grace the occasion of the 2 days Public Health Conference conducted by the Directorate of Public Health and Preventive Medicine team. You all know very well, most of the participants are aware that yesterday we have conducted a pre-conference sessions with components of artificial intelligence, mental health preparedness, and also health technology assessment. We are thankful to the participants who attended the pre-conference sessions, and I believe that yesterday's program was much beneficial and also useful in taking the public health department forward in a more nurtured way. I would also like to extend a special thanks to all our stakeholder participants, all our organization who are partnering with us for more than 100 years in public health. And also, I extend my warm welcome to the organizing committee members, volunteers, and supporting teams who have worked immensely to make this Dphicon a grand success. We place on record our sincere gratitude to all the participants for their active involvement in all the sessions and also in all the activities or components of this conference. Our heartfelt thanks to the Medical College faculty who have organized a quiz program, a junior panel discussion, which will be a first one of its kind, which we have introduced in this conference. I would like to experience, probably the junior panel will be conducted in this conference hall, and I request you to give your feedback and inputs so that our future leaders are prepared very well to face the public health challenges in the future. We remain thankful to every individual and institution whose support has helped us to make this conference a successful one. In this juncture, I would like to place some points where we are conducting or why we are conducting this conference every year. In fact, the question is, should we conduct this type of conferences every year? Or should we invite all experts to share their experiences, knowledges to our public health cadre, which is first of a kind in Tamil Nadu? The first and foremost priority will be the knowledge and policy. Knowledge sharing is very much important, particularly in this era of technological improvement and artificial intelligence, and we can coin many words like machine learning, artificial intelligence, etc. The capacity building is very much essential for all the cadres of public health. Next. Another important is collaboration and innovation. Public health is a unique or a unit of the whole health and social development. But can public health exist alone, or can public health alone can contribute or achieve anything? It's definitely not. Public health in other countries mean other states and other countries mean it is a public institution or the provision of healthcare services to the public is vested with the country. But in Tamil Nadu and in some of the states where we are foreseeing public health cadre, the public health means many think that it is communicable diseases, epidemic preparedness, disaster management, or program, national health program implementation. It is not so. We need public health in toto means it puts all departments in the health and family welfare department of Tamil Nadu as well as other line departments like social welfare, ICDS, education, revenue, rural development, town panchayat, municipal administration, urban local bodies, etc. So we have a lot of partners who were working with us, who are working with us, and who will be working with us. So encompassing every team, every department, we need to have networking and partnerships across sectors. And also in this era of digitalization, we have to encourage innovation and digital health. Next. Also we have an emerging challenges and also we have to be prepared for that. Addressing emerging and re-emerging health challenges is a foremost issue. Many of the new doctors, many of the new nurses, because public health in Tamil Nadu is every year facing a dynamism of new doctors. Probably thousands of doctors are coming into the system while those thousands of doctors are going out of the system for want of their career progression or by means of retirement or voluntary resignation. But the input is equally good and the training and the capacity building is needed which is very much essential for emergency preparedness as well as re-emerging and emerging disease. See, every time there is a threat or a public health threat in Kerala or the bordering states, the first question in Tamil Nadu, the media or the government or the politically committed persons, first they ask what is the border preparedness in Tamil Nadu. This is a very, very, very essential and simple question. But the new doctors, new nurses or the new health workforce, field or institutional workforce, they have to be prepared for facing these challenges and also be prepared for managing or tackling these issues. So there is the theme of this conference is resilience. The resilience means you have to face everything, you have to withstand everything, and you have to come back after each and every disaster. Next. And also the important is not only the health workforce need to know everything, but the same tempo has to be conveyed to the community. Unless the community knows what is happening in the department or what is happening to the improvement of the self or some form of treatment or recovery for the individuals, for the family, for the community. So our main part is IEC, awareness making, behavioral change communication, etc., etc. There are many jargons which we can go on talking about this awareness terms. Human resource development is a challenging one in the current situation of financial, crunch in every country, and also the assumption of any time disaster in the financial system or the financial management system of the whole country. Everybody is talking about other countries, but now we are downsizing human resources in both private as well as government institutions. So the downsizing means whether it is fitting to health department or not. That is a $1 million question. So suppose if we have a doctor in a PHC, single doctor PHC, if you downsize one doctor, what will happen? Suppose if you downsize a doctor, number of doctors in a unit of a medicine department or a cardiology department in a bigger hospital or a bigger medical colleges, it will not have immediate implication. Probably it has implications and challenges, but having 2 doctors minimum in a PHC cannot be downsized. Similarly, 4 nurses in a primary health center cannot be downsized. So human resources development motivation, and also the demand for human workforce should be brought from us, and also it should be conveyed to the policy makers. So that has to be discussed here. We have a HRH policy evolving in the Department of Health. So now we have to talk about strengthening human workforce. The human workforce retention was very strong in Tamil Nadu some 12 or 13 years back, but now it is a challenge. So retaining doctors, both from the individual perspective, from the community perspectives, and also from the government perspectives, is very much essential. Next. The student engagement, I have missed about talking about student engagement. Now we have NMC bringing into family adoption program, where the dream is every student should look after 3 or 5 families right from the joining of medical, right from the time he or she joins the medical college. So that is actually complementing the universal health coverage objectives. What is universal health coverage, or what is comprehensive health coverage? Suppose if we go to a household, if there are 5 members, elderly person, a widower or a widow, along with the families in a joint family or a nuclear family, or a single person living alone in a house, they have to be taken care of. Suppose if a person, if a health person goes to a household, for each and every category of individual, suppose if it is a 60-year-old male, we have programs, we have schemes, we have strategies. Suppose if it is a 5-year child, we have different programs. Suppose if it is he or she is an adolescent, we have an adolescent health program. Suppose if it is a child less than 1 year, we have a immunization program, nutrition development, exclusive breastfeeding, supplementary feeding, etc., etc. So a lot of programs focusing on individual families, in fact individual persons. So the universal health coverage is complemented by the engagement of not only existing health force, existing health persons in the public health, but also from different quarters of the health department. For example, I was talking about the family adoption program. Similarly, NMC has introduced a district residency program. So all focus is taking health to the community. It is not the community coming to the institution and getting health services. It is taking health to the individuals. So the typical example is, now we have the NCD program. It's termed as Makkalai Thedi Marthum in Tamil Nadu, which is taking every medicine, every tablet to a household, wherever it is needed. And the next one is equity and accountability. Again, the take universal health coverage, it overshadows all the concepts of equity and accountability if it is ideally implemented. And this has an indirect implication on achievement of SDGs and health goals. Next. Next. And now, this all activities so far we have done in the year, in 100 years, have to be showcased. What is to be showcased? Achievements and best practices. Cross-country experiences, cross-state experiences, cross-district experiences, now coming to cross-block, in the national language we can say cross-taluk experiences. All have to be put together, implementing the best practices and implementing the innovations are to be showcased here. That is our objective. Next. Next. And you know very well that all policy dialogues, in fact, earlier we have a saying that major decisions are made over a cup of tea. Major decisions are made over a cup of tea. 2 persons talk in a table, in a hotel, they decide and it becomes a major decision. But nowadays it is not so. Every decision, every policy framework, dialogues have to be based on evidence-based, be it a clinical decision or be it a public health decision, or it is a sociological or socio-public decisions, it is needs evidences. Now, particularly in the era of social media, digital platforms, and artificial intelligence, definitely everybody will look for evidences. You see, a normal person, a lay person goes to a doctor and asks for some treatment, and he refers to the Google and artificial intelligence messages and countering the doctor's advices, and he is asking for plan A, plan B, plan C for the different treatments. So now we are at a very embarrassing positions that we have to be prepared with plan A, plan B, plan C. So for multiple plans, we need to have evidences that can be discussed here. Next. So summarizing this, the strategic platform for knowledge and collaboration, this conference will be useful, strengthens preparedness and resilience, promotes innovation and digital health. I told you yesterday there was a conference, workshop on artificial intelligence, and many of the public health, the stakeholders, NGO stakeholders are coming with various innovations, particularly with reference to machine learning and artificial intelligence. It is introduced already in the tuberculosis program. We have a portable X-ray, which is taking multiple X-rays, be it a false positive, more of false positive or more of false negative. Forget about that. But we have introduced, we can make more and more improvements in the years to come. Promotes innovation and digital health, enhances equity, inclusivity, and also accountability. And ultimately, this conference brings many people, many experts, and which can make some changes in strengthening the public health system and also ultimately the population well-being. Coming to updates in public health, I am not going to talk about numbers because we know, everybody in Tamil Nadu know where we are. Next one. See, globally we have a different, now the era is, particularly in India, it is not pre-independence, post-independence. Globally it is not first global war or second world war. It is pre-COVID and post-COVID. Now, post-COVID-19 preparedness or post-COVID, we have changed ultimately into a new thinking or a new platform. Even if a man dies of an accident, now people start asking, probably it should be due to COVID. Such an amount of, extensive amount of or in-depth analysis of COVID are being undertaken. Climate change and health, heat waves, floods, vector-borne diseases. Digital health transformation, AI, telemedicine, global health strategy, digital strategy. Universal health coverage, we have started implementing, we are into it, we have seen many successes. And antimicrobial resistance, again a global action against antibiotic misuse. Everybody is talking about AMR, every day news about AMR is coming, but we have to have a long way to go. Then mental health prioritization, community, everybody, yesterday again there was a pre-conference workshop on mental health. Everybody in this room, I can definitely say everybody in this world is a mentally healthy person, and why we can also say mentally not healthy person. I will not say mental illness, but everybody is not mentally healthy to a perfect 100%. So we have to have a mental health services and priority should be given to that. Next. So now what we have in our country, the National Public Health Bill, modern, it is probably it is overtaking our public health acts, and Ayushman Bharat Health and Wellness Centers, expanded primary health care, digital health mission, Ayushman Bharat digital health mission, we are going into. Now the challenge is getting an Aadhaar card itself is a challenge. Now getting an ABA ID is a challenge, and now if you go and enroll yourself as a student in university, you have a one digitalized student ID number. Unless you get a student ID digital number, you cannot enroll in a university. To such an extent, in all departments, the digital platforms have come into play, and non-communicable diseases, still we are diagnosing diabetes, diagnosing hypertension, diagnosing complications, but we are not controlling them. We are finding it a challenge to control them. So it has become a major problem. And cancer, unless it is early detected, it's very difficult to manage. By the time you suspect, by the time you do a biopsy, by the time you bring a result to the individual, by the time you start the treatment, the patient goes into stage 1 to stage 4. So the lot of time is lost. So probably we have to find out some mechanism to, or AI, use the AI to suspect and do the treatment, initiate the treatment at the earliest. So we all know about nutrition, anemia control, maternal child health, and now particularly in institutions, the quality issue is a big talk. And unless we practice quality day in and day out, see, the medical colleges have the annual function. It is not the anniversary function. It is not the convocation. It is the NMC visit function. Similarly, the quality should not be a function. It should not be a celebration. It should not be a one-day affair. It should be talked of. It should be internalized, and every day it should be practiced in such a way that the individual coming into institution for ailment should not ask even a single question to complete his treatment, except for telling his complaints. So that amount of quality should be internalized and practiced. Vector-borne diseases, again, we have not controlled dengue, we have not controlled chikungunya, we have not controlled malaria to the extent which is anticipated or expected. We have controlled to our satisfaction. See, so for example, filaria, leprosy, we told that leprosy has come down. But if you go internally into every blocks or every taluks, then we say this block is high risk. We cannot say, we cannot take a norm of, suppose if it is less than 1 per 10,000, leprosy has been eliminated. It cannot be a national goal. It should be a block goal. It should be a taluk goal. Similarly, every time we go into the internal or intricacies of each and every disease control, we find new surprises, and still we have challenges. Next. In Tamil Nadu, we have a different way of coining, but still we are in tune and with the global and India update. We have Makkalai Thedi Marthuvam, health facilities at the doorsteps, and campaigns and camps. For example, we have recently converted this Varumun Kapum Thittam, the village level camps, as Nalam Kakum Stalin. So what is special in that is using or utilizing the available technologies, incorporating health management information system in the camps, creating ABA IDs, creating or delivering the insurance cards, all are well appreciated by the public. We can see visually or physically we can understand the satisfaction with which people go out when they go out from the camps. We cannot say that all the 1,500 people or 2,000 people who come for the camp are going with satisfaction. But we can definitely observe improved sense of satisfaction in total among the public as well as the political or elected representatives when they give us inputs and feedbacks. Yesterday our additional director was saying, one of the political person, he was saying he is going to give treat to the his constituency health workforce because he is immensely satisfied with the way the people are working, the health people are working. So that type of feedback when we listen, it gives us a sense of satisfaction and feel of award being given. So such type of inputs we need. It is not for the gratification, it is the sense of recognition when we can understand the satisfaction and also the words uttered by the people for our, it is recognition of our services. It is not again recognition, it is acknowledging the service. I will simply say no certificate, no award is needed. But if people acknowledge whatever we do, then that is the final. And again, expansion organ donation, I will say Tamil Nadu is the leader still for past 8 or 9 years. And expansion of emergency care, we have innovated and followed best practices in the form of 108 and trauma network. Public health workforce strengthening, I was telling that the health workforce retention was unique in Tamil Nadu some 10 years back. Now we have to bring back the same tempo, that is the need of the hour. Next. So now through this conference, shall we still focus public health moving towards preparedness and resilience, digitalization and innovation in healthcare delivery, equity and inclusivity, and focus on NCDs, nutrition and MCH further, and climate change adaptation and community-based care. So now everybody talks about rabies, everybody talks about dog bite, and everybody asks whether dogs can be controlled. And now it is open to the forum, open to the community, open to the policy makers, which should be controlled. Now it is again a question to the people who are administering vaccine. How long we are going to administer vaccine? What is the quantum of vaccines we are going to get or supply or distribute or give? We do not know. So this is, for example, I'd say there's a lot of challenge. We still have to deliberate and discuss in the opportunities like this. Thanks. Next. Thank you. Thanks again for all the participants, delegates, experts who have come here to grace the occasion and make the conference a success. Thank you. Thanks for the organizers.
Thank you, dear sir, for your pearls of wisdom. The backbone of any PHC has been the goal of providing a financial risk protection against healthcare cost. Moving on to the next session of the day, panel discussion on health financing in primary healthcare settings. I would like to invite our Additional Director, Dr. V. Vijayalakshmi Madam, onto the dais to moderate the session. The linchpin, the keystone of PHC, the universal health coverage, preventive, promotive, curative, rehabilitative, and palliative are the apt words. I take immense pleasure in introducing the speakers for the session, Dr. Himanshu Bhushan, Public Health Specialist, former Advisor and Head, Public Health Administration, NHSRC. Welcome, sir. Onto the dais, please. A few words about Dr. Himanshu Bhushan. He has been the former head of Public Health Administration Division, National Health Systems Resource Center, supporting GOI. He has led the development of key healthcare policies, including guidelines for district hospitals, national ambulance services, and the National Urban Health Mission. I would like to invite our second speaker for the session, Dr. Grace, Technical Officer, World Health Organization, Country Office for India. A few words on Madam. She has been a health economist and medical doctor with 19 years of experience in the health sector across Africa, India, and Australia. She has served as a medical officer in both public and private sectors, including Baylor College of Medicine, Children's Foundation, Uganda. Professional supremacy in public health policy, economic evaluation, strengthening health systems through evidence-based approaches has been her accolades. I now request Dr. V. Vijayalakshmi Madam, our Additional Director, to moderate the session. Over to Madam.
So good morning to all. அனைவருக்கும் இனிய காலை வணக்கம். So it's on, sir. It's on. So I would welcome both of you for this wonderful panel discussion, sir. It's not audible. Okay. Yeah. So first, Sir Bhushan, sir. I would like to brief about discuss about the investment in the primary health care, like in health financing in Tamil Nadu and in India. Then what is the status? So what is the status of health financing in Tamil Nadu and in India, and its impact in reducing the out-of-pocket expenditure and the gaps in delivering the primary health care, sir. And your experiences and expertise where you have visited in other countries. And for madam, yeah. So we would like to hear from you, because where we have limited budget, how can we prioritize it? So how can we set our priorities and maximize the health outcomes? And the data needed for HTA and about HTA, and what are the key elements in the good priority settings? All this we need the inputs from you, ma'am. Thank you. Sir, can present first.
So, very good morning to all the participants. First of all, I would like to thank Dr. Selvaji who could not join today because he is out of station. Our beloved Director Public Health who has just taken over, Dr. Soma Sundaram, a long-time friend of mine, and the whole, public health professionals of Tamil Nadu. Most of them I know very closely, and also the panel member and also the panel, coordinator ma'am, for giving me this opportunity. In fact, Tamil Nadu is the only state in the country who is conducting, such public health sessions since last 4 or 5 years continuously with a prospective vision where with a focus to the young generation and building their, concept, future thinking and prospective, planning aspect. So it's a great endeavor and I am greatly thankful to the state for this. Now, today's topic is very important given to me. So, what I would like to deliberate today is, first of all, I would like to showcase you what are our goals, and then if these goals are to be achieved, what we did in past to achieve these goals, and how now we should also do, and for achieving these goals, do we have adequate funding, and if not, how we need to approach it. So this will be a sort of approach of my presentation. So what we can see very clearly is our national health policy commitments, the SDG goals, the universal health coverage goals, and also creating a resilient health system, be it RMNCHA, non-communicable disease or SDGs, but along with that also how to reduce the out-of-pocket expenditure. These country goals can only be achieved if the states achieve. And Tamil Nadu will look forward always, Kerala will look forward always, because your achievement is not the achievement of achieving the goals. Your achievement is achieving beyond the goals. And you have always done so. It's not that you have not done so. So how do you achieve your goals beyond what are the goals and targets is the important point to deliberate. You can see all of you sitting here in this room, all of you know how you reduced MMR, NMR, TFR, IMR, and it has always been reduced beyond the achievement, beyond the goals. It was accelerated achievement of your goals always. But this achievement, if you see that how you achieve this, you achieve this through collaboration and partnership, building community, in your fold, bringing community in your fold, utilizing ASAs, VHNs, Anganwadi workers, timely antenatal care, identifying high risk of pregnancy, full antenatal checkup, full immunization coverage, birth planning, a timely referral, along with, you had your secondary and tertiary care for emergency obstetric care. Majority of these achievements are because of your actions at the primary level. Now, same if you will see for Tamil Nadu, how you have reduced your TB. Your investment again in the community level. You screened all the adults. You found who are suffering from respiratory problems, who are underweight, who are malnutrition, and you linked and referred them timely to the higher health facilities. Not only that, even at the PHC level, you have molecular diagnostic, equipments available there. So, and along with all the workforces that were available, you were able to reduce your case notification, and you were increase your case notification, also increase your successful treatment rates because of this cascade mode of the care for the TB, where the pyramid's base is the primary care. Again, at the primary care, your investment paid in your elimination of the disease burden. And what the global technical agencies said, the WHO also confirms that India has a very high cervical cancer load, and if this cancer load is to be reduced, your attention needs to be given for the screening and the vaccination. Sorry. So your attention needs to be given for screening and vaccination. Just by the screening and vaccination, it's a very cost-effective, model, and you can reduce cervical cancer cases up to 76% and deaths up to 81%. So all this again at the primary care level. Now, sorry, I missed this slide. Correct. So now if you will see the disease burden of Tamil Nadu, again if you will see the success rate, it is for communicable disease, maternal, child health, accidents and trauma. And all these efforts, I vividly remember when I was there in the ministry, the state came forward with a big budget on the emergency care, and up to the PHC level, your emergency care was streamlined up to the tertiary care. And you can see the reduction because of that, effort. Mother and child health, MNCH reduction, you already know that primary care investment has, helped in it. So, if you want to reduce your NCDs, communicable, it is reflection of the investments done in the past, meaning wherever we have allocated funds to strengthen the ground level human resource, if we have improved the training capacity, if we have improved the infrastructure at the lower level, there the reduction has been achieved, and that will also help for our cardiovascular disease, respiratory and other NCD problems. Now, if you will see our nutritional risk factors, then again if you will see for Tamil Nadu, we have a very high hypertension, high blood sugar level. We also have a high BMI, and all the parameters of the NCDs, nutritional parameters of the NCDs are very high. And if we want to reduce this NCDs parameter, then what we need is primary prevention. Primary prevention is the need of the hour, because all these important things cannot be done by the tertiary care investment, but it needs investment and care at the lower level through a healthy lifestyle, through the nutritional counseling, and such small things that will help you, rather than doing investments at the higher level. Now coming to the out-of-pocket expenditure, National Health Policy says that we have to reduce to 25%. It is still not saying we have to reduce to 0%, 25%. And where we stand now, even Tamil Nadu is at 34% and India is at 39%. So unless the out-of-pocket expenses of the states will be reduced, the India's population will not reduce, and India stands at 69th position, and 1.5% of the GDP goes for the out-of-pocket expenses, and your OPD per delivery at public health facility is still 3,316, despite Suman and so many other care guidelines. Now, this data might be a little bit old, because after the insurance and health and wellness center, this must have changed. But then what we are seeing here, that both your urban and rural population, the large section of the people do not have the coverage. And if they don't have the coverage, it is only the government health expenditure will help them, in getting the coverage of the medical care and reducing the out-of-pocket expenses. Now, if you will again see here that our 1.2% of the GDP, Government of India has at present till now achieved 1.2% against 2.5%, and if we talk of the state's budget, instead of 8%, you have achieved only 4.3%. Only 3 states are there, Odisha, Puducherry and Delhi, who are putting up 8%. Whereas even the countries like Thailand, Ghana, Rwanda, they are putting 16% of their overall budget for the health care and expenditure, and majority of them for the primary care. Now you see, this graph indicates if the government health expenditure increases, then our out-of-pocket expenditure decreases. So unless we improve the government health expenditure, you have seen that graph, because majority of our population does not have a coverage. So we need to improve government health expenditure, and if we improve the government health expenditure, our GDP also decreases. And state-wise allocation, if we see the funding norm, of course, even the country has not achieved the desired 66% investment at the primary care, and the country has not achieved even it at the higher center. But at least India, the trend is good. You can see the investment at the tertiary care is the lowest, and the investment at the primary care is the highest. Now, if you see the same trend for Tamil Nadu, it is just opposite. So your tertiary care investment is the highest, and primary care is the lowest. And what you have got in the last 10 years, analysis from, it is only, say about 18% of the total budget you are getting as the primary care. Whereas I told you, even the countries, smaller countries like Ghana, Rwanda and other countries, they have given highest budget to the primary health care. Now see, where is your footfall? Your footfall is in the PHC. PHC is not the indoor. PHC is the only outdoor. So all the outdoors are at PHC, but your investments are at tertiary care. So this trend needs to be reversed. This is very important because we have already seen the answer for reducing mortality and morbidity lies in the primary health care, not in the investment of tertiary care. But when it comes to funding, it is just opposite. So unless this trend is changed, this is not possible. So again, the risk factors. You see, the most of the risk factors can be tackled through metabolic, behavioral and environmental actions. And these actions are again primary care actions, not a tertiary care actions. Most of the behaviors, most of your bigger risk factors can be tackled through this, and this is also at the primary care level. Now, again, almost summing up that this is the slide given by the WHO said that scaling up primary healthcare interventions across low and middle income countries could save 60 million lives and increase average life expectancy by 3.7 years, and estimated 75% of the projected health gains from the SDG could be achieved through PHC. So internationally also we are saying that you need to invest in the primary care. And if you see this slide, this is a self-explanatory slide that whether you want, cath labs or you want change of the lifestyle, healthy food, yoga, exercise. So all the major disease burdens can be tackled through the simpler things rather than, going to the clumsy problems. Now we have the gaps in health system. I am not going to deliberate much on it. You know your gaps. On the one hand, even the poor countries like Ghana, Rwanda and Thailand, they have invested more in the infrastructure and human resource at the primary care, but our infrastructure at the primary care is still not yet complete. And yesterday, I visited a medical college, informally I went there, a 2,000 bedded hospital. So do we expect our rural people all to walk to the medical colleges? This is a point for pondering. Now, finally, if you see our approach, so patient-centric approach with approach towards the community, infrastructure, human resource and finance with an overall health plan will help us achieving our universal health coverage goals, because district health action plan is the central, district should be the hub, and we don't have the district hospitals, or if at all we have, people are not knowing. So unless the district is the hub and whole primary care from the district to up to the down below is governed by this community based approach is not there, this is very, very difficult for us to achieve. So in the last, I would only like to say, to accelerate the reduction of disease burden of the state, it is pertinent to invest more in health and prioritize primary care. That is all. Thank you so much. Sorry for taking some more time.
Thank you, sir. Thanks for your valuable insights. Now I would request Dr. Grace to talk about HTA.
No, this is the old slide. There are other slides that I sent later on. This is the old presentation. While you load, I can speak while you load, but let me wait for the next. There's a new presentation. Good morning, everyone. This is the old presentation. I sent a new one. This is not the old. This is not the new one. This is the one that I sent yesterday. Good morning, everyone. My name is Grace Achungura. I lead the health systems strengthening work in the WHO country office in India. While they set up the right set of slides, I will just preface my talk by first of all congratulating Dr. Soma Sundaram, Director Public Health, for a well-organized conference. It takes a lot of work to put together something like this, so I want to congratulate you and your team. I also want to congratulate the state of Tamil Nadu on the progress that has been displayed here. You are one of the states that not only India looks up to, but many countries in the world look to learn a lot from what you are doing. So I just want to use this opportunity to encourage you to keep doing what you are doing. The other thing is, it's an honor for me to speak at this meeting, and I do not take it lightly. WHO is very honored to partner with the state of Tamil Nadu in the implementation of your efforts towards improving health and well-being for the citizenry of your state, and so I'm glad to be here. I'm going to be speaking about priority setting in primary health care, and I will preface it by remarking, reflecting on the presentation that Dr. Bhushan has made. As you can see, at the beginning of, in 2017, the government of India made some aspirations on things that they wanted to achieve for health. And one of the things was they wanted to improve spending on health up to 2.5% of GDP. As we have seen from the slide, we are in 2025, but the latest statistics show us that it's only 1.8% of GDP that the government has managed to achieve so far, and there are reasons for that. And that is what makes the presentation that I am making pertinent. Thank you. First of all, can you all hear me? And you can understand my accent? All right, we are good to go. Okay, so in the next few slides, minutes, I will be reflecting on priority setting in primary health care. And I will first start by defining what primary health care is. I will also talk about what priority setting is and why it is essential. I'll touch a little bit on the different methods, but I'll focus on one. We'll see how it has been applied in other countries and what it has enabled them to achieve. And we'll also look at what has been done in India and what India has been able to achieve therein. So in 2018, the world had another meeting on primary health care in Astana in Kazakhstan, and many of the world leaders, including leaders from India, the Minister of Health went, and they were reimagining primary health care in light of universal health coverage and the SDGs, what it means. And that was because the way different countries were implementing primary health care was not up to the mark. In some cases, it was being selectively implemented, and so they needed to have a holistic definition, and this is what was proposed. So primary health care is a whole of society approach to health and well-being that is centered on the needs and preferences of individuals, families, and communities. It aims to organize and strengthen national health systems with the particular aim of bringing services closer to the communities and the individual, enabling access, equitable access to essential services. There are three main aspects that I want to emphasize here. One is integrated health services. So it's not enough to have a primary care level, a secondary care level, and a tertiary level. These must be integrated. They must speak to one another. In addition to the community level, and that's where community empowerment comes in as a second pillar of this approach. The engagement of the communities is very essential. And lastly, a multi-sectoral approach that is addressing the social determinants of health like wash, water and sanitation, education, nutrition that affect health and well-being. And so primary care is different from primary health care, and it's important to emphasize it. Many times when we speak of primary health care, people immediately go to primary care. That's different from primary health care. Primary health care is broader. Now, as Director Sir presented earlier, there are many things that have come up. Digital health, mental health, communicable diseases, non-communicable diseases, injuries, climate change, COVID-19, different pandemics. The needs are immense. And as we had seen earlier, like we saw from Dr. Bushan's presentation, the government committed to 2.5% GDP. Whether that would have been enough to meet the needs for primary health care or health in India as a whole remains to be seen. But even that we were not able to achieve, as the data he presented and the one I'm presenting shows. And that is because resources are finite. There is scarcity of resources, and because of scarcity of resources, therefore then it is important to rationalize how these resources are distributed. So priority setting is important because it is a systematic process and a deliberate process that recognizes that resources are scarce, and therefore decisions need to be made on what health interventions you finance, what services, and for whom you are prioritizing these resources. How these resources will be distributed among different people, and also which trade-offs are acceptable. Shall we say we shall immunize, we shall provide free care for pregnant mothers and children who are under 5, and maybe trust that somehow the elderly will be able to take care of themselves because resources are scarce? If that is the case, is it a fair decision that we have taken? So those are some of the decisions that priority setting concerns itself with. It is because, again, expenditure is increasing. We are seeing more and more drugs coming on the market for cancer, for obesity, for diabetes, but these are not cheap. The newer the technologies, the more expensive they are getting. And we see that health expenditure is growing, but the budget may not necessarily be growing. So because of that, then you have to make decisions on what to fund and what not to fund. The epidemiological changes, as Mr. Bushan talked about, which I want to go into, as well as we are seeing in low-income countries a transition as donors are leaving. So for instance, in Africa, where I'm from, some countries in Southeast Asia, the funding cut that happened because the United States decided they were not going to focus a lot on foreign policy has meant that now governments have to go back and see how to fund their services in a different way. Now, priority setting can be done in two ways. Do not be fooled. Every government, whether it is the US, whether it is the United Kingdom, whether it is Sweden, they are all doing some sort of priority setting. In some cases, it is explicit, meaning that the government will call some stakeholders together and say, this is the budget we have, these are the priorities we have, these are the key issues that face us. Now we need to decide how we divide the pie across the priorities. And we shall use these different criteria to judge which intervention should be funded. In other cases, the decision making is made behind closed doors. A busy politician or a director, I'm not saying you, sir, but will decide to fund something without necessarily bringing other people on board. This usually happens in hospitals as well, and that way it is called implicit. You're not quite clear why cancer is getting funding and diabetes is not getting funded, because that was done behind closed doors. It can also be technical in that it is guided by clear processes. For example, health technology, cost effectiveness analysis, as we shall see later. Or a politician comes up and says, I've decided from now on, everyone in India is getting free care. That is a political decision. It has not been informed by what is feasible, what the budget is, because the politician has decided you will all go along. So there are many tools that are used to inform priority setting. Some of these, I will be honest, have been used more in the academic setting, but one that has become very relevant for policy, both in high-income countries, in low-middle-income countries, upper-middle-income countries, low-income countries, is health technology assessment. So while all these tools and more exist, I'm going to focus for the purpose of this meeting on health technology assessment. So before we go into health technology assessment, I just want to guide some of the issues, because again, when resources are scarce, it means that when I make a decision to fund person A, I'm not funding person B. It means that person A is gaining, person B is losing. But for me to be a fair decision maker, I must make that decision based on factors or criteria that the whole of society can look at and say, okay, because of this and this and this was a fair decision and we can all align with it. But if I decide to make it out of selfish interests, then it's unfair. And these are some of the factors that we commonly see affecting priority setting. And I'm sure many of you, in your own priority setting at your level, you apply this. Is it efficient? Is it cost effective? Is it affordable? Does it affect the most severely affected people? How does it align with human rights? Is it equitable? What does it mean in terms of our solidarity with our brothers? For instance, the scheduled tribes or the scheduled tribes or other vulnerable groups that are being left behind. As an altruistic society, do we think it's fair that we leave them behind? So those are some of the things, the factors that affect priority setting. The data that is needed for priority setting and for HTA is clinical data, including mortality data, economic data such as cost of the technology, budget impact analysis, epidemiologic data, social and organizational data. The elements of a good priority setting is that it should be transparent, clear. There should be good stakeholder involvement, everyone who should be at the table, including patient representatives are at the table, it's evidence-informed, it's ethical and equitable, and it should be feasible. So when it comes to health technology assessment, it is designed to determine the value of health technology, inform policy and decision-making, and serves as a bridge between research and informing policy. It's multidisciplinary, policy-oriented, ideally should have a system lens, and should support UHC. So I'm going to give a few examples of where it has been applied. In Thailand, which in this region has attained a high level of maturity in the adoption and usage of health technology assessment to define the packages for PHC for secondary and tertiary care, where they have used it, it has resulted in high cost savings. So they used it, for example, in determining the cost effectiveness of tenofovir for treatment of HIV, oxaliplatin for colorectal cancer, and more. And when they used that method to determine the price of the drugs that they were going to purchase from the manufacturer, the government was able to realize a lot of savings compared to what they would have gotten on the market. In Australia, they use it to determine the list of drugs that will be reimbursed in the health insurance scheme. And when they have used it, it helped them to switch medicines for biosimilars for infliximab and externap, which saved millions, and similarly they were able to remove one drug that was not cost effective. The same was done in Brazil with significant savings, as you can see. In India, India has established the Department for Health Research. It has 9 regional hubs and 19 resource centers, of which one of them is in Chennai, in Tamil Nadu. And they support evidence-based decisions for medicines and devices. So far, despite having started in 2019, they've completed 98 studies with 68 ongoing. It has been used to inform a lot of priority setting for primary health care and Ayushman Bharat PMJ. So these are some of the instances where it has been used to inform policy. For sickle cell disease, it helped the government to negotiate the price on the kit, the point of care tests for sickle cell disease, and it helped the government to save over 1,700 crore INR. Similarly, for safety engineered syringes, it helped also result in some savings in crores as well. We also used it in Tamil Nadu. There is a new testing for hearing that was implemented not only in Tamil Nadu but in other states, and this kit was subjected to HTA, and it was found to be more cost effective than what was being used before. Similarly, for the National TB program, there's a lot that has been done to inform some of the new tools that have been adopted, and has helped not only put effective screening tests and treatment in India, but also reduced the cost of care. In PMJ, it helped in screening for one of the drugs for breast cancer, trastuzumab, and it resulted in savings of 416 crore. So that is all that I wanted to share about HTA. The WHO has done a lot of resource work in helping countries, one, in developing a compendium of cost-effective services that is available. I'm done. That is available for use. There's also a kit that we have that can guide any country, any state that wants to adopt and institutionalize HTA to do so. So I'm available for any questions. Thank you.
Thank you so much, ma'am, for your insightful contribution in today's discussion. So to summarize, any doubts? Any queries?
Thank you to both the speakers for your good presentation. My question is to Himanshu sir. There was a graphical presentation you showed how budget allocation for primary, secondary and tertiary has been happening in Tamil Nadu for the last 5 years maybe. We had put all the amount together, annual budget amount for the 5 years and it showed. I was looking at that and I was just thinking, there will be a natural allocation which will go very high for tertiary care institutions. And that graph reflected that exactly. Then of course, one learning point was secondary care allocation is pretty bad. And primary, you said it is low compared to tertiary. And then I was just thinking that at the face value, it will always look the allocation for tertiary very high because of the nature of investments which go there and the kind of the huge thing it swallows. So I was just thinking if sir can drill it down a bit and tell us for primary care, what should be a reasonable proportion of allocation either at national level or at state level?
So, National Health Policy has already defined 2/3 of your investment should be at the primary care, and tertiary care is a pyramid. Pyramid is the apex. So, ideally, it's very clear. Most of your actions are needed from CHC below. Your indoor bed starts from CHC. PHC is not an indoor, it is only some emergency day care. CHC, SDH, district hospital, your indoors, that is the secondary care. Your means pan-India, I am saying. The district hospital should be hub for all the specialty care, and the tertiary care should be only the complicated specialties plus, super specialty care at the tertiary care. The trend in our country is just opposite. You go and see medical colleges have so much rush, and primary and secondary care there is no demand. One of the major reason, which the evidence also says many country also had the investment in the human resource. Unless we invest in the human resource, our investment will be only, if we increase the GDP budget, where will be our investment required? Most of the investments are one time, infrastructure one time, ambulances one time, maybe after 5 years, 10 years. It will only be the drugs, diagnostic and human resource. These are the recurring investment, and there the fund should be given. But we are not able to give this fund to this recurring and important, You have seen in COVID how our colleagues suffered badly, and not badly, very poorly suffered because we did not have the HR. Successive Indian public health standards have come. There is not even a single state who has, approved human resource and infrastructure as per the IPHS. So, my short say is this: there can always be a differing view that PHC, we should act in a pyramid base. PHC and the HWC, community-based care, is the base of the pyramid, where all the human resource and community-based approach should go. Secondary care is your indoors, and tertiary care should be only super specialties. So that is all my say. Thank you. Thank you. Very good question, sir.
May I just also briefly respond to your question? I think that is where some tools like HTL so coming, costing coming. I think you cannot plan when you don't know what resources you need. Ideally, a good costing should be done, and I know that DHR has done some work on this, although it has been largely for the district hospitals and above. But ideally, a costing across the health system that enables you to see the costs for primary health care, the costs that then would now be for secondary and tertiary care, would also be good to know that even if I am spending 50% on tertiary care, when I look at the relative cost, the 50% is warranted. You see what I mean? Yeah, so it's important to do a costing, but if you are, if a government is, and I'm not saying that's what India is doing, but if a government is all the time budgeting without that understanding of what the needs are at all the levels, then you will have that kind of skewed distribution. So you can't do away with the quantitative element.
Can I ask?
Thank you, ma'am. Thank you, sir. So, to summarize, I thank Bhushan sir for highlighting our key public health achievements that we have achieved our SDG targets in IMR, under FIMR, mortality rate and NMR, and also our national health policy targets we have achieved. So then regarding the TB prevention treatment, also like we are the pioneer among in our country in initiating this TPT treatment for reducing the spread of TB infection. And sir said mainly going to the rural area at the doorsteps, that's the main thing in reducing the out-of-pocket expenditure. Is it audible? It's audible, sir. And also sir said that primary prevention is the need of the hour, and of course we are doing the cancer screening. So to all the medical officers who are over there, early diagnosis at stage 1 reduces the mortality risk by 6.7%. That should be the take-home message from this panel discussion for you all, so that we should improve our cancer screening. We should motivate the mothers even before the age of.
We have a query from the audience.
Hello, sir. Hello, ma'am. This side.
Yeah.
Am I audible? Hi. So you mentioned on the slides that the ASHA workers, that is the frontline health workers in India, they cover over 1,000 population, but they lack certain training. Sir, we wanted to understand from you what kind of specific training that you kind of sense that is lacking, and how can the private sector or the third sector can complement the government in enabling that? Thank you.
Great, good question. So, in fact, not only the ASA, Anganwadi workers, in Tamil Nadu, VHNs, they all need a good supportive structure and capacity building training. If you will keep, loading the guidelines every 15 days, and you will expect the ASAs and VHNs to be becoming the masters of those guidelines, it is not possible. So, in fact, again I will say Tamil Nadu. When I launched the SBA training, which was a 3 weeks training for the pan-India, Tamil Nadu modified it and made it, 3 parts of this training, 7 days each for their ANMs. And that was very helpful training, because low dose, you absorb it, again come to the training. But in our country, our challenge was, if I roll out the same model in the whole country, today Tamil Nadu was able to, place, suppose Sita is placed, Sita in training A, training B, training C, continuously. But if I go in other states, first training Sita will come, second Gita will come, third Rita will come, so the whole will be mess up. So anyway, so what I am trying to convey the message is that this low dose training with a good mentorship and supportive care is the key for the community level workers, be it ASA, be it Anganwadi workers, be it VHLs or ANMs. And therein, government alone will not be able to do it. They should certainly seek public-private partnership like self-help groups, NGOs, and many other models who are locally available. In Jharkhand there are the models. Even in many other states there are the models who have successfully undertaken these trainings and they were very helpful. So that type of training is needed for Tamil Nadu and for the country.
So just to follow up on that, in terms of digital tools for the health workers, how is the government conducting training, and how do you think entities outside the government can come in and basically make the work of the government easier in skilling them? In any specific areas, if you can highlight or point out, that will be helpful. Thank you.
So see, I mean, as far as trainings by the government, I am not the right person because I am not presently in the government, but government has already launched many digital platforms where the trainings can be conducted both at the primary level and for the various other programs. And many of these digital platforms are being run and supported by the private partners only. So digital platforms are there, private partners are also there, and I think what country now needs is the action at the ground level. Platforms, too many digital platforms are already there, and every day a new digital platform is coming up. So we have to stop these digital platforms and rather act on the ground level for the implementation. Use any platform, but please implement, support, mentor. That is the key word. Thank you.
Yeah, thank you. Just to maybe compliment, in terms of private sector, I think there is a big role that the private sector can and is already playing. So for instance, I know there is a foundation, please forgive me if I don't say the name right, Nandelini Foundation. It's one of the philanthropic partners. They have developed modules for CHW, for CHO training based on the modules that NHSRC developed. And they have made a digital app for that. And they are training a lot of community health workers in Karnataka and elsewhere. They've also come up with some trainings for nurses, for continued medical education that are being used to help nurses on CME. So there's a lot that they are doing there. Secondly, I do know, for instance, there are some private sector actors that have been working in Uttar Pradesh, working with community health workers, developing clinical decision support systems for them to help them in the course of their care to be able to make decisions quickly on some of their key tasks that help them to execute much faster. And these have been supported by private sector in Uttar Pradesh. These are small pilots, but those are some ways that private sector can plug in, aligning with the government's program, the policies the government has put in place, the guidelines to support and complement what public sector is doing.
Thank you.
So, to summarize, already I said screening of cancer service that we medical officers should keep it in mind, and Sir said SDGs can be achieved by investing mainly in the primary health care. So we policymakers and NHM officials are there, so we should take care of that. And for the doctors, burden of lifestyle and nutritional risk is more in Tamil Nadu. Overweight and consumption of alcohol among the adolescents, that's the main concern. And increase in diabetes, hypertension patients are more. So all this we need to take care of that. Then for primary health care, the sector-wise allocation for the primary health care is very less. He said only 18%. That has to be increased at least up to 60%. And because we are getting lowest allocation to the DPH, so that also we program officers need to take care of that while preparing the proposal. Then, so that's all. Then Madam, she said there should be equity, and while planning, prioritizing, we should give priority to the disease burden, and we have to maintain the human rights also without any discrimination. All that, and the key elements, main key element is to be, there should be a transparent, and we are already doing the screening for hepatitis B and C at the PHC. So these are the low cost interventions. So then finally, as lack of time, those who have any other questions, please we'll give the panelists mail ID. You can mail to them and you can get your answers. Finally, I would like to extend my gratitude to our panelists for their time, valuable time, sparing their valuable time and giving their valuable insights. Thank you.
Thank you, dear speakers, for your insightful and thought-provoking words. I request our Director of Public Health and Preventive Medicine, Dr. A. Somasundram sir, to felicitate our speakers. Thank you, sir.
Moving on to the next session, DPH Icon 2025 cordially welcome Dr. Nirmal Jo sir, Senior Regional Director, Regional Office of Health and Family Welfare, to moderate the panel discussion on health system preparedness for disaster and extreme weather events. We welcome you, sir, onto the dais. A few words on speaker. Coordination and liaison, training and capacity building, monitoring and assessing effective public program delivery, and on the whole, a liaison between the central and state government. Welcome you, sir. Now we cordially welcome our panel speakers, Dr. Akash Srivatsava sir, Additional Director, NCDC, and Dr. Syama B. Syama ma'am, Associate Director at Swasti NGO. We cordially welcome our speakers, Mr. Hari Kumar sir, Regional Coordinator, South Asia, Geohazards International. We welcome Dr. B. Senthil Kumar sir, Dean, Allied Health Sciences and Head Information Transformation, Vinayaka Mission Research Foundation. We welcome all the speakers to the dais. Over to Dr. Nirmal Jo sir.
Good morning to everyone, distinguished guests, panelists, and the participants. It's my privilege to welcome you all for this panel discussion on health system preparedness for disasters and extreme weather events. The urgency of our conversation cannot be overstated if you see the global disaster database, which says that we have at around 393 disasters all over the world, with around affected 167 million people, with economic losses of around $250 billion. And India, unfortunately, is one of the 10 disaster-prone countries, one of the 10 most disaster-prone countries in the world. We are simultaneously facing floods, we are facing cyclones, landslides, cloudbursts, so many natural disasters and public health emergencies. Recently also, I think in Chennai, Manali town, we had a cloudburst. I think we all remember it. These disasters disrupt livelihoods and put a tremendous pressure on our health system. In such a context, our health system is the front line of defense, not only during emergencies, but before and during and after it. I invite our panelists to share their insights, grounded in evidence and their vast experience, how India and maybe the global community can build a resilient health system capable of withstanding the shocks of disaster and of the extreme weather events. Let me warmly welcome our first speaker, Dr. Akash Srivatsa. I would like him to give a perspective on the National Program for Climate Change and Human Health in the context of our disaster and extreme weather events. Welcome, sir.
Good morning, everyone. To begin with, at the outset, I would like to give my special thanks to the Director of Public Health of the state of Tamil Nadu, and also to all officials of the Directorate for organizing this wonderful Dphicon and the efforts that they have taken to strengthen their public health systems, and to which this Dphicon I believe contributes immensely. The topic that I'm going to talk about is climate change driven extreme weather events and public health preparedness, the perspective of the National Program on Climate Change and Human Health, which is a new program 5 years ago started under the National Health Mission for the Ministry of Health and Family Welfare. Climate change is a phenomenon to which most of you would by now be familiar, but my attention that I seek for all of you is to go to this round figure on this side. If you look at that circle, you will see how the drivers of climate change in their turn tend to impact a number of series of exposures, and then in turn all of these exposures would lead to a number of health phenomena. In today's talk, my focus will be only on the top three that you see: the extreme heat, the severe weather, and the air pollution. The purpose for drawing attention to these three is the extreme manifestations of these three phenomena in recent time in the world, also including India, is taking a toll of human lives and also to the health of our public. In climate change extreme weather events, the drivers are not only environmental drivers, the more important ones are also anthropogenic and drivers. That means that we as human beings are also responsible to a large extent for why all this is happening. We may not be able to do for what's happening in the environment on its own by the way of nature, but at least we can do our role by ensuring that we minimize the anthropogenic contributions. If you look at this figure out here of the World Health Organization, you would like to understand that the health risk from the climate change is largely because of a cluster of three group of factors, what we call as the vulnerability factors, the climate-related hazards, and the exposure factors. A mix of all this eventually decides the risk for a country, the risk for the state, or the risk for the district. Of these, there is also a huge contribution to adaptive factors which are included within the vulnerability factors, and the only way we can help from our end is to ensure that we increase the substance of adaptive factors so that we are able to counter the impact of other factors and eventually be able to reduce the risk that we have from climate change on our health. But what's important is when you go down to the section of health outcomes, you see, look at the spectrum of the health outcomes that the climate change has, beginning from injury and mortality to heat-related illness, to respiratory illness, to waterborne diseases, to water-related health impact, to zoonosis, to vector-borne diseases, to malnutrition and food-borne diseases, to non-communicable diseases, to mental and psychosocial health. Please understand that there is no spectrum of human health which is spared by the impact of climate change. I've just tried to give some of the examples on the side of the statistics that are true for India. Now to the same figure, if you go a bit more right after health outcomes, another impact is how it impacts the health systems and facilities. It not only impacts the human health, but it also impacts the healthcare deliveries and the health system through which we try to help our people. And if you look at the numbers that I have given around, it also as how the healthcare infrastructure and health systems are impacted by climate change related impacts. So what are we doing about it? Globally, there have been certain declarations by which pathways have been shown to the countries that how they can work towards climate change. India became signatory to the Maldives Declaration in 2017, in which certain national level commitments were listed. Also, in 2023, the World Health Organization, CRO, put in place an operational framework for climate resilient health system, which also provides what national level commitments can be done. If you look at what these commitments are, briefly, it's about having a strong leadership and governance, a climate smart health workforce, working towards climate health risks and greenhouse gas emissions assessment, integrated risk monitoring and early warning systems, climate resilient low carbon infrastructure technology and supplies, climate informed programs, emergency preparedness, climate health research, and climate health financing. Now all of that component is what any country, any state, any district needs to do if it has to work towards becoming climate resilient. India started a struggle in 2015 when the Prime Minister's Council on Climate Change proposed that there should be a separate mission for health, the health mission. And the road journey started in 2015, went up to a program being inducted under the Ministry of Health as a national program on climate change and human health. In 2019 under NHM, we had our first national action plan in 2019, followed by a thematic area-wise action plans. In 2021, we had integrated digital surveillance systems integrating climatic component and health by 22-23. By 2024, all states were able to develop independently their state action plans on climate change and human health, including the state of Tamil Nadu, which were released none other by the Honorable Prime Minister himself in the month of October 2024. And now we are advancing toward development of district level action plans on climate change and human health. I'm glad to know that the state of Tamil Nadu's all districts have been able to make substantial achievement in putting up their district level action plan. So what are the main objectives of the program? They are all same aligned to what I showed you about what we had commitment from the WHO framework and from the Maldives Declaration. We also work on the 5 pillars. The first pillar is awareness advocacy. The second is climate smart health workforce. The third is strengthening health sector preparedness. That are governance and climate informed programs and climate health research. So what was the state action plan, why they were needed, and what are the district action plans? The state action plans are action-oriented guidance developed by the state government themselves, which identifies their priorities and their resource allocation. The health is led by the health-led multi-sectoral task force, wherein sectors of all others relating to health, be it water, be it environment, all of them are brought together to discuss where health is on the charge. The document that was developed was for the year 2022 to 2027, and after it's over, we'll go on to a 2.0 version of State Action Plan, which will have far more thematic areas included. The current thematic areas in the State Action Plan are about the heat health plan, the air pollution health plan, the extreme weather event and health plan, and the sustainable climate resilient healthcare facility plan. But we would also go forward in the next 2.0 to have specific zoonotic diseases, vector-borne diseases, mental health, NCDs, etc. Now, when we come to the district action plan, again, the levels have been reduced up to the district because within the same states you would have different climate scenarios for different districts. So each district should be able to develop its own action plan. The most important part is that these plans are also supposed to be integrated into the mainstream plans. There is a state action plan on climate change that the Ministry of Climate Change developed. So the SAP-CCHH or the DAP-CCHH gets integrated into the main plans that the Ministry of Climate Change developed. The heat health action plans get integrated into heat action plans that the NDMAs and the SDMAs develop. The extreme weather event health plans get integrated into the SDMPs and the DDMPs that are developed by, again, the state disaster management and the revenue authorities of the states and the district. So I'm not going to speak about what we are doing in heat. Most importantly, the activities are what I've listed up here are there, but I just want to bring an attention. Please understand our understanding on heat is very important. It is a new subject. Many of the officers or clinical people in your state would be hesitant in diagnosing a heat-related stroke case or a heat-related affected case or a heat-related death. It is a purely clinical diagnosis. We do not have lab tests or autopsy findings that are needed to confirm a heat-related case or a heat-related death. They may be supportive, but they are not confirmative. It's purely a clinical diagnosis. The clinicians, the medical officers, should be trained and should be able to diagnose with full conviction that it is a heat-related death or a heat-related case. Now, it's not only the heat stroke that is an important phenomena that you need to understand, but a lot of cardiovascular deaths that happen during summers are also precipitated because of the impact that heat has on the patient who already have a weak heart. Right. But many important points in there are work that we are working towards heat is developing a heat stroke management unit. You can see a picture from Ram Manohar Lohia Hospital from Delhi, putting in place such management unit, at least in all secondary units in your districts, is to help give the attention to the heat-related sickness in the first 30 minutes of the heat stroke, which is a critical period to save the lives of these patients by immersion cooling technique. Next is air pollution. Again, a lot of work that we are doing in the program in air pollution, but I need to bring to attention to you all, if there are 60 million deaths that happen attributed, 60 million total deaths in the globe, then every year 7 million of those 60 is attributed to air pollution. That is close to 10 to 15% of the deaths, of the total deaths that happen in this world is attributed to air pollution alone. And air pollution right now ranks at the topmost risk factor attributing to death and to NCDs. Please mind it, it's going far ahead of all other risk factors we have ever known. So it's high time to sensitize the medical community and make them understand, and the clinicians to get together and work on that. Right, so the next one is about extreme weather events and health. I know all of the states for a long time have been working on extreme weather events and disasters, so there is not much to do, but what is important is to have a preparedness system And we, therefore, beyond what we usually do, have put in place a tool for assessment of your healthcare facilities and assessment of your district health system on emergency, on extreme weather events preparedness. Please use these tools and try to ensure that your health facilities and your districts are upgraded as per the requirements of protocols internationally sought under this program. Last is the green and the climate resilient healthcare system. There are two components. One is green, that is being a sustainable healthcare facility, and the second is climate resilient, that is to be able to withstand the impact of extreme weather event. Again, a work related to energy efficiency and water efficiency are being worked under sustainable systems, but we also want you to work towards a climate resilient healthcare facilities to ensure that the impacts of heat, floods, cyclones, etc. can be withstood by these health facilities that have been developed by retrofitting or those that you are developing new. We already have under the Indian Public Health Standards put in so that the new facilities will comply to these these principles. Right, so these are some of the work that's going on in the country related to strengthening the health sector preparedness in green and climate resilience. And what's important is also putting together collaborative efforts. What we see at the national level, we have brought together many ministries and many programs together. We also expect the states to also bring together through the work that they have at the state. Please understand, in the state level, there is a multi-sectoral task force and a governing body that overlooks the program to provide a platform for a multi-sectoral approach to handling extreme weather events, handling climate change, and also at the district level, we have provision for a task force. So whether sort of a multi-sectoral working and networking is necessary towards it. I hope I've been able to meet within the timeline of 10 minutes. Thank you.
Thank you, sir. Next, I call upon Dr. Sama, Associate Director at Swasthya NGO. Madam, you can give us some concept regarding vulnerable populations in disasters and how we can use technology in disasters and extreme weather events, and why does it matter whether recovery and resilience matters in disaster or we are only interested in relief.
Sure. Thank you so much, Dr. Nirmal. I'm sorry. Hello. Is this better? Thank you so much, Dr. Nirmal, for the questions. I don't have a presentation, so I'm largely going to speak about what we did, especially taking a leaf from our response to COVID. So you asked, how do we ensure equity in disaster response and preparedness? We have seen that disasters deepen inequities because response often reach those who are easiest to access, right? Unless resilience building focuses on women, urban poor, migrants, farmers, fisher folks, and factory workers who are hit the hardest and have least access to response measures, I think we risk rebuilding systems that leave the same people behind. Intentional partnerships with community collectives and associations is what ensured that the very people most at risk became active partners with us in resilience building. In our response to disasters, we tried to work with community groups and associations who reflected the voices of communities most appropriately so we could customize what we were doing for them. By institutionalizing community engagement as part of disaster preparedness plans, communities became co-designers. They were not just passive participants, which promoted ownership and accountability, and they built it with us, right? And I think going forward, equity must be a design principle. It should not be an afterthought. Probably we make equity, like a financing and accountability criteria. It cannot and should not be just a value statement. I would actually take this opportunity to sort of make a call for action that funders and government should warrant evidence that demonstrates interventions closed, not widened gaps. I'll move on to the next one. So that is about how we used vulnerable populations to, or how they were part of the resilience building with us, right? Now I'd like to discuss about what is the role of technology and innovations in building resilience. System innovations in public health to continue providing services to those who need it the most is what ensured that we came out on the winning side in our battle with COVID, right? And I want to highlight that the most important innovation during that time was collaboration. To address a problem of that scale and magnitude, it was humanly impossible for any of us to do what we were doing by ourselves, right? So we came together through the Community Action Collab, erstwhile COVID Action Collaborative, with about 373 plus partners. We saw how collaboration enabled equity to move communities from relief to recovery to resilience. It helped us pool resources, act faster, reach wider, and build health systems that are shock-proof and future-ready. The collab successfully demonstrated its capabilities by delivering 25 million services to 15 million individuals across India as part of the COVID response. I want to say that this was made possible with the help of technology. I'm not saying that technology is the silver bullet, but technology is definitely the most important enabler, and it definitely is a multiplier that amplifies the effect of everything that we do. A couple of examples that I want to take is that we managed to deliver comprehensive primary healthcare services through digital innovations like telecare models, which made sure that care was never disrupted for those who needed it the most, right? By integrating multiple solutions like healthcare, access to social protection, emotional well-being, etc. on a single platform, we could ensure resilience building was comprehensive, not episodical or fragmented. Another significant potential of technology that we have always known but realized much more during disaster was that how it effectively addresses the challenge of data silos. By leveraging data from multiple sources, we created interoperable systems at the intersection of multiple departments that enabled coordinated action on the ground. But I also want to point out that technology only works when it is designed for equity, right? Simple, accessible, and linked to frontline action that creates impact, lasting impact on the last mile populations. Otherwise, it simply risks widening gaps further instead of bridging them. I want to take this example of how we worked, private sector actors, government, and everybody came together during COVID. We used wastewater testing to estimate and predict the outbreak of COVID through platforms like Precision Health, where we leverage GIS and predictive modeling techniques that help stakeholders have a lead time for planning and focused disease management strategies. One thing I want to highlight here is that we managed to include both formal and informal drainage networks in its sampling focus, which helped to represent underserved and marginalized populations and also provided a holistic picture of disease scale at wider level. Since then, the approach has been expanded to multiple other streams like maternal health, anemia, communicable diseases outbreaks, heat resilience, and so on and so forth. So, what is the role of recovery and why does it matter when it seems like relief is the most important currency, right? So, I just want to start by saying that resilience is not something you deliver, it's something you create. It's an experience, right? It is not an isolated event, it's a journey, a continuum from rapid relief to recovery and finally to systems that can withstand future shocks. While relief saves lives, recovery restores dignity. It is important to rebuild essential services, livelihoods, and psychosocial support so that communities are not just surviving, but they are regaining stability and they are becoming resilient. And I think that is what resilience means, right? It means ensuring continuity of essential services and it brings communities out of crisis to continuity and ensures well-being. Having said all of that, it's very important that resilience is also localized. Preparedness has to begin at the community level to ensure resilience building empowers the most vulnerable, where we equip communities with the right set of tools, knowledge, and networks to participate, anticipate, and respond to crisis. I want to close by saying that Resilience system should be measured not only in infrastructure, but in terms of how communities experience it. Using people-centric metrics like healthy days gained or unhealthy days reduced will help us determine the true measure of resilience. Thank you.
Thank you, madam. Next, we will have Mr. Hari Kumar, Regional Coordinator. And to him, I just have a few questions. What is the meaning of resilience in health, in the health facilities or hospitals? And what is the role of government or public health authorities in coordination and governance?
Thank you so much, Doctor. Good afternoon, everyone. I was hoping to say good morning, but now it is already afternoon. And this is really a great opportunity which has been provided by the sir sitting in front and all of you. Wonderful opportunity. And I was very, very happy to see the theme of this year's event is resilient public health system. Resilience is not something which we hear often when we talk about health facilities, and I'm glad that Tamil Nadu is doing this. I was so happy to hear that this event happens every year and that this year's theme is on resilience. And thank you for the question, sir. I'll talk a little bit about Thank you. So, in my segment, I'll be talking more about keeping health facilities functional rather than safe. Resilience is not just safe hospitals. Resilience should go beyond safe hospitals. Because many a time we think of, safe hospitals and there is a delay. Yeah, that's okay. Safe hospitals may ensure, safe buildings may ensure safe hospitals, and safe hospitals may ensure that whoever is in that hospital building during an event, a disastrous event like a cyclone or a flood or an earthquake, may be safe. May be safe. I'm saying maybe. But will that help the people who have been affected by the flood or the cyclone? That may not be enough. This is an example of a safe hospital in an extreme weather event. Do you think this is useful for the community? Can we take in the patients who are affected by this event? This is not enough. Is this enough? This is from the Japan tsunami, and it looks like this hospital is the last building standing. That is how we expect health facilities to be. Looks like it is the last building standing, but when you go closer, you see a different picture altogether. That is, they had considered, you can see the figure 2.8 meter. They thought that the tsunami which will affect them will be 2.8 meter tsunami. The one that actually came, somebody had messed up with the figures, and the tsunami which actually hit them was 13 meters. So all their effort they had put up, because they thought it was be 2.8, they had put their generator on the first floor. All critical utilities were on the first floor. But everything was dashed away because the tsunami which hit them was 13 meters. So you need to understand the risk. I'm told that there are several PWD engineers here, and when you look at sites, you should be able to understand what kind of risks are we going to face in the lifetime of the hospital which I am creating. This is one such case from Sikkim. You see the primary health center of Chungtang was hit by a rock coming down from the hill during the Sikkim earthquake. I am not interested in the rock which hit the PHC. I am more interested in the rock which is outside, the old rock. So the engineer who went to the site to set up the PHC there would have seen this rock. And he should have thought, where did this come from? It came from up there, up the hill. And the brothers and sisters of this rock are up there still, waiting for the next monsoon or the next earthquake for it to come down. So this is not a good site for my PHC. That is something that seems to be common sense, but unfortunately, many a time we don't use our common sense. This is a hospital in Chennai, affected in the 2015 floods. Hardly less than 100 meters from the river. The engineer or the architect or whoever it is decided that the basement is a good place for our electrical panels, for our generators. Was that decision good? Because that is the first place which will flood. We are not understanding our risks, and that costs lives. People died because of that decision. 18 people died here, including little babies. And we don't want, as administrators, as engineers, we don't want blood on our hands. We should really be understanding what all can happen where we are having our facilities. This is from Chile, a hospital built earthquake resistant. You see the building, not even a crack on it. The engineer has done its job, but the false ceiling was not earthquake resistant. The fire sprinkler system was not earthquake resistant. Can we treat patients here? No. You had to evacuate the hospital. Imagine in a wind event or an earthquake, one tile from your false ceiling comes down in your OT. There goes your sterile surroundings. So we need to think beyond the safety of the building. We need to think about continued functionality. How do we ensure continued functionality? What are the factors that cater to the continued functionality? And climate change is reality. You look at, you open the TV any day, you see Uttarakhand, you see Punjab, you see Kashmir, you see Himachal, and tomorrow you may see Tamil Nadu. We have already seen Tamil Nadu many times, but we need to really be looking forward to what all can affect us. Climate change will bring floods, landslides, vector-borne, the spread of vector-borne diseases, heat waves. Sir already spoke about the heat waves and what NCDC is doing. But when we talk about health sector preparedness, we sometimes tend to focus on the building, but not keeping it functional. And there are several factors which have to work together for a hospital to remain resilient, to remain functional. Only one is the building. The other is the preparedness of the staff members. Just imagine, normally you have 300 patients coming in, and in the event of a cyclone, that may go up to 1,000. Is your staff members ready to deal with this mass casualty event? It's part of their preparedness. And if they have to be ready, their equipments have to be functional as well. And if the equipment has to be functional, you need the utility supplies, utility supply systems. Utility systems are electricity, water supply, your medical gases. They all have to be functional. If you need to run your autoclave, you need electricity, you need water supply. And if they are not functional, you may have a good system, you may have staff prepared, but you are not going to help anyone. Your communications have to work. Your medical supplies have to be enough during an emergency to cater to the mass casualties coming in. And your access. We saw a hospital which has become an island in the flood. We have to have access. And this is the component of a health facility. And if all our health facilities can remain functional, that will make a resilient health infrastructure system. That is what we are looking at. Mobile clinics and all may help in the short term, but really what we need to look at is long term, the system preparedness, system resilience. That is what we should look at. And infrastructure, building the infrastructure well is important, but we also need to look at what kind of logistics are required. We have to go beyond the hospital. One thing COVID did for everyone, almost every hospital now has its own capacity to make oxygen. Oxygen plants were given. But what is happening is some smaller hospitals, they don't need to run the oxygen plants now because they don't need that much of oxygen. So they have shut that down and they are still buying oxygen from local suppliers. I've seen, I don't know about Tamil Nadu, but I've seen the rest of the country, that is what is happening. And when an emergency strikes, it is the resilience of that supplier that matters. The road access from that supplier to your health facility, that also matters. The logistics matters. And it is not just a one sector issue. And we understand that now many sectors have to work together. It is a team effort. It is not just the health department. We need the PWD to working along with the water supply department to be working along with us, the power department to be working along with us. It is going to be a team effort, and the state disaster management authority as well. And putting together all of this, it takes time. It is not something we can achieve in the short term. Resilience is not achieved in the short term. It takes time. And the pathways to resilience will be long-term planning. You need to make a long-term plan on how we can get all our health facilities resilient and to remain functional. And it will take a sustained effort. It will also require long-term vision, long-term effort, sustained investments, capacity building, continued capacity building, and policy commitment. This is required I'm taking the example of Tamil Nadu. If Tamil Nadu has to have a resilient health system, then there has to be these. We cannot be achieved in a few months or years. Have we done this before? Has any program had these kind of long-term planning, long-term vision, long-term effort? Whenever we talk in the disaster risk mitigation field, when we talk about a successful program, I have to come to the health sector. The only example, the best example of a long-term risk reduction happened in the country is the Pulse Polio campaign. We had to do it many times. Was it a short-term effort? No. It needed long-term planning. It needed vision. It needed continuous capacity building and a long-term commitment. And that is what we need to do when we are talking about resilience of our health facilities. It's not built in a day, but every step we take, but it has to be taken in a planned way, builds the safety and health of generations to come. Let us invest now so that our health facilities are prepared for tomorrow's disastrous events. And for our engineers, I say, we should not build our tomorrow's infrastructure based on yesterday's information. We should be looking forward to what all can happen in my city, in my town, what all can affect my hospital or PHC in the future. And it's everyone's job. It is not, I'm talking about engineers, but it is not just the engineer's job. It's everybody's job. Disaster risk reduction is everyone's job. When I see this picture, I often remember talking to the health sector. It's like this man, he has to draw the line on the side of the road. There was a branch on the way. Moving that branch is not my job. He painted around it. You cannot paint around disasters. You have to get down and move it. You have to. It is our job. So all of us, let us commit together. This is a great occasion that we can commit together for resilience building. Thank you so much. Thank you, sir.
Thank you, sir. A picture says 1,000 words. Huh? So, thank you for that picture. Right. Next, I will call upon Dr. Sendil Kumar, and we will be kindly give us some insights regarding how medical education institutions' role is in disaster risk reduction and how we can take forward human resources and training also.
Good afternoon, respected Director of Public Health. Thank you so much for the opportunity, sir. And also respected panelists and respected dignitaries on the dais and off the dais. Once again, good afternoon. And thank you so much for the questions, sir. Like, being educational institution. So I would like to give just 5 minutes talk. Anybody talk about the educational institution, what is the importance of education institution related to disaster risk mitigation or disaster risk reduction. And I would like to say, like, Tamil Nadu government is doing extraordinary job. And how many of you know about this Tamil Nadu State Institute Rural Panchayat, that is TNSIR, adopting a villages, signing a MOU with the educational institutions, and doing the wonderful job to finding the local sustainable development goals, LS, that is a sustainable development goals, like identifying the villages, identifying the group, and working on the local villages improvement. For an example, being a Vinayak Mission Research Foundation, like we developed a model village across nearby our institution, like Ariyanur and Veerapandi. What we are doing is, like, we signed the MOU with the Tamil Nadu State Institute Rural Panchayat. Anganwadi workers and health workers, health inspectors and the PAs in every, so everybody concentrate towards, like, the health beneficiaries. And once a disaster comes, like, we need to know, we need to identify the risk in the community, within the community, not outside the community. Most of the people, like, ASHA or Anganwadi workers, they'll go and see, like, what is the vulnerable population, vulnerable group. But in terms of the community, in terms of risk involved in the community, the best person to know is the local people. So we need to involve the local people. So what we are doing is, like, we need to identify the community person, we need to identify the volunteer, and what we have developed is Youth Disaster Preparedness Committee, that we have developed on a club called Youth Disaster Preparedness Club, where it involves the youth club person, that's an area Kendra Sangathan person, and also the Anganwadi workers, and also the ASHA and our public health professionals. And combined together, we conduct a lot of mock drills for the public. What are the vulnerable population, vulnerabilities there in the community? We are developing it. We are doing the plans also based on that. And also, we need to create awareness. So awareness, like, we do the regular training to the volunteers, health workers, and also panchayat members in rescue, first aid, and safe water practices, and wash, as rightly said by the previous speakers. Wash also should be taken care. And in terms of crisis, the main focus is information, because information spreads faster than the disaster itself. So what people hear and how they hear it makes all difference. So our humble suggestion is, we need to ensure the message reach people in their own language through channels they trust, be it in posters, mobile alerts, and local media and village meeting. At the same time, our health facilities need to be ready with backup medicine, water, and power. Preparedness at the facility, clarity in communication, build in trust, and trust save lives. So preparedness becomes practical when broken down into small and clear responsibilities. Each village can form simple task forces, one for early warning, one for communication, one for rescue, one for first aid, one for water and sanitation. These teams ensure no household is left behind. Sustaining this requires more than just plans. It needs regular reviews, involvement of schools and women group, and weaving of preparedness into the everyday culture of the village. And I would like to mention about the lesson from the Odisha model. And Odisha has shown what true community readiness look like. In Kanjam district, tsunami ready villages had volunteers on every street who knew which families needed help and how to move them safely. Through strong mock drills, youth groups like Apta Mitra, they developed the Apta Mitra, like we are developed here as a disaster preparedness committee, and consolidated efforts across health and disaster agencies. Odisha has saved countless lives. Their story remains not only for everyone, it's all the states should have a disaster preparedness, and also educational institution to stress about disaster management. So what we did, we have asked all our students to get into this National Disaster Institute of Management, that's NDIM. We have asked the students to go take up modules and complete the modules, and most of our students, the paramedical students, are having a certificate from National Institute of Disaster Management. And also we are talking, giving a awareness session about this Sendai framework for disaster risk reduction. Sendai framework for disaster risk reduction 2015 to 2030 talks about the Sendai framework talks about priorities, 4 priorities. The priority 1 is understanding the disaster risk. This involves assessing and sharing information on vulnerabilities, exposure and hazard characteristics. Priority 2 is strengthening disaster risk governance. Good governance at national and local levels is crucial for effective disaster risk management. The priority 3 talks about investing in disaster risk reduction. Public and private investment in both structural and non-structural measures is essential for resilience. And priority 4, enhancing disaster preparedness. This includes improving early warning systems, planning for effective response, and rebuilding more resiliently in the aftermath of disaster. And also we focus on the targets. The targets talks about substantially reduce disaster mortality rate, substantially reduce number of affected people, and reduce the disaster economic crisis, substantially reduces disaster damage, substantially increase the number of volunteers, substantially enhance the international cooperation, and also substantially increase the availability and access to multi-hazard early warning systems. So, and when you talk about human resource and training, human resource are the backbone of preparedness. No disaster plan can succeed without a well-trained, motivated and resilient workforce. Healthcare workers from doctors and nurses to paramedics, technicians and community volunteers must be trained not only in routine manner and also in emergency response skills. So, we have a team called Psychological Preparedness and Mental Health, and where we work on closely work on this community volunteers, and we are periodically doing the awareness session onto these volunteers. And to conclude, health system preparedness for disaster on extreme weather events is not an option but is a necessity. It is about safeguarding lives, protecting equity and building resilience. Disaster risk reduction strategies provide the structural shield, while human resources and training breathe life to our preparedness. At VMRF, we have embraced this responsibility through our emergency care programs, mock drills, public health outreach, and population safety initiative and psychological first aid training. We have instilled preparedness not just as knowledge but also practice. Let us remember, disaster may be inevitable, but their health consequences must not be catastrophic. If preparedness is integrated into every layer of our health system, policy, practice, and people, we can ensure that communities are not only able to survive disasters, but to recover, stronger and more resilient than before. Thank you.
So, is there any questions from the audience to the panelists?
So my question is to Dr. Hari Kumar. The question is, you explained very well with nice pictures about how the system, the infrastructure should be also resilient to meet. You explained, OT, if the false ceiling collapses, then even that is an important point. It's not the mere structure, even in interiors, how it could matter in a disaster. Now, one area I find a big gap in this infrastructure thing is, in spite of many disasters happening time and again, we still find we have certain mundane or a routine system happening in the country, because state governments operate through PWD and PWDs will put up the structure. Most of the situations, that will be the truth. Has anything gone into this important gap or a gray area in the health infrastructure, which we are still missing out very badly, and which we should do? And what is that most important thing which is not called for till now? That's my question to you.
Thank you so much, sir. It's a very, very important question. The state PWDs, it varies across the country. The way our building codes are written, the building codes which guide all our constructions is only meant for life safety only. I am talking about functionality which is several steps ahead. So you follow the code, your building will be safe, it will not be affected by natural hazards like cyclones or flood you cannot save, because the PWD has to decide on what levels to keep. But health facilities, especially very critical buildings inside health facilities. Not all health, in a hospital there may be 10 buildings, not all are critical. The critical buildings are the ones which give the critical services. So the National Disaster Management Authority has brought out the hospital safety guidelines, and they have recommended that we need to go beyond the code for health facilities, for critical health facilities. And they have also recommended, this is still remaining a recommendation, they have recommended that health facilities need a different code, because the way you build a school and the way you build a hospital should not be the same. In an emergency, I don't want the school to be functional tomorrow, but I want my hospital 5 minutes from that emergency. So these should not be built the same. So there should be different codes for it. But for minimum, every state PWD, I believe, is following the building code, and our building codes are good. They have been proved correct all over again in several disasters. But the basic tenet is that they, what they guarantee is life safety, not functionality. I hope I answered that question somewhat. Thank you, sir. One second, one more.
So from the perspective of the program, I tried to highlight something on my slides. Now health facilities, the program suggests would be some that have already been built, and there would be health facilities that would be built in times to come. For the health facilities which are going to be built in times to come, the Indian Public Health Standards have now been revised. So the Indian Public Health Standard will now comply to the principles of sustainability and also to resilience. So it will be important for any new health facility that comes up to follow those principles whenever they are built. It will provide for ensuring that all the necessary codes that exist at that period of time in the national and the state government will be complied to ensure the safety. But the building that already exists We've also in the program provided checklists and opportunities for the state and the district government to go for assessment of their existing health facilities. Based on the score that you get, you are able to identify and understand using those checklists and tools how safe your health facility is in terms of sustainability and also in terms of resilience. And then based on that, you can seek funds under the program and elsewhere to ensure that you do the needful retrofitting, if possible, to change and make it a better structure.
Yes, sir. Yes, sir.
Sir, thank you, sir. Thank you for all the speakers, because from different perspectives we are able to perceive what is resilience, particularly from the institutional perspective, from the building perspective, etc. I am just saying in a lighter vein that the only creation with resilience, forget about the lifespan, is human being. Because Harikumar sir was telling we were very tired of answering the delegates and the people who were questioning the theme, why you have put resilience. Now you have given a different perspective, it is continued functionality. Now we can confidently tell what is resilience. So thanks for highlighting the thing. From all we are talking about the resilient mechanisms, which is a current need. And also now we are not supposed to plan for today, and we are supposed to plan for the future generation. That is what we imbibe from the speakers. Thank you, sir. On behalf of all the participants, I am complimenting you, sir. Thank you. Thank you very much.
Good afternoon, sir. Sir, my question is towards Harikumar, sir. Sir, can you please tell some of the challenges that you faced during this type of disaster management from your personal experience?
The challenges challenges are everywhere, sir. The challenges is what I have been showing also. In a post-disaster scenario, I'm talking about post-disaster scenario, I think the first challenge is how quickly can someone do the assessments and certify that the hospital is safe for someone to go back in and work. Because we need to give the confidence to the doctors and the nurses that it is safe to go back in. And we really have not built that cadre of engineers who have been trained in doing rapid assessments in post-earthquake or post-disaster scenarios. And there are so many examples where the building was good. There were only a few cracks on the walls which actually was not dangerous at all. But when a doctor looks at it, when a patient looks at it, it looks very, very alarming. So somebody has to give them that confidence and say, this is safe, it's only a plaster crack. So first challenge I often feel is that many hospitals operate outside even though the building is good enough. That is one thing. And also the other challenge which I have mentioned is long-term planning. People cannot, I'm talking generally, no one thinks beyond 5 years. Because 5 years is my tenure. I think maximum is 5 years. And resilience doesn't come in 5 years. Sir talked about Odisha, and I am thinking Odisha in 1999 when the cyclone happened, the 10,000 people died. 10,000 is the number we are guessing because we don't know how many people died. And after 13 years of intense effort by Odisha State Disaster Management Authority, and the cyclone fell in hits 2013, the number of deaths is 22. From 10,000 to 22 does not happen by chance. 4 lakh people do not get evacuated without proper planning. You go to the communities and you ask about their disaster management plan. Even a child will tell, direct me, oh, that is my cyclone shelter, and if I go there, I will be on the first floor and I will get poha for in the morning. They know the menu also. That is the level of preparedness. But it took time. I mean, 13 years is too short, but we don't think beyond in long term. That is, I think, one challenge we have all been facing. I'm sure all of us will have some challenges to talk about. Would you like to add something, sir?
When you talk about disaster, you can speak about this COVID-19 itself. So managing the COVID-19, nobody knows what is the COVID and how to manage the things. We need to trust the process. One. Number two is you need to believe during this COVID-19 in our hospital actually you won't believe the youth, that is paramedical staffs and students, they are the frontiers of COVID-19 rather than doctors, because they are the first responders and they only responded very well and managed well, because nobody knows what is that virus and how it reacts and everything. But we need to trust the process, and we were able to manage, and I think Tamil Nadu managed very well.
I have two words to add to it. In the way our country is built up, the disasters and the planning and the response, both of them are led by the disaster management authorities. The disaster management authorities are usually the revenue authorities. Now the point is, when a disaster strikes, it has got two major impacts. An impact on the revenue, the economy. It also has an impact on the health. There are two major impacts, and the lead is always of the revenue department. What I'm trying to emphasize is, I know that in India for a very long time, all state health departments, specifically health departments like that of Tamil Nadu and other states, have played a wonderful role in working against disaster. But in the way that the thing is designed, the health is always kept at a second step, beyond revenue. It's high time that we have to appropriately ensure that the human losses are less. In that case, the health has to come in the front, not only as a player in the whole game, but as one that actually leads the preparedness role. So health is a very important component of how disaster happens, and when I go across the various states to see how the preparedness plans have been developed by the revenue department, somehow or the other, the contribution or the role that they have assigned to health is only of the supportive role, which is very unfortunate. Whereas health should be on the forefront, leading the leadership, because health is one of the most important damage that happens after any disaster that happens. So that change of focus is probably going to be a very important requirement, which all states which have strong leadership to try to afford to make a change. Thank you.
Because of lack of time, and as requested by the organizers, I think we will close this panel discussion with just one comment from Dr. Sendil.
Actually, that previously sir has asked about the building code, actually to Harikumar sir. I would like to mention about IIM Ahmedabad. When the Gujarat, this earthquake has come, so the IIM Ahmedabad build a sustainable building where they build a larger structure. Even if the earthquake comes, it won't collapse. It won't give a massive destruction. That building, sustainable buildings, they developed after the earthquake. Probably if you are able to see, you can visit the IIM Ahmedabad website. You can find it, the sustainable buildings.
Okay, sir. Thank you. Thank you.
Thank you, sir.
Sir, one last thing. Because Akash sir brought up that point about health, I think this is something probably all of us recognizes, but since we have a multitude of stakeholders, I just want to table this for everybody's thinking. I think one major challenge that we have experienced and we have seen that others have always brought forth is multi-sectoral coordination or the lack of that, right? Because health is important for sure, but then with a disaster, livelihoods get disrupted. With that comes economic insecurity. So Like, see, the person on the ground who is actually facing the brunt of it, how do they go to the hospital? How do they make sure that they have the right kind of resources to get to the hospital? They have to run pillar to post to make sure that they are even able to step out of their homes, right? Like, so their priorities are different. We can sit here and think that this is what is important to me, that is what is important to me. But then, which is why I was saying that unless we make all sort of responses people-centric, I think we are going to always face one or other challenge.
Thank you. Thank you, our esteemed panelists and participants, for the engaging and insightful discussion. I just want to say a few points which I think everybody, the main priorities which they have said. One is regarding Dr. Akash Srivatsa's 10% of deaths are mainly due to air pollution, and the preparedness checklist which has already been prepared by the national program which can be utilized. Dr. Sharma was, she has given an insight regarding the vulnerable population and how we can involve the community for it, community level resilience and the continuum of care. Dr. Hari has said one is regarding the site of the health facilities. Usually I have seen the sites of health facilities is the end of the village, near the lakes, near the cremation grounds. These are usually the sites. So that is the one important thing. And then continued functionalities of those health facilities. I think that is very important. Not only the site, but the continued functionalities. Dr. Sendil Kumar had given us regarding the youth disasters preparedness clubs which can be formed in the communities. So that is one important, and then Apna Mitra also has been informed. So thank you all of you for the key takeaways, and we must shift from reactive responses to proactive preparedness. 3 or 4 years ago, we had a good discussion, panel discussion about rabies, which was thought about that time, and after that the whole country is talking about rabies only. And after this panel discussion, I think for another 3 or 4 years, I wish that this topic will be talked about throughout the country. And on behalf of the organizers, I thank our panelists for the valuable insights and all of you for your active participation. Thank you all.
Thank you. Thank you all speakers for sharing your valuable insights. Now we cordially invite our additional DPH and key organizing secretary, DPH Icon 2025, Dr. P. Sambat sir, to honor our speaker, Dr. Akash Srivatsava sir, Additional Director, NCDC. To moderator, Dr. Nirmal Jo, sir, Senior Regional Director, Regional Office, Health and Family Welfare. Mr. Hari Kumar, sir, Regional Coordinator, South Asia, Geohazards International. Dr. B. Sendil Kumar, sir, Dean, Allied Health Sciences and Head Transformation, Vinayaga Mission Research Foundation. Dr. Syama B. Syam, Associate Director at Swasti NGO. Thank you, sir.
I hope your sugars have not gone down in an effort to grab your attention, we are having a special audio visual on our DPH, sir. Please maintain silence. I expect the audience in the extreme end of the hall to be seated in their respective seats.
In the year 1922, we have celebrated the centenary year celebration. And during the centenary year celebration, we conducted the 100th year of Public Health Conference named as DPH Icon 2022. The conference was organized to share the experiences of experts, public health experts across the countries, and highlighting the Tamil Nadu's public health achievements, and also highlighting the activities of different healthcare workers, right from the Directorate of Public Health officials to the frontline workers like village health nurses, health inspectors, etc. So, in continuation of this conference, and motivated by the response during the DPH Icon 2022, that is the 100th year, and based on the government order, we are continuously conducting annual International Public Health Conference, and we have conducted in Tanjavur and Madurai in the year 23 and 24. This year we are conducting the conference in Salem, this DPH Icon 2025 at Periyar University, Salem. The conference draws participants from various sectors like public health staffs, officials, postgraduates of community medicine, postgraduates of public health related departments, undergraduates and faculties from different medical colleges. We have support from different speakers, national and international level, with rich public health experience, and the public health topics covered in this conference are public health, community medicine, public health obstetrics, community pediatrics, psychiatry, non-communicable diseases, One Health, and health financing, etc. So people from various quarters are coming as experts, and they will share the experiences. And the conference has different components like plenary sessions, paper presentations, poster presentations.
Grow old along with me. The best is yet to be, the last of life for which the first was made. Our primitive healthcare system has embraced the challenges and has transformed to this present-day digital mission. I invite our Additional Director, NHM, Dr. Gerard Maria Selvam, sir, onto the dais. Here comes our speakers from the Tamil Nadu Health Systems Project, Dr. Jodhiban, Medical Officer, and Dr. Sangameshwaran, Medical Officer, to brief us on Ayushman Bharat Digital Mission. Welcome, sirs.
So good afternoon, one and all. We wholeheartedly thank the Directorate of Public Health and Preventive Medicine for giving us this opportunity to address such an esteemed gathering. So this is going to be a topic on digital health, a slight deviation from all the public health topics that you have been exposed to recently. So Ayushman Bharat Digital Mission. Next slide, please. So how do we all carry our health records? Most of the people, we usually carry our health records in a file system. We have it physically with us. We have huge files that we carry around everywhere. So what is the problem with these file systems? They can get easily damaged, they can be destroyed, we misplace them, and most of the time people tend to forget it when they come to the doctor's visit. So ABDM tries to address this specific issue. It tries to create a digital health information platform, and make us go towards a paperless ecosystem. Next slide. So are we not digitalized when it comes to health? Of course we are. We have our very own portals when it comes to health information. We make RCH entries, we make THI registry. Every hospital has its own MIS systems. But what is the problem with it? There is no interoperability. There is no exchange of data that is happening between these platforms. So what ABDM actually does is, it creates an ecosystem that is interoperable. It enables data exchange between various digital platforms that already exists. So when we use the word data, what obviously comes to people's mind is that our data is being captured. It might be misused. Somebody is trying to steal all our data. That sort of concerns obviously comes to everyone's mind. What ABDM does not do is, it does not have any sort of central repository. Every data that is being created resides with the creator itself. Next slide. So the visions of ABDM are, it is inclusive, it is accessible and affordable, it is safe and secure, and it is timely. Next slide. So why ABDM? For a citizen, ABDM helps to access all his medical records at his fingertip, and he can even consult a doctor remotely through an ABDM platform. And for a health professional or a health facility, it enables the facility to access health records with the consent of the patient. And for policymakers, that is where we come in, ABDM gives us a source of trustworthy data upon which we can make our policies. Next slide. So this is the whole ABDM ecosystem. On one hand, we have health information providers, and on the other hand, we have health information users. Basically, both are the same. All our citizens and private digital health services and government digital health services, through a connecting platform, we facilitate exchange of data. And that is where the 4 registries come in: ABA, HPR, HFR and drug registry. So these are the 4 registries that we create in ABDM ecosystem. ABA is for the citizen. It is a 14-digit unique number for every citizen. And HPR, Health Professional Registry, is for the health professional providers. Basically, they are doctors, nurses, paramedical staffs, etc. And Health Facility Registry is for the facility. They range from big, huge medical colleges to even a small clinic, even pharmacies and laboratories. And the final one is Drug Registry. It is for all the drugs that enables e-prescription. So this is ABA. ABA is a 14-digit unique identification. So why ABA? ABA tries to simplify things. It is a unique number to each citizen. So instead of having a different identification number in every hospital, the citizen can have one registration number through which he can access all digital health facilities, and that is ABA. So when a citizen registers ABA, and he uses a PHR app, and through the PHR app, he can create his health records and keep the health records in his health locker. And based on his consent, he can share the records to the facilities. And that is how a citizen can become a digital citizen. So this is, the second one is Health Professional Registry. As I have already told, this is for healthcare providers, doctors. All modalities of doctors can get registered under HPR, and healthcare professionals and allied healthcare professionals also. So what are the other key benefits of HPR? Basically, it is a trust and verifiable entity. Doctors have already their own registration number, but this also provides a trustworthy national level identification. So basically, with the HPR, a doctor can create health records at his facility, and using a ABDM compliant HMIS, and he can prescribe digitally, and that is how a doctor can create a digital health record at his facility. So next comes Health Facility Registry. Similarly, as HPR, this is for the facility itself, and this is also a national verification building trust. So the same workflow is for the Health Facility Registries also. So these are all the various personal health records app. The ABA and Argyo are the government apps, and we have many private partners too, such as Briefcase, Paytm, Bajaj Health. Using the personal health record app, one can create an ABA address, he can link his health records, he can view his health records, he can book his appointments through scan and share for OPD registration, he can manage his health records that are shareable, and he can even update his profile. So next is end-to-end ABDM adoption, that will be spoken by Dr. Jyotiban. Thank you.
Good afternoon all. Respected DPH sir and participants of the workshop. I thank you all for giving me this opportunity. So why ABDM? So why is ABDM? So why do we need to digitalize the health records? So in most of the cases, how long do we preserve our health records? If you ask this question, you all know the answer. When the treatment gets over, the records are over. It's finished. So what is the disadvantage? So okay, let it be. The treatment is over. The records let it go to waste. What is the problem? So you all may think. So there are we as a doctors we all know there are a lot of cases where the previous records are very important, especially in surgical cases, oncology cases, we all know. So these records are very valuable, and the next doctor who is going to treat the patient, he can take most of these decisions based on what treatment was given previously. So these records are very invaluable. So these records need to be preserved. So Government of India has taken this initiative to preserve all these records. Not only preserve those records, the public should access their own records. The public should know what treatment is given and what all treatment he is going to get. So this is how the program is designed. It's basically a citizen-centric program. So my colleague has explained very well about all these pillars of the program, all the registries which are getting created. So ultimately, what is the purpose? The patient, he has to enter into the hospital, all his records, all the prescriptions, all the lab reports, whatever is generated in the hospital, it has to be digital. So when he comes out of the hospital, the patient should be able to see all his records, whatever is created. The happiness, I'm seriously telling that the happiness which the patient gets on seeing his records, all these prescriptions, lab reports, everything, it's invaluable. So ultimate aim is when the patient goes out of the hospital, he should be able to see all his records in his own phone itself without any difficulty. So we will quickly go through few slides. So the Government of India actually has created few model facilities, actually around 134 model facilities, out of which 29 are AIIMS and central government facilities and 90 are state government facilities. And 15 private facilities are also included. As we all know, the private participation in this program is also very important because there is a data which says that around more than 50% of health data flows through the private ecosystem. So the private data is very, very important. So without capturing the private ecosystem, the system is of not much value because most of, as I said, 50% of the data flows through the private ecosystem. If we miss out these data, it will be proved to be costly. So we are also trying to capture data from the private facilities also. We have all these 15 private facilities which are model facilities which is implementing the program. they are doing end-to-end ABDM adoption. So we will quickly go through what is end-to-end ABDM adoption. As I said earlier, when the patient walks into the hospital, his registration should be done in a digital way. The OP slip should be created in a digital way. Next is creation of health record. All his health record should be created in a digital way. Next, digital payments. If suppose any payment has to be made, instead of waiting in the queue, the patient should be able to scan a QR code and make the payment. Then access to the electronic health record. So that is our ultimate goal. The patient should be able to see all his electronic health records. So this is what is expected in the patient journey. So what is expected from the hospital? The facility should have scan and share. I will explain about the scan and share in a short time. So scan and share is basically a OP registration process. Then next comes the health record and lab report and whatever records linking. Then is the scan and pay. Then IPD registration and end-to-end process completion. So not only it is useful in OP procedures, it is very useful in IP monitoring also. So basically if the program has to run in a very seamless manner, HMIS is the basic component. HMIS is the backbone. So without HMIS, this program is useless. So as you all know, we have very few government facilities with current running HMIS, which is being implemented by CDAC HMIS, as you all know. So there are two model facilities which are using this HMIS. One is Tirunelveli Medical College Hospital and other is the Keelpark Government Medical College Hospital. These two hospitals are end-to-end ABDM compliant. I have few pictures of these hospitals with the capability of end-to-end ABDM compliant. I will come to that in a short time. In the private ecosystem, we are using a lot of methods. We have a few team of around 10 members in TNHSP who are going hospital to hospital and trying to make the hospital ABDM compliant. So there are few materials which are basically required so that the facility can be declared ABDM end-to-end compliant. So first is the HMI system along with functional PC, laptop, internet facilities, TV monitors, etc., the required hardware. Then the module for ABDM enabled HMIs with lab and pharmacy module which has to be there. Then we need to create lot of the ABA ID for the patient. Then only the records will get along with the ABA ID. So the creation of ABA ID is very mandatory. So scan and share is an EC registration process which we will see. Then rigorous IEC material. All these things has to be there. Then only the hospital can be declared ABDM compliant. So the photo you can see, this is not in our state, this is in North India. So in the first photo you can see there is a lot of queue waiting there. The basic reason which was identified for the queue was, one is the receptionist was typing the demographic details. So what he will do is, what is your name, what is your phone number, tell me your father's name or address, everything he has to type. That is one problem. And the next problem is like whether it is a verified data. No. The patient, I go to the hospital, I don't want to disclose my identity, I can tell my name, I can bias anything. So these kind of problems are there. So what we have achieved with the scan and share is, there will be a QR code which will be displayed in the hospital OP desk. So you can see this is the QR code which is placed in Keelpark Medical College. So the patient has to walk into the OPD, he just have to scan the QR code. So by scanning the QR code, two things will happen. One, all his Aadhaar verified data will transfer directly to the OPD counter. So that is number one. So the data is verified and authenticated. So next thing, there will be a creation of token number. So for example, if I am the patient walking into the queue, by scanning this QR code, I will get my token number. I don't need to wait in the queue for a long time. I can go sit anywhere in the hospital. So whenever they call my token number, I can approach the registration desk and I can get myself registered and get a OP slip. So this all process has, these photos has been taken from Keel Park Medical College only. So this is how the token number gets generated for the patient. So when the token number 29 is called, the patient has to approach the OPD desk and he can get himself registered. So this is a screen of a doctor, treating doctor who is going to see the patient. So he has two options. So if he is a new patient, he can treat directly, or if he wants to access the patient's previous records. So what he has to do is he has to raise a consent. So these records cannot be accessed directly. So these consents are granted in two ways. So one is through the PHR app. So this through the ABA app, the consent can be raised and the patient can give consent for sharing his health records. This is one method. The next method is OTP. He can raise a OTP if the patient don't have an Android phone or something. The patient can share the OTP so that the doctor can see his health records. So this is how the doctor views the previous health records. So next, if the doctor wants to refer the patient to the lab, so inside the system itself, the QR code will be generated, and out of this QR code, stickers can be printed. So by using the stickers, the samples are collected in the lab. The stickers will be placed on the tubes, it will be processed, and the reports are purely QR code based. So there is no chance of like mismatch of reports or something like that, because everything is QR code based. So once the lab reports are ready, the doctor can see the lab report in his own screen. He can take the clinical decisions and he can give a prescription to the patient. So everything is happening digitally. Nothing, there is no paperwork in between. So as far as the patient, finally all his records he can access through the any PHR app. So through ABA app itself, if the patient log into his account, he can be able to visualize what all records are generated right from entry into the hospital till the patient comes out of the hospital. Everything is digitally recorded and everything is accessible to the patient. So ultimately, the patient can view all of his health records in one place. It is arranged in a chronological order. So, for example, I take a treatment at Madras Medical College today. So those records will be recorded. So after 1 week, I go to Stanley. All these records can be viewed by the patient and the treating doctor based on consent in one place itself. So this is how the system works. So I thank you all for giving me this opportunity to showcase this program. I hope everybody understood the concept and it will be implemented in future. Thank you so much.
So we thank both Dr. Jyotiban and Dr. Sangameshwar. Please be seated. Thank you for your presentation. A very important area for discussion actually, but we are actually touching upon the lunchtime now. The point is, there is a great challenge at national and state level for fixing up a unique health ID. If the states are all connected together based on a unique health ID, then half the problem is solved. So that way you have your ABA ID, the ABDM generation, which is supposed to show, which is showcased as a model. And of course there are challenges. And state governments also have their own unique ID. They are also trying to bring up. So I think it is an area where we are struggling to make it happen. But some model, both of you explained very well, some working models, especially in Tirunelveli Medical College and Keel Park Medical College. Dr. Sendil, our joint director, had lot of exposure and experience. He should have been the moderator for this. I actually thought after I came over, you would have been also very good to support and complement to the discussion going on. The forum is open for the audience. to tell your views or like say anything which will bring more meaning to the table. Kindly introduce yourself, sir.
Hi, my name is Devesh Verma. I work for Ola Foundation. I have a question for both of you. Am I audible?
Yeah. You keep the mic closer, sir.
Sure. Thank you. So you both spoke about interoperability, you spoke about facilities. The question is that purely from a public health information continuum perspective, how do you see the way ABHA was visualized right from when the digital blueprint came out, and I was lucky enough to be part of those blueprint discussions as well. What I want to understand is that if I look at per facility ABHA implementation or ABDM implementation, how do you solve the interoperability problems within disparate systems? Is it something that you would create an interop for, let's say SNOMED or ICD or LOINC, or they will have to work on? So what is the approach to bring or converge everyone to adopt a system like this? Right now, one facility, longitudinal, does not solve the true sense of ABHA.
Sir, I hope I have got your question right. So you are asking how two institutions talk to the system. I hope this is what you are asking.
It could be two or more, because that's the whole idea of converging a longitudinal record.
So basically, this HMIS has to be ABDM compliant, sir. So for example, I have XYZ hospital, there is another hospital. My hospital has to be ABDM compliant. There are 3 milestones the hospital has to cross: M1, M2 and M3. So M1 is basically creation of ABHA ID. M2 is creation of health records within the institution, and M3 is interoperability, where the patient can access his records anywhere and any other hospital can access the record. So for this, the integration team is there at the national level. So there is a sandbox. We have to register in the sandbox. We have to register our HMIS, and through the sandbox registration, the NHA team, the National Health Authority, Government of India team will work along with us and make the HMIS ABDM compliant. There are few HMIS which are already ABDM compliant. The HMIS which I showcased to you, the CDAC HMIS, which is ABDM M3 compliant. Also, there are around 57 private HMIS players which are ABDM compliant, which are available in the NHA website. So those HMIS are basically plug and play. So any hospital can adopt those HMIS and they can start using. Only thing they will be charged a nominal amount for using the HMIS. So if I already have an HMIS and I don't want to change the HMIS to another one, then any HMIS can be integrated using the method which I told you in the beginning. Like it has to cross through 3 milestones, M1, M2 and M3. It will take some time. It will take around 50 to 60 days at least. It will take some time. But any HMIS can be made ABDM compliant. The integration network is there. Integration can be done in a seamless manner.
So there I agree. Systems exist, but then we are still not solving the public primary health care problem. How can I expect?
Can you change the mic, because we are not able to hear well. Either sir is not speaking close or...
I am putting it...
Yeah, change the mic.
Can you hear?
Yeah.
So I'm saying that's well established. That's what ABDM provides as framework. But the question is more nuanced. If I look at a sub-center and people walking up to sub-center, there is a lot of encounter that happens at the doorstep. So that information continuum from the doorstep to sub-center to a PHC to a CHC, then to a district hospital needs to happen. Now the interop does not exist between these facilities. There is a lot of tertiary ABDM with ECA care and PayTM, but that does not solve my citizen's problem who is at a village level. They cannot carry their medical record. So how is ABDM now thinking of, from a state-based perspective, to solve for this? E-Sushrut or Mera Aspatal or E-Aspatal are systems available, but they are a DH or a CHC available facilities. But what happens at a ground level? Anmol is still not compliant with ABDM, right? So how do we solve that?
Sir, basically, what is required is a HMIS, sir. So, right now, when you are talking about the primary care, in the government side, CDAC is implementing the HMIS. So, at the primary level itself, the CDAC HMIS will work, even in mobile phones. Basically, the record has to pass through the HMIS system to get into the ABDM record. So the HMIS will solve all the problems. The HMIS has to be fine-tuned in such a way that the record has to be captured and the HMIS should be ABDM compliant. That will solve the problem, sir.
I think what sir is trying to explain, Jyothiman, is patient-centric data. So patient-centric data is more viable in the hospital setting. You are second year tertiary care, you got a individual patient-centric data. With the PHC and subcenter, we have more of a HMIS data. Now, if you want to connect all the thing, it should be a patient-centric data, which ideally should be generated from bottom level, subcenter and PHC. That's what he's trying to say, which is not actually in place. So, what do you like to tell about it?
Yes,
That's
sir.
the question.
So just to add on that, as sir already said, HMIS is the backbone of ABDM, sir. Without HMIS, ABDM cannot function, because without HMIS, we will not be able to capture the health data. When it comes to a primary health center or a clinic setup in a rural area, one thing that is recently being developed is eSushruth Lite. They are launching a light version of eSushruth, which is very easy and doesn't require much of connectivity or technical knowledge to be operated. So that is going to be rolled out soon, and a small clinic or even a primary health center with the support of government can adopt eSushruth Lite and can start gathering patient-centric data, sir. But without HMIS, there is no capturing of data that can happen, sir. So HMIS has to penetrate till the grassroots level.
Sure, thank you.
Professor Dr. Raghunandan wants to say something.
Just only one thing, sir. Regarding the privacy of the individual, is it at stake? Because as a patient, as an individual, can he say my data should not be documented? Is that a right, or it's compulsory, it is going there, number one? What is the quality of the data? For example, some sensitive issues like HIV status and other things. Similarly, whether it is it's a must in a private sector also.
Sir, it is not at all mandatory, sir. A patient can or cannot generate his own health records. Because when it comes to a patient generating a health record, only he is going to do that. And if he wants to share that particular data to a hospital, it is only consent based. The hospital will request the patient's data, and only if he consents, it will be provided to the hospital.
So it cannot be shared without the patient consent?
Without the patient's consent, it will not be shared, sir. The entire health records capturing and sharing is compliant with the DPDP Act.
Sir, also the data cannot be, is not being stored in any government server, sir. The data is kept maintained in the hospital only. Only thing the government is providing a gateway like UPI. So the transfer of data from one hospital to another hospital. So this is what the government is doing. The government is not capturing any records from the system itself. Thank you.
Okay, I think there are no more questions. I think we can wind up the session, and we congratulate both the speakers for really bringing an important topic, and we should go a long way in this also, the times to come.
I need to add one thing, sir. We do have an active stall in the entrance. Doctors can get their HPR registry done. It will be helpful because this is going to be the future. Thank you, sir.
Thank you, dear sirs, for clearing all the doubts from the grassroots level. DPH Icon 2025 invites a well-informed, conversant, genial, affable, biovent, and pragmatic Joint Director, Maternal Health and Child Health Services, Dr. J. Nirmalsan sir, onto the dais to honor the speakers. Thank you, sir.
We respect Dr. Gerard Maria Silvam sir, Additional Director NHM, to stay back to chair the next session. The session on HIV by Dr. Kalu Sivalingam sir, DD Tansax, has been postponed to post-lunch. We cordially welcome Mr. Kaushik Ganguly sir, Social Policy Specialist in Child Survival, UNICEF, to moderate the panel discussion on protecting future, strengthening systems for early prevention of NCDs in children.
அனைவருக்கும் வணக்கம். பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை நூற்றாண்டு விழா கண்ட துறையாகும். இந்த துறை தமிழகத்தில் இளம்பிள்ளைவாதம், பெரியம்மை மற்றும் நரம்பு சிலந்தி போன்ற தொற்று நோய்களை ஒழித்துள்ளது. மேலும் மலேரியா, பைலேரியா, டிபி, லெப்ரசி போன்ற நோய்களை எலிமினேஷன் செய்வதற்கும் தேவையான பணிகளை தொடர்ந்து செய்து வருகிறது. டெட்டனஸ் எலிமினேட் செய்யப்பட்டுள்ளது. மேலும் மக்களை தேடி மருத்துவம் என்ற ஒரு சிறப்பான திட்டம் இந்த 5 ஆண்டுகளில் செயல்படுத்தப்பட்டுள்ளது. இது மூலம் உயர் ரத்த அழுத்தம் மற்றும் நீரிழிவு நோய் கண்டறிந்து தொடர் சிகிச்சை அளித்து அவர்களுடைய ஆயுட்காலத்தையும் மேலும் அவர்களுக்கு ஏற்படக்கூடிய காம்ப்ளிகேஷனை தடுக்கும் விதமாக தொடர்ந்து இந்த துறை செயல்பட்டு வருகிறது. நன்றி, வணக்கம்.
Now, DPH Icon 2025 cordially invites Dr. Abhishek Kuvar, NPO, WHO. Sir, he will be joining us in online. Dr. K. Krishnaraj, sir, Joint Director, NCD DPH and Preventive Medicine, Chennai. Dr. Pradeep Kumar, sir, Director, Health System Research India Initiative from Kerala. Dr. Raghunandan, sir, Director, ACS, Advanced Medical Research Institute. Dr. G. Prakash, sir, HOD, Department of Diabetology, GM KMCH, Salem. We welcome all the speakers to the rise. Over to Chairperson, Dr. Gerard Maria Selvam sir, Additional Director, NHM.
It's a big challenge to start this session just before the lunch, but at the same time, we look at the importance of the topic and we expect all the audience to pay good attention to this topic. To talk about the children and the non-communicable diseases, we should all take back our memory many decades ago. We have come a long way. Let us imagine 5 decades ago, what did we hear about NCDs? We heard that NCDs are diseases, hypertension, diabetes, affecting the higher socioeconomic status. We used to call them fashionable diseases. And then we brought a program to screen. When we brought a program to screen, we also did a step survey. When we did a step survey, we find in Tamil Nadu, hypertension is about 34%, either single hypertension, single disease, or both hypertension, diabetes. And diabetes as a single disease is 17%. So we came to realize it is not related to the higher socioeconomic status, it is affecting the adults. Now, today's topic, we are trying to talk about children predisposed for NCDs and also developing NCDs. A very important topic because it has its origin. What we see, the NCDs in the adults, it has its origin which can be traced back to their childhood. How do we look at this problem? And definitely type 1 diabetes, asthma, congenital and acquired heart disease, obesity, mental health disorders, they often become chronic when the child becomes an adult. To touch important statistics, can we believe 71% of the preventable adult deaths are due to NCDs? And that gives us the scope for prevention in adolescence. 60 to 65% deaths in India and Tamil Nadu, they happen due to NCDs. What do we do with the risk markers, especially among the children? In Tamil Nadu, 1 out of 5 are obese and 9.4%, about 10% are overweight. Children developing pre-diabetes, which can be reversed. Children with hypercholesteremia, which can be reversed or which can be intervened. Children with hypertension, children with pre-diabetes or diabetes, CKD, chronic kidney diseases. All these things are very, very important areas which we should look into. As the audience here, what are we going to do about prevention, early detection? How do we effectively manage this in their early years? Do we have a life course approach? Are we going to reduce the future morbidity and mortality and the cost involved to the health system? We have a lot of intersectoral applications in the field. School health program, RBSK, ICDS, Poshan, Pygmy, lot of things. What do we find? What is that framework we need to work out in an integrated manner to address this childhood NCD? This will be the forum to tell us how we think about this burden, what we are going to do in future. So now I invite the first speaker. Who's that? Dr. Abhishek, who is supposed to join us online. So maybe we can have the person, since he's waiting on online, he's one of our speakers. So let sir join, and we welcome you, sir. Can we have the video of the speaker opened up and ensure that he is audible and the screen sharing is perfect?
Can you hear me?
Yes, sir, we can hear you, sir. Welcome, sir.
Okay, thank you, sir. So, shall I? Okay, presentation. Okay. Thank you, sir. Thank you, respected chair, Dr. Gerard, all the dignitaries and the panelists. And I sincerely thank the organizers for giving us an opportunity, WHO, to be part of this very important and very important discussion on the NCDs in the children, and which is really the upcoming and most will be in the coming future. This will be one of the topics which needs to be discussed all over the globe, and where the focus has to be made in terms of the policy decisions and the financing and the education and the behavior. So thank you again. So next slide, please. So if you see that we all know that about the NCDs associated with the adulthood in the adult population, where the India also the 30+ population where screening, diagnosis and treatment is being done, and Tamil Nadu is one of the leading in this area for the NCDs management and the control. But now the focus has to be on the children and adolescents. Why? So there are some areas like cardiovascular diseases, chronic kidney diseases, type 1 diabetes, type 2 diabetes, asthma, cancer, metabolic condition, other conditions where we see the more than 2.1 billion children and adolescents are affected by NCDs in 2017, and more than 1 million deaths in children under 20 in the 2017. This is a very high number, and this is increasing year by year. So if you see in terms of the 1.2 million people aged under 20 years dies from non-treatable NCDs, which can be treated, which can be prevented, but there is a death of more than 1.2 million. And 24.8% of Delhi's and 14.6% of deaths among the children and adolescents. So I'm giving this figure because this is alarming, and it's an alarming situation where we all stakeholders need to come together, policy makers, need to come together and all the partners to come together to build some sort of planning for to tackle this burden of NCDs among the children. And if I give because WHO is working on the estimates on the childhood cancer burden, and I am part of that. So if you see this, giving some rough figure on among the children aged 0 to 19 years, the childhood cancer is a leading cause of deaths and ranks 4th in the global disease burden. So I'm just giving an example. Other diseases are also very important. Type 1 diabetes, type 2 diabetes, cardiovascular disease are very important. And if you see in terms of the childhood cancer, again, approximately 90% of new cases are diagnosed in LMICs, and it is estimated that up to 33% of cases remain undiagnosed worldwide. So these are the figures which is really brings with the policy makers to discuss and decide, and this is the one of the forum I thank again to organizers for coming with this discussion. And if you see there's an article that says that the estimate 70% of premature deaths in adults can be linked to the behaviors that start in adolescence. So this is the global burden, which increasing burden among the NCD children with various areas, various diseases. Next slide, please. In terms of India, I see that India has the highest number of children and adolescents living with NCDs in the world. So the numbers are increasing in India year by year. And if you see that more than 27 million children and adolescents are living with severe or debilitating NCDs by 2021. So these data show. But if you see the second part of this, that 3.4% of children there is a childhood obesity. But this is the childhood obesity. If you see the overweight is more than that. So that can be a obesity again. So the numbers are growing. Diseases are growing. This is a time to work together for the prevention and the control of the NCDs of the children. And more than 4 million cases of these severe NCDs are being added every year in this age group. And this impacts the children and adolescents, all age groups of the children and adolescents, where the adverse impacts on the child's social and academic development, mental health issues are there, comorbidities are there, out-of-pocket expenditure of the family, and the expenditure on the government, on the policy makers are there, impact on the economic productivity, and significant future burden and cost for public health. So this is the India scenario. Next slide, please. So there is a need. If you see the current 2011 census, so there is around 30% of population living in this age group. And if it is not tackled, so if you see the projection population of 2036, it's going to grow, it's going to increase in all areas if it is not prevented now, if it is not tackled now. So it is going to grow in all the age groups of the children and adolescents. And children affected by NCDs often face a lifelong challenge, and we all are aware about the societal issues and other issues in terms of how the children are facing the NCDs among this age group. So this requires a multi-sectoral approach. If you go to next slide, please. So if you see that it is not a foolproof strategy, and this is a thought how we can in the existing system. Tamil Nadu has a very good system of NCDs. They have MTM, they have other systems are there. So building on those adulthood, managing the adulthood NCDs can be come together for the childhood NCDs also. Like the areas for the health promotion and prevention of the risk factors, we know that prevention is the more important in this age group. So promote healthy eating habits, encourage physical activity, prevent tobacco and alcohol use, and there are other areas also. And there are the contributing factor where we need that community environments and environment health promotion. And of course, most important is the mental health promotion, mental health area where needs to be, the focus has to be there. And there are other areas, strategies which can become as one of the strengthening of health systems, NCD clinics and the primary care health, early diagnosis and management. We always talk about adulthood, the early diagnosis and the treatment is the key to save the life of the people living with NCDs. Here also the early diagnosis and management is key, and linkages with other existing programs. So can you go to next slide, please? So this is my last slide, and this is a very, you can see that there are many areas where can be linked, and all the multi-sectoral areas, multi-departments have to come together. It is like a RBSK is there, RKSK is there, maternal and child health, school health program, nutrition program, tobacco control program, oral health, NCD program is already there. Department of School and Education, Reproductive Maternal Neonatal Health, Child and Women Development and Sports Ministry. So there can be much more. So what I am trying to say here that the multi-sector and multi-collaborative approach will be very helpful in tackling the NCDs in the children, which is growing and increasing day by day and year by year. Thank you very much for again, Chair and all the dignitaries and panelists and organizers for giving WHO an opportunity to speak. Thank you very much.
So thank you, sir. When we sum up, we will be taking up some important highlights. Call upon Dr. Pradeep Kumar, Director, Health Systems Research India Initiative, Kerala, to share your experience on this important topic.
So good afternoon.
Volunteers to ensure that all our medical officers are inside, because it is very important topic for all our medical officers. Please encourage each other to be present inside.
Directing to the here itself. Okay. So good afternoon to all the dignitaries on and off the dais. And I have a great pleasure in coming and talking to you, and I express my thanks and gratitude to all the organizers and also to UNICEF for giving me this opportunity. So I am coming from Kerala, and Kerala is also a state with a high burden of NCD. And almost 2/3 of all deaths in these years are due to NCDs. And in 2016, almost 4% of all NCD deaths occurred in Kerala were among people below 30 years of age. We all know the causes. Exposure to risk factors, especially the modifiable risk factors like tobacco use, alcohol consumption, air pollution, unhealthy dietary practices, and physical inactivity are the major causes. And the people are exposed, and the newborns are also exposed even before birth. Prenatal exposures, natal exposures, postnatal exposures, and in exposure throughout the life are the are the situations in Kerala and also else of the country, and these are the grave situations. So let me quote 3 recent studies from Kerala to substantiate this statement. So one study conducted among adolescent students in higher secondary school in Kasaragod revealed multiple risk factors among them. The consumption of packaged food and soft drinks were very high, 67% and 90% respectively. The consumption of fruits and vegetables required for the day as per the WHO recommendations were less, only 49.4% were taking this much fruits and vegetables. And the physical activity as per the recommendations were also low, only 41.9% were physically inactive. All these things resulted in overweight, obesity. 13.2% of them were overweight, and there were high clustering of risk factors. They studied 8 risk factors, and 34.7% had 2 risk factors, and 21.7% had 3 risk factors. And another study among adolescents in higher secondary schools in Thiruvananthapuram that also showed almost similar pattern, and the prevalence of hypertension among them were 25%, overweight 19%, and obesity 6.4%. This is not the adult population. In Kerala, among the adult population, almost 20% are suffering from diabetes, and more than that, 20% of others are in the pre-diabetic state also, and almost 30% are hypertensive, and 25% are in the pre-hypertensive stage. So that is alarming in the adult population, that usually leads to very high numbers of renal failure, cardiac deaths, and stroke events. But you see, even among adolescents, the hypertension, overweight, and obesity are very high. The other risk factors are also high. Consumption of junk food and soft drinks are 63% and 53.5% respectively. Consumption of fruits and vegetables at least 2 to 3 times a week in sufficient quantity is less, 54.5% and 31.8%. Physical activity was also less, 38% only. And another study conducted in the among the college students in Kannur also revealed the similar results. What we can do, the strategies should be started right from the childhood itself, and the strategies can be at the micro level or at the macro level. Some of the risk factors, most of the risk factors are related to dietary factors and also physical inactivity related factors. So the need of awareness generation is good, and making the healthy food choices available, affordable, and accessible are more important than awareness generation. And also about the physical inactivity, the situation should be suitable for promoting sports, games, and other physical activities are useful. But these voluntary control measures through awareness generation may be usually unsuccessful, especially in large populations. Legal measures and policy formulations are more important in such situations. Such measures are available and are cost effective also. Let us see some of them. Before going to that slides, let me narrate some of the pilot studies we have conducted in Kerala with the help of the NGOs like Kerala Voluntary Health Society in coordination with the VHI, Ministry of Education Kerala, and Kottayam Municipality. We have conducted some pilot studies in 5 schools in Kottayam, and included students studying from 6th to 9th standard. About 800 students participated in the study, and it was the Healthy Tiffin Box campaign. The objective was to upscale the nutrition intake of students, to prevent childhood obesity, and to create awareness about the junk food and trans fat. So the activities, the parents, teachers, and students, leaders were sensitized about the risk factors and the results in the adult life, and the health education classes were given to the students. Dietitian also talked in the classes, and the dietitian helped the students and parents to modify their food habits, but they modified it in such a manner so that every family can adopt it easily and affordably. For example, if the child is coming with bread, the dietitian worked with them and asked them to add some fruits and vegetables along with that. The children coming with sweet, the dietitian advised them to they take other foods without any sugar, something like that. So they created this awareness, and a sticker campaign was also conducted along with that. Then another one was, along with that, healthy corner were created in the schools to establish a space for health in schools and to develop health as a subject for extracurricular interventions. So created a space as a resource center in these schools, and provided reading materials, IEC materials, posters, etc. in that resource center, so that the students can come at any time and can read and get information. Then there were health talks also. So all these, and also another thing, in small scales, traditional game promotion activity was also conducted in these schools. So finally, the result was, in the initial stage, almost 60% of the students were bringing unhealthy food. At the end of 6 months intervention, this reduced to 20%. Then other interventions like tobacco-free home initiatives, tobacco-free school initiatives, school protection committees were also there during the. So there are policy options like that, but because of the positive time, I can brief it in, make it a brief. So develop policies to reduce children's exposure to ads and marketing of unhealthy foods and beverages. Tie up with the food industry for reformulation of packaged food and beverages with less fat, sugar and salt contents, and make them widely available at a lower cost, and the government can give subsidy or incentives. Restrict the sale of unhealthy food to reduce the impact of children, like reduce the frequency of dissemination through electronic and print media, reduce the power of messages, and avoid dissemination before the bedtime of children, and restrict the advertisement in all settings where children frequently visits, like schools, parks and children's shops, etc. Improve the food labeling, especially the FOP, front of package labeling and traffic signal packaging will be more helpful also. So because of the positive time, I stop here. Thank you very much. Thank you all.
Thank you, sir. I request the speakers to restrict, stick to your timing. It will be helpful for everybody. And all the block medical officers, DTTMO and other APMs, we look forward to some questions at the end from you, because medical officers' attention is very, very important for this session. So as I said earlier, the Salem district organizers, please get in touch that people, even if they are a little out, can be called inside. Now I invite upon Dr. Raghunandan sir, Director, ACS Advanced Medical Research Institute, Chennai, to deliberate on this topic.
Good afternoon, most respected Director of Public Health and other higher officials of Directorate of Public Health, and also respected dignitaries on the dais and off the dais, and friends. We are conscious that we are standing between you and lunch, and as the moderator already said about the time management, I am also for it. So I'm not going to project any slides, but just I want to share some of my thoughts on this very, very important topic. Before I go to the topic as such, I should really congratulate the Director of Public Health for taking up this topic, because this prevention of this NCD can be discussed only in this forum. In no other forum we can discuss. We only talk about management, complications, high-end investigations and treatment, transplant, like that. But I think we should congratulate the Director of Public Health and Director for choosing this topic, because normally when we say DPH, we only focus on communicable diseases. But now the time has come to focus on the NCDs also. So with that small introduction, I view the topic in a different perspective because the topic talks about prevention of NCD in adolescents, children like that. But there's one beautiful Tirukural all of us know, Noi Nadi, Noi Mudal Nadi, Adithanikum, Vai Nadi, Vaipachayal. Normally we tell this for fever outbreaks. Whenever a patient comes with fever, find out what is the cause of fever and manage. But today, when you are talking about NCD, today we have a program of walk-in. Anybody who walks into a PHC 30 years plus, you are being screened for a non-communicable disease like hypertension, diabetes and other things. 18. Okay. So, we are screening them at the age of 18 years. But all of us know, once we understood the etiopathogenesis of all NCDs, it starts from utero. So when you are talking about prevention, we are not only talking about prevention of NCD in childhood, we are talking about prevention in adulthood also. I think that is the most important because as a parents, as grandparents, we want our children to have a healthy life. But none of us conscious of their health related issues starts in utero. So starting from pregnancy, we already know the subject, so I'm not going to the nuances. But starting from utero, and one of the major points that I want to take up for discussion is obesity. I think obesity is a risk factors or a risk factor for most of the non-communicable diseases, including cancer, diabetes, hypertension, and today we are talking about metabolic associated steatoliver disease like NASH. So everything starts with your diet. So I want to concentrate on two important components. One, my previous speaker has already shown so much of evidence about junk foods because they say, because we are all addicted to the taste. Even if you go with so much of motivation not to take ice creams when you go for a party, the smell and the sight makes you to take it because we are addicted to that. So I want the younger generation to be conscious. Still I remember when I was in GH, one of our professor used to say, he is a diabetic. He will say, when I go to a party, when I see a laddu there, my mind says, please take it. But again, my subconscious mind says, if you take one laddu, you have to do another 10 minutes of walking tomorrow. So he has to choose whether to take one laddu or take another 10 minutes of walking. Ultimately, he decided, I don't want to strain more, so I will not take laddu. So what I'm trying to say is, it's nothing but your mindset. So make sure that all our kids are told about all these impacts at childhood. Ilamayil kal, and also they say, Tottil padakam, idugadu mattum. And also there's another, all these are no, vidai vidaitavan vinay arupan. If you take, in fact, one more thing they say, God has given you, say 10 lakh units of insulin. It's up to you to use it throughout your life. Human life is meant for 120 years, that's what they say. But how you protect yourself, how you use your health or you use your diet, use your exercise judiciously will make you to survive for a long time. So that is one thing that I wanted to tell regarding the modifiable factors as far as NCDs are concerned. Other is the non-modifiable factors like genetic disorders. I think one of the important programs that we do in our state is screening for thalassemia and sickle cells. In Jabna Mathur already the program is going on. So we can identify certain high-risk places where non-communicable diseases through genetic or other inborn errors comes. We can have a structured screening program for those high-risk groups that can be done. That's one more. And another non-communicable disease that is being commonly screened in our program is on thyroid disorders. I think all the newborns are being screened for thyroid disorders and all pregnant women are being screened for thyroid disorders. We have a structured program so that thyroid is being already taken care. And another important problem as a social responsibility is drug addiction. Today, I think the drug addiction starts in childhood in schools. So I think that's a very big problem. Unless we address them that day, that level, we are going to face complications later. So one, and another is using mobiles and social medias, sleep deprivation. I think another common, because most of my students, they come late. They say, I go to sleep only at 2 a.m. because of the social media and other things. So there are many more like your what should I talk about? The environmental, already air pollution was discussed, that has to be addressed. And before I conclude, I want to include one more thing. Today we go and get checked for cholesterol, creatinine, LFT and other things. Now the time has come to check your microplastics in your blood. Already articles have started coming of doing a microplastics. We consume roughly around some 10,000 particles, 10 to 20,000 particles per year. That's what we are consuming, microplastics in one, and we are able to detect the microplastics. So be aware of using all these bottles, even other things like your Dipty. Dipty contains plastics. So like that, please go through the articles on microplastics. So there are many areas which are acting as a triggering factor for non-communicable diseases in our life. So please take care of them. So before I conclude, just I want to tell 3 important components. Begin before birth. Starts with antenatal and your life changes. Continue after birth. Be aware of your diet and exercise. Make it a habit till death. At last, it matters is your health. Thank you.
Thank you, sir. I admire sir for quoting a lot of Tirukkural and other important quotes. One quote he mentioned was, Yagavarainum na kavakal soga appar sollirukkupatte. பொதுவா எல்லாமே நம்ம அந்த மற்றவங்களை ஹர்ட் பண்ற வேர்ட்ஸ்க்கு தான் நம்ம நினைப்போம். ஆனா அவர் சார் நாக்குக்கும் சொல்லியிருக்காரு. அதாவது நம்ம உணவு உண்ணும் பொழுதும் அந்த நம்முடைய நாவை நம்ம காக்க வேண்டும் என்ற ஒரு டிஃபரண்ட் இன்டர்பிரேஷன் கொடுத்திருக்கீங்க சார். That was very interesting to observe. Next we call upon Dr. G. Prakash, HOD, Department of Diabetology, Government Medical College, Salem. Welcome, sir.
Good afternoon, one and all. At the outset, I thank the scientific committee for inviting me here. So they are calling a diabetologist during hypoglycemic period. So we are in the era of non-communicable disease. So how to prevent? Communicable disease prevention is very easy. We have given vaccine and we have done everything. But now it is a tremendous task for the public health department in prevention of this NCD. So this is a concept wherein we need to say that the prevention starts pre-conception even. A young adolescent woman should maintain her ideal body weight. She should not be overnourished or she should not be undernourished. Both undernourishment as well as overnourishment causes non-communicable disease. Why? Because the undernourished, when they give birth to low birth weight or poor gain in weight during infancy, when they are succumbed during adulthood or during childhood to excess consumption of food, that causes diabetes and other metabolic disease. Why? Because undernutrition causes poor beta cell development, so they could not cope up during the childhood and adolescence. Similarly, nourishment causes obesity and overweight, which strains the beta cells in the utero even. So we need to prevent both undernutrition and overnutrition. Then this is a concept called fetal origin of adult disease. The left hand side you see, this is David Barker. He had done a retrospective study. He collected all the data of those who had NCD and he had gone to records of their birth. He found that those who had a low birth weight or poor nourished developed diabetes and metabolic disorder and cardiovascular event. Similarly, Chittaranjan Yajik is doing a prospective study in Pune wherein he started collecting data from the birth and is following up almost 10 to 15 years. He found that those children who had born low birth weight and poor gain in weight has an increased incidence of this metabolic disease. So early fetal intervention is a must. Optimization of maternal nutrition is very helpful in prevention of diabetes, and control of maternal hyperglycemia is very much essential to prevent the metabolic as well as cardiovascular disease. And another important thing is maternal weight management is important. So periodic weight assessment helps in producing the good healthy baby. And another important thing is encourage exclusive breastfeeding. That itself has found in few studies prevention of development of type 1 diabetes. And we need to delay the weaning foods, complementary foods, later part. So what are the risk factors in children? Unhealthy diet, which is very much rampant. And next is physical inactivity. And recent study for our officials, you should not sit idle for more than 2 hours. You need to break. So that itself causes diabetes in future. So break your sedentary sitting time not more than 2 years. Then obesity is another risk factor, environmental exposure and the mental stress what the children are having, the academic pressures. So don't stress the child. Now most of the school are stressing, has started IAS course from 6th standard even and this NEET course from 8th standard. So don't put pressure, that is also a risk factor in children. And family history, this is a non-modifiable risk factor. Then we need to detect early. How? Based on the growth chart and periodic BMI monitoring. And blood glucose and lipids in overweight child. So the primordial prevention is promote healthy diet from childhood, enhance physical activity. One of the important factor that we need to do is limit screen time because almost most of us are with the cell phone. So we need to teach the children to restrict the screen time. And school-based health education is very much important. And another important thing is we must ask the teachers not to give excess homework. That itself disrupts the metabolic life of the child. So sleep hygiene is important and reduction of mental stress. This is the CBSE has mandated these boards has to be kept in all CBSE affiliated schools, sugar boards, wherein they are promoting not to take these high calorie drinks. So this must be also be included in our Tamil Nadu government. So a brief word about diabetes occurring in childhood. All diabetes occurring in children are not always type 1. There are other types even. Although type 1 diabetes is common, we need to also focus on other classification of disease. Type 1 diabetes usually starts between 6 months to adults and it presents acutely and you could not trace the family history in type 1. Obesity is rare in type 1. Acanthosis nigricans is a marker of insulin resistance which is not there in type 1 and most of the person present with high blood sugar and DKA and autoantibodies are positive in type 1 whereas type 2 it do occur in overweight and obese children wherein both of the family members will have diabetes and obesity and overweight is a common feature of type 2 diabetes. Acanthosis nigricans will also be seen. Glycemia is variable, autoantibodies is negative. And another important is we come across is maturity onset of diabetes young, which is also not that much common, but we need to study that. And it is incident and one parent lineage will have diabetes. For example, if the child father and father's father may be diabetic. So one single lineage that is autosomal dominant inheritance. And how to diagnose type 1 diabetes earlier, that was our moderator's question. So there is no specific factor to detect type 1 diabetes early, but we can detect based on the weight measurement. Similar to progress card, we must ask the school teachers to maintain weight card. Every month they need to assess weight. So periodic weight assessment itself helps in detecting diabetes. How? Why? Because it is a rapid loss of weight is a feature of type 1 diabetes. Similarly, overweight is also a marker of diabetes. So these are all the various stages wherein in stage 1 it's very difficult to pick up. In stage 2 we can pick up. Now there are drugs in preventing the stage 2 progression to stage 3. So we need to primarily prevent the maternal and early life intervention, healthy lifestyle promotion and environmental measures promoting outdoor activities. I like the public health officials not only give sanitation certificate to the schools but also active playground certificate. Thank you. Thank you very much for your patience hearing.
So thank you, sir, for a lot of valuable inputs. We will come back to in the summing up. Next, I call upon Dr. K. Krishnaraj, Joint Director, NCD, Directorate of Public Health and Private Medicine, to share his views.
So good afternoon. ரொம்ப கஷ்டமாக இருந்துச்சு. Now on I am hypoglycemic. Right? 12 மணி பேசுறது 2 மணிக்கு நம்ம சாப்பிடாம பேசுறதுனால I am in hypoglycemic. பட் நான் ஆரம்பத்தில் கொஞ்சம் கஷ்டமாக இருந்துச்சு. நீங்கள் எல்லாம் எல்லா சேரும் வேக்கண்டாக இருந்துச்சு. யூ ஆர் ஹேட் a குட் கிளைசமிக் இண்டெக்ஸ். நல்லா சாப்பிட்டு நிம்மதியாக வந்து உட்காந்துருக்காங்க. ஸோ நம்ம கொஞ்சம் கஷ்டப்பட்டு பேசணும். நீங்கள் இஷ்டப்பட்டு கொஞ்சம் சில பாயிண்ட்ஸ் எடுத்துங்க. ஃபஸ்ட்டு ஸ்லைடு போடுங்க. பேர்டன் சொன்னாங்க. ஒரு படம் முடிஞ்சோடனே யூ see the 5 மூவி ரைட், ஆல் ஸ்டோரிஸ் ஆர் ஓவர். ஸோ ஐ வாண்ட் டு ஸ்பீக் 1 or 2 இம்பார்ட்டன்ட் பாயிண்ட்ஸ் வித்தின் a 5 minutes. பேர்டன் அப்படின்னா எல்லாருமே they are saddened, burden and study and all things. So we are screening above 18 years NCD. As a NCD JDங்கிற முறையில் we are concentrating more 4 years. We are achieving detecting hypertension, diabetes, both and CSRX and all things. We are achieving 2,47 lakhs line list maintained only in Tamil Nadu compared to throughout India, right? That is our achievement. But sir exactly says this topic is chosen. Thanks sir for DPH for this topic. We should concentrate the screening from 0 to 19, right? That is the point. And also sir exactly mentioned the before marriage, after marriage. So we are having more tools, more portals from various departments, from the geriatric, MCH and RBSK and NCD for MTM, so many portal, right? பல portal வச்சுருக்கோம். ஒன்று தனித்தனியாக பீஸ் மீலாக வச்சுருக்கோம். பட் நாட் மேட்சிங், நாட் fetching, not able to ourselves by clutching, right? So output is different, right? So that is our worry. But childhood prevention is the most cost-effective life course of strategy for the NCD. So we are missing in Tamil Nadu. Acceptance is the administration, right? Next. Current state மக்களை தேடி மருத்துவம் இன்னும் வெரி வெல் அபவுட் எல்லாருமே வந்துருக்கீங்க. VHN வந்துருக்கீங்க, ஹெல்த் இன்ஸ்பெக்டர் வந்துருக்கீங்க, மெடிக்கல் ஆஃபீஸர், BMO, ஆல்ரெடி அடிஷனல் டைரக்டர் செய்யும், மெடிக்கல் ஆஃபீஸர் ப்ளீஸ் செட் சொன்னாங்க. மக்களை தேடி மருத்துவத்தில் ப்ரோஸ் தெரியும், கோன்ஸ் தெரியும், கேப்ஸ் தெரியும். ஈவன் தோ ரெசிலியன்ஸ், வி ஆர் ஏ ரெசிலியன்ஸ் பப்ளிக் ஹெல்த் சிஸ்டம். என்ன அடி வாங்கினாலும் நாணல் மாதிரி நம்ம DPH சொன்னார். வி ஆர் அச்சீவிங் 2.47 crores. ஸ்கூல் ஹெல்த் ப்ரோக்ராம் அவர் பார்த்தீங்கன்னாக்கா RBSK சோமசுந்தர் சார் பார்க்குறாரு. அது தனி போர்ட்டல் வச்சுருக்கோம், RBSK போர்ட்டல். இன்னொரு பக்கம் எமிசிஸ் அப்படின்னு ஒரு போர்ட்டல், அதில் BMI செக் அண்ட் ஆல் திங்ஸ், ஆல் வி ஆர் என்டர்ட் ஆல் திங்ஸ் இன் த போர்ட்டல், ரைட்? அது இருக்குது. எஜுகேஷன், ஹெல்த் எஜுகேஷன், அதில் வி ஆர் மிஸ்ஸிங். ஹெல்த் எஜுகேஷன் சார் ஆல்ரெடி கேரளா சார் saying so many studies. ஹெல்த் எஜுகேஷன் வி ஆர் என்னமோ கொஞ்சம் வி ஆர் மிஸ்ஸிங் நம்ம தமிழ்நாடு அப்படின்னு நினைக்கிறோம். இயர்லி டிடெக்ஷன் கன்ஜெனிட்டல் NCDஸ்க்கெல்லாம் RBSKல இருக்குது. ICDS ஒரு பக்கம் இட்ஸ் எ பீஸ் மேல். ICDS தனி போர்ட்டல், செப்பரேட் போர்ட்டல், என்ட்ரி கலெக்ஷன் ஆஃப் டேட்டா இஸ் செப்பரேட், இஸ் எ பீஸ் மேல். மிட்டேல் இன்க்ளூடிங் டொபாக்கோ ஃப்ரீ ஸ்கூல் நவ் இஸ் எ சேலஞ்சு. சார் இஸ் தூங்க மாட்டேன்றாங்க, படிக்க மாட்டேன்றாங்க. அவர் சார் சொன்னார் ஸ்கூலில் வந்து டொபாக்கோ கோட்பா 2003 கோட்பா இஸ் எ சேலஞ்ச், இஸ் நவ் சேலஞ்ச். ஸோ NCD இஸ் 2 main factor. One is stress, adrenalism. அம்மா, பார்ட்னர், ஃப்ரெண்டு, டீச்சர். DPH சொல்லிக்கிட்டு இருந்தார் பேசிகிட்டு இருக்கும்போது. இதெல்லாம் ஜெனட்டிக் கவுன்சிலிங் வேணும் முன்னாடி. வி ஆர் மிஸ்ஸிங் ஜெனட்டிக் கவுன்சிலிங், மிஸ்ஸிங் பிஃபோர், டூரிங், ஆஃப்டர் மேரேஜ் ஜெனட்டிக் கவுன்சிலிங். அதே மாதிரி சார் சொன்னாங்க இன்சுலின், mother insulin we should monitor 8th week onwards. We are missing. After birth 0 to 6 year ICDS, merging of ICDS RBHK data with NCD. கடைசியில் பார்த்தோம்னா NCD JDக்கு வேலைன்னு பார்த்தீங்கன்னா JD MCH, அப்புறம் JD HEP, அப்புறம் JD எல்லா JD டேட்டாவையும் ஒன்றா வாங்கி போட்டு we should extract the output. அதை எடுக்கணும். How to formulate the Next SOB, protocol எப்படி டெவலப் பண்ணணும் கொஞ்சம் பயமாக தான் இருக்குது. நெக்ஸ்ட் திஸ் ஆர் கரண்ட் சிஸ்டம் லெவல் சேலஞ்சஸ். பார்த்தீங்கன்னா எம்டிஎம் டீம் இப்போ சேலஞ்சஸ் அதிகம் இருக்குது. மேன் பவர் சேலஞ்சஸ் இருக்குது, ஃபைனான்ஸ் சேலஞ்சஸ் இருக்குது. ஸோ அதெல்லாம் ரொம்ப இருக்குது. ஃப்ராக்மெண்டட் டேட்டா பேசிட்டோம். அர்பன் ரூரல் இஸ் எ சேலஞ்ச். என்சிடி அர்பன் ரூரல் மோஸ்ட் ஆஃப் த ஸ்கூல்ஸ் பேஸ்ட் அப்பான் த அர்பன். அதே மாதிரி நம்ம ஆர்பிஎஸ்கில் பார்த்தோம்னாக்கா நம்ம வந்து we are concentrated on the government aided school. We are not able to concentrate on the private school. Private school la dhaan obesity அவர் சொன்னார் 3.5% obesity most in the private school. government aided la நம்ம கான்சென்ட்ரேட் பண்ணுறோம். behavioral risk இப்போ வந்து behavioral communication, social behavioral communication நம்ம we are not concentrated. Only collection data, compilation of data, analyzing the data, then preventive measure, control, elimination, eradication. We are not concentrated the primordial preventions. Thank you for this topic. Right, next. No, 2 more slides. That's all. Opportunities. எல்லாமே இருக்குது நம்மகிட்ட. ஆல்ரெடி தமிழ்நாடு ஹேவ் ஆல் டேட்டாஸ், ஆல் ஹெச்ஆர்லேருந்து போர்ட்டல்லேருந்து எல்லாமே இருக்குது. மல்டி செக்டர் கொலாபரேஷன் இருக்குது. பட் இன்டகிரேஷன்ஸ் சார் சொன்னார், இன்டகிரேஷன் இஸ் புவர். ஐ ஃபீல் த இன்டகிரேஷன் இஸ் புவர். ஸோ அந்த டிஜிட்டல் டூல்ஸ், so we should modify the separate digital tools. NCD tool is enough for the monitoring all categories of MCH and all things. Community awareness should be created for the primordial prevention from birth to 19 years is very more. Next, opportunities there, recommendations. Already sir exactly says life course approach, maternal, child and adolescent is must. Integrate, already discussed. Equity, the equity is a challenge. Urban rural system is very challenge. So we should prepare for that in Tamil Nadu. Monitoring and review, very good review system sir. We will integrate, after integration, extraction of this childhood data and all things, we create the tool for the review mechanism. Next. ஸோ எல்லாமே இருக்குது நம்மகிட்ட. we are doing hard work but we are missing primordial prevention. This is the only platform, the first platform Tamil Nadu to for all. Thank you sir, thank you for this time. Thank you.
Now there will be a moderation by Dr. Kaushik. He will focus the questions, specific questions.
So maybe the panelists, thank you for the very elaborate presentation and the discussion. And the advantage of having a high powered panel is that most of the questions are already answered. So it's going to be mostly a little bit of repetition. I will go to Dr. Abhishek Kumar from WHO first. Dr. Abhishek, can you hear me?
Yes, sir. Yes,
Yeah. Thank you so much for being a patient listener. So from the global perspective and from WHO's global experiences, we know Tamil Nadu has had, as Dr. Krishnaswamy mentioned, Tamil Nadu has a very robust community level screening program. They have almost line list of 2.5 crore people being screened and for NCDs and also given drugs, free drugs. From your experience, is there any learning from the global level or from national dispensation on how to better integrate NCDs or early onset NCDs into the program, into the community level program, and what kind of policy shift is needed for us to move that needle forward? Over to you, Dr. Abhishek. So my question is, what are the key learnings in the space of policy reform or community level engagement for early onset NCDs or NCDs in children? If you can throw some light on that, that would be great. Dr. Abhishek, we can't hear you.
Can you hear me?
Yeah, we can hear you now. Yeah.
So thank you again for the question, and what I want to mention it here that There are a couple of examples from global on terms of the NCD in children school health programs and other programs related to the childhood NCDs. But having said that, and you have mentioned about the Tamil Nadu example also, Government of India, Ministry of Health, and in terms of the NCDs for 30 plus population, there is a very good population-based screening is there, existing there for hypertension, diabetes, and three cancers. So particularly if you talk about the hypertension and diabetes, India has been a champion in terms of the screening, diagnosis, and the treatment, and providing the medications at the households and medications at the primary healthcare Ayushman Arogya Mandirs. So India has received many acknowledgements from globally in terms of the managing the adulthood hypertension and now in the diabetes area also. So now coming to the NCD in children, my all thought is that building on the existing infrastructure of the screening program and integrating into the existing child health platforms, that will be the one of the area where we can India focus on. And there has to be task shifting with the focus training and the job aids for the training of the community health workers and the other medical professionals. So that will be the other area where this can be leveraged based on the national experiences. If you talk about the global experiences, I think Vietnam has a very good example for the school-based obesity program, which they have done a randomized control trial. And the key lesson from is that effectiveness of the modifying school meals and nutrition education, which we have just many of the speakers, the dignitaries, and they have talked on in this area. So how to modify the school meals and the nutritional educations and combining this with the physical activity and involving families and the teachers. So the Vietnam has done one of the key intervention in this area, which can be learned from the global example.
Okay.
Also, if I talk about the WHO Pen Plus, when UNICEF is also involved, and particularly in the Africa, which brings the which brings the NCD care very closer to the needs of the underserved populations, and the training to the physicians and non-physicians for the management. And many of the African countries which are showing this, leading this, and the UNICEF and WHO are working together with those countries to build this capacity with the Pen Plus strategy.
Okay.
Ghana has examples, we can discuss all the, but more importantly, there are some examples from the Brazil is there for healthy habits in action in schools. So bringing all these global examples and bringing the current Indian strategy for the NCD management at the community level, school health programs, bringing all the multi-sectoral, multi-departments together to build a uniform system of managing and tackling the NCDs among the children. I think that will be the one of the great, one of the ideas which can be put forward. So this is all from my side. Thank you.
Thank you so much, Dr. Abhishek. I think the key message that I got is that there needs to be a better integration between child health and the NCD's program. So that is how we can integrate the different platforms where child's touch point is. So I will go on to the next, Dr. Pradeep. Dr. Pradeep Kumar from HSRI. You have recently done a study on urban health. And it would be great if you can throw some light on what kind of key challenges in urban health centric challenges do you see in managing risk, identifying risks and managing risks with respect to early onset NCDs in the children?
Yeah, in urban centers, actually in Kerala, the urban healthcare services started recently, especially for the non-communicable disease services, and it is mainly working for on clinical nature, and they are providing medications, testings, and all these are free of cost. So it is more popular, and a lot of people are coming there because it is so free and everything is available, and it is less difficult than going to secondary and tertiary care centers. But though I have visited several urban health centers during my recent study, I could not find much public health activities in the primary health center, in the urban health centers. So they are trying to get more funding, support, and technical guidance also.
Right. So yeah, technical guidance and perhaps better protocol for integrating NCD related public health activities
Yeah.
in the primary healthcare giving setting.
Actually, they are doing some health education sessions in the class, in the schools, occasionally. That's all.
Right. Thank you so much. I would move on to Dr. Dr. Prakash. If you spoke about the low birth weight babies being more prone to developing NCDs later in life, and I was actually referring to Dr. Chittaranjan Yagnik's recent paper, yes, on how visceral fat, children tend to accumulate visceral fat, children low birth weight and towards the lower spectrum of the birth weight children tend to accumulate more visceral fat and are more prone to developing diabetes and NCDs.
Yeah, low birth weight, they have a poor development of beta cells.
Right.
And when they succumb to environmental exposure, to higher food intake, the visceral fat gets stored. So insulin resistance increases. So the poor beta cell function at the fetus cannot cope up with the nutrition they are taking. So that's why the low birth weight and preterm are more prone to develop diabetes.
So my question is, if I were to ask, request our frontline workers to give 2 to 3 messages, key messages to the parents of low birth weight children, what would those 2 to 3 messages be?
To the antenatal mothers.
Antenatal as well as postnatal mothers.
Yeah, whoever it might be, adult mother or in reproductive age group, we must guide them to maintain a good lifestyle with appropriate BMI and avoid sedentary or active lifestyle. That itself will help, and also to take micronutrient supplements if they are undernourished.
Okay. Thank you so much. A very related question to Dr. Raghunandan, you sir. So following from Dr. Prakash's submission, I wanted to check with you, what kind of parenting advice do you think we should give to a parent who has been detected with, whose child has been detected with NCD or early onset NCD, and how do we operationalize a life course approach for such a child? Okay. We have been speaking about life course approach. Many people of, many of you.
I do understand. In fact, as all of us have agreed that incidence of obesity is increasing, and when you go out today in the community, we see so many children are obese, and even to tell the parents about their diet modification, they may take it in a different way.
Right.
But I think today we should identify the influences of children. I think the first influence starts from family. So parents and grandparents and friends. So they must be sensitized, number one. Next influencer is school. So school teachers, in fact, I would strongly recommend, when we say vitals, we say temperature, pulse, respiratory rate, BP. I think we should include BMI. BMI must be periodically measured at schools, and whenever we do under the school health programs, we should have a targeted interventions and follow. I think it's a subtle issue, but we have to counsel them individually and make sure the impact of obesity in the long term, including the parents. Right. I think that is the because it is, as I already said, atherosclerosis starts from early. If you attack obesity, you can address 5 to 6 diseases. So I think the most important is your diet, exercise and environmental awareness. This will go a long way, and maybe we can take a policy decision of awareness every month. Like first Monday of every month should be awareness on the fitness and other things. And sir has suggested about playgrounds. I think physical activity must be a compulsory in all schools.
Curriculum, part of the curriculum.
They should do some activity. It could be some athletic activity or a sports activity where they should do some exercise. I think we are already advocating gyms in government institutions. Like that, physical activity must be a must in all schools. Thank you.
Thank you so much, and thanks for those pointers actually. My last question to the last but the most important panel is Joint Director NCD. So, for a program like Makkaletedi Martuvam, the MTM program, what do you think are the couple of two things that you would like to see as challenge that needs to be overcome, and also from the point of view, suppose say any other state who wants to implement a program like MTM, what are the two things that you will advise them that they need to do or they should avoid?
So thank you for this question. The MTM program we are facing mainly from bottom to top approach level. So you are reviewing all things through the tool and collecting the all data and all things. But frequent visit and frequent behavioral change by the WHV, you know. WHV, number of WHV, we should compare to other state. Ashas, one Asha for 1,000 populations. For example, 250 houses. They are frequently visited and change their behavior frequently. The quality of screening, that they are touch their heart and frequently and mingle with the family. So they are, and also not only the NCD, all work MCH and all works done by the year. Our need of WHV 63,000 for our population. We are managing only by 12,000, right? Yeah. In urban, peri-urban areas and slums areas, 20,000 population on WHV, no? So this is the main challenge.
So in that context, how do you think can we integrate early detection of NCD screening for childhood screening and NCD screening? Is it possible to incorporate into the MTM program?
Yes, we will plan to so more work already is done by WHO, you know. Right. Hypertension screening, blood screening, and motivation for the cancer, breast, CSR.
Actually, the school teachers can themselves monitor. I think we can't expect VHN to do. We can identify the school teachers, Anganwadi people who can be part of the screening program.
Even though, sir, WHV also we give some training to the WHV, 1 or 2 points to maybe discuss with at the time of visit at the parent house to level. Yeah. From that to father and mothers and school and teachers training.
Yeah. Right. Thank you so much. Yeah, one
more point. Identify the children born to the mothers had gestational diabetes. Also, the child born with low birth weight and prematurity, and follow them closely to control these diabetes, these NCDs in future.
So perhaps not everyone, but a risk stratification can be done for whom the screening can be done early.
Yeah, another point what I missed in your previous question about the challenges in the urban centers is the easy availability of all the junk foods and the soft drinks. Yeah. That and again in the urban areas, the children it is more affordable also. So they will easily buy, and these unhealthy food materials are available even in school canteens. So the action is required at the government level for policy formulation. Local level it will be difficult. That will be a big challenge. Thank you.
Also one point, sir, in our setup of institutional setup, our OP attending OP above 18 years percentage is more in government setup, right? And also RBSK we are concerned on the primary, the government aided schools. All private school students they are went to private hospitals. So we should include in the private monitoring and evaluation of private hospital also, the follow-up.
Right. Thank you so much. I will ask Dr. Gerard to summarize.
So, there has been a lot of important decision points coming out of this. So, with the request to our Director of Public Health and Preventive Medicine, I think this topic is one of the most important topics in this conference, because as a recommendation, I think the audience and the panelists and everybody agree that we will take it as a policy to intervene into childhood NCD. So that will go as an important recommendation, sir. The other one is life course approach. How? Yeah.
Okay. Yes, sir.
Yes. No, the school is the best opportunity for Kaushik's question. School is the best place where children can be screened. Already some of the components are already introduced into the RBSK system, where we measure BMI and brand them as childhood obesity or not. But this can be more focused one. Another one is, already we are, the government has recently asked all the departments to evolve a child health policy. Now it is the right time that we fit child NCD policy into the child health policy. So these are the updates which I want to measure.
Thank you, sir. Thank you very much. There is also a need for expert guidance, which we should take up after this conference. We should have the expert guidance meeting so that we look at the community level screening also, because we have to take up the community level screening, look at the challenges in future. And I would like to congratulate also this Kerala experience where you mentioned about healthy tiffin box campaign. So maybe our directorate should look into how they did that healthy tiffin box campaign and how they try to interfere in the school. And lot of things which Dr. Raghunan sir said, like the DPT has got plastics, microplastics in your blood, limiting the screening time, sleep deprivation among our children, the youth and all that because of the screen time, and specific roles we have to do for the high risk children like babies who are prone for NCDs when they grow up. That is the low birth weight and children, the visceral fat issues and all. And FOAD, fetal origin of adult disease. I have noted down a lot of important points. I really thank our directorate, our director and everybody for giving me this opportunity to chair the session, because for my own learning I have taken down a lot of points. And my sincere appreciation to all the panelists and the moderator from UNICEF, Dr. Kaushik. I think this is going to be a lot of takeaway messages for us. We will be taking home a lot of good messages, and it should not end with this panel. After we go back to our respective job, we should sit up with our other works with the expert opinion and all that and take it more seriously. By the next conference, I think somebody should be presenting on Tamil Nadu's experience, how we started doing something for the children NCDs. And I also thank Dr. Vinay, who was instrumental from behind the screen to give a lot of inputs to me also yesterday in the hotel, and like kind of like, I thank everyone and the organizers, everybody, and please go and have a good lunch. Thank you.
Thank you, sir. I, on behalf of DPH Icon 2025, thank all the speakers for the insightful session. Now, we cordially invite the active and vibrant Joint Director Immunization, Dr. Vinay Kumar, onto the dais to felicitate our speakers. Chairperson, Dr. Gerard Maria Selvam, Additional Director, NHM. Moderator, Mr. Kaushik Ganguly, Social Policy Specialist, Child Survival, UNICEF. Put your hands together, please, everyone. Dr. K. Krishnaraj, Joint Director, NCD, Department of Public Health and Preventive Medicine, Chennai. Dr. Pradeep Kumar, Director, Health System Research, India Initiative, Kerala. Dr. Raghunandan, Director, ACS, Advanced Medical Research Institute, Chennai. Dr. G. Prakash, HOD, Department of Diabetology, Government Morgan Kumaramangalam Medical College and Hospital, Salem. Thank you, sir. Thank you all. Due to time constraint, we will take a short lunch break and then again meet for the afternoon session at 2:45.
Secondary and tertiary care institutions. I'm sure even this fourth International Public Health Conference will be opening us to newer topics like NCDs among the
and 27. ஸோ இதில் நம்ம என்ன லேர்ன் பண்ணோம் அப்படின்னா ஜஸ்ட் 2022 அது வந்து மகாபலிபுரம் ரிஜிஸ்டர்ஸ் ஆர் 1678, அப்ஸ்ட்ராக்டர் பொறுத்த வரைக்கும் 305, ஸ்பீக்கர்ஸ் வந்து 40. கிராஜுவலி இட் இஸ் இம்ப்ரூவ்டு. 2023 அது மதுரை, சேலத்தில் வந்து எவ்வளோ பேருக்கு வந்திருக்கு இது வரைக்கும்னா ரிஜிஸ்ட்ரேஷன் பொறுத்த வந்து 2300, ஸ்பீக்கர்ஸ் வந்து 52, எல்லாமே வந்து இம்ப்ரூவ் ஆகிட்டு இருக்காங்க. ஸோ இதில் நம்ம என்னென்ன பண்ணியிருக்கோம் அப்படிங்கிறது ஜென்ரலாக சொல்கிறேன். நம்ம டாக்டர்ஸ் பொறுத்த வரைக்கும் நியர்லி வி ஆர் ஹேவிங் 6000 அண்ட் ஸ்டாஃப் நர்சஸ் ஆர் 9000 அண்ட் அலைடு ஹெல்த்தில் வந்து கிட்டத்தட்ட 35,000 இருக்காங்க. ஸோ இவங்க எல்லாமே சேர்ந்து முதன்முறையாக ஒரு 2022 ஆரம்பித்த மாதிரி ஒரு மிகப்பெரிய ஒரு இயக்கத்தில் என்னென்னலாம் செய்கிறோம் அப்படிங்கிறது நம்ம வெளிப்பட்டு கொண்டு வரோம். நிறைய பேர் நம்ம தெரிஞ்சுக்கிட்டு நாலேஜ் பண்ணிகிட்ருக்கோம். ஸோ இதில் நம்ம என்னென்ன சக்ஸஸ் மெயினாக பார்த்தீங்கன்னா நாலேஜ் தான். நாலேஜ் ஷேரிங் நிறைய வந்து நம்மளுக்கு வந்து யாருக்கு தெரியாது அப்படிங்கிற மாதிரி இருந்தது. அந்த ஷேரிங் வந்து நல்லா கொண்டு போயிட்டுருக்கோம். அவேர்னஸ் ஜென்ரேஷன்ஸ் அது வந்து நிறைய நம்ம க்ரியேட் பண்ணிகிட்ருக்கோம். இல்லை குவிஸ் நடத்திட்டுருக்கோம். அதில் சில பிள்ளைங்க அவங்க நல்லா படித்து சிறப்பாக வர்றாங்க. இனோவேஷன் ப்ரெசன்டேஷன்ஸ் அதுவும் போயிட்டுருக்கு. ஸ்கில் டெவலப்மெண்ட்டு இது மாதிரி இருக்குது. நிறைய ரெகக்னைசேஷன் ஒரு இதை வந்து நம்மளுக்கு புரிய வச்சுக்கிட்டு சிறப்பாக நம்ம பண்ணிகிட்ருக்கோம். தேங்க்யூ.
The main aim of the universal health coverage is to bring the comprehensive primary healthcare services at their people's doorstep, thereby reducing their out-of-pocket expenditure. So, we provide 12 comprehensive set of services: preventive, promotive, curative, rehabilitative and palliative services also. Along with minor ailments, we provide communicable disease and non-communicable disease screening and preventive and treatment. Apart from rural health and wellness centers, we have created 7 or 8 urban health and wellness centers also in the local bodies, in corporation and municipalities for serving the underprivileged population in the slum areas. Health wellness are being conducted in all the health and wellness centers every week, and we provide basic screening services, curative services and give specialist services also. And after that specialist services, we give referrals further care. So our doctors screen the patients and they treat for the communicable disease and non-communicable disease. So patient support group is also formed, in which the patients they share their illness experience, they clear their doubts, and the doctors they screen their illness and they give drug dispensation for the non-communicable disease like diabetes and hypertension. Wellness sessions are conducted in all the health and wellness centers. Their health education is given, and all the wellness activities like yoga, walkathon, marathon and other health education activities are carried out in the centers.
இந்த சுகாதாரத்துறையினுடைய 100 ஆண்டுகள் கழித்து முதலில் மகாபலிபுரத்தில் தொடங்கி இன்று சேலத்தில் நடந்து கொண்டிருக்கின்ற மாநாட்டிற்கு வருகை தந்த அனைத்து என சொந்தங்களையும் வரவேற்று பல்வேறு பிரிவுகளாக பிரியாமல் ஒன்றிணைந்து சுகாதாரத்துறையை வலுக்கட்டாயமாக வேண்டிய சூழ்நிலையில் இருக்கின்றோம். இந்த மாநாட்டில் ஒன்று கூடி பிரியாமல் இணைந்து பகிர்ந்து அனைத்து மாநாடுகளிலும் இதேபோல் பங்கேற்று சிறப்புற வாழ்த்துகிறேன், வணங்குகிறேன். வணக்கம்.
The Directorate of Public Health and Preventive Medicine is conducting its
disease surveillance project reporting, and we are the first state to develop district action plan for climate change and human health, as well as submitted the first state action plan for climate change and human health to the National Center for Disease Control. And we are proud to say that following the extreme weather events like cyclones and disasters, we have taken so much of robust public health activities to control any kind of epidemics or outbreaks. I'm really proud to be part of the Directorate of Public Health and Preventive Medicine. Thank you.
I'm R. Govindasamy, Joint Director of Admin and Director of Public Health and Preventive Medicine. To strengthen our manpower in the administrative wing as well as the paramedical staff, then and there appointed by MRB and as well as TNPC, routed through TNPC side. According to that, in concern with the lab technician grade 3 during 22 to 24, more or less 332 vacancies are filled by MRB. Likewise, field assistant 174. They are also appointed by MRB 22 to 25, as well as administrative line.
திட்டத்தை செயல்படுத்தி வருகிறது நம்ம பொது சுகாதாரத்துறை. யூஎன் கூட இன்ட்ரா ஏஜென்சி அவார்டு கூட நம்ம மக்களை தேடி மருத்துவத்துக்காக கொடுத்துருக்குறாங்க. இந்த மாதிரி பல சேவைகள் வந்து நம்ம குழந்தைகளில் இந்த ஆர்பிஎஸ்கே திட்டத்து மூலம் நம்ம நிறைய குழந்தைகள் வந்து இருதய நோய், உதடு பிளவு, அண்டப்பிளவு மாதிரியான நோய்களை கண்டுபிடிச்சி அறுவை சிகிச்சை செஞ்சுருக்கோம். ஸோ ஒவ்வொரு மனிதரின் வாழ்க்கையிலையும் நம்ம வந்து பப்ளிக் ஹெல்த் டிபார்ட்மெண்ட் வந்து பங்கு பெற்றிருக்கு. இந்த சிறப்பாக இந்த நூற்றாண்டு முடித்து மகாலிபுரத்தில் சிறப்பான ஒரு முதல் மாநாடு நடந்தது. இப்போ சேலத்தில் நடக்க போகுது. ஸோ நம்ம சேவைகளில் வந்து நம்ம மக்களுக்கு ரீச் பண்ணிட்டு இருந்தோம். இந்த மாநாடுகள் பப்ளிக் ஹெல்த் கான்ஃபரன்ஸ் மூலிமா நம்ம பண்ணுறதை வந்து டாக்குமெண்ட் பண்ண முடியுது. நம்ம ஒவ்வொரு டிபார்ட்மெண்ட்டை நம்ம விஹெச்எனாக இருந்தாலும் மெடிக்கல் ஆஃபீஸராக இருந்தாலும் எல்லா கேட்டகரியும் அவங்க பண்ணதை வந்து நம்ம உலகத்துக்கு தெரியப்படுத்த விதமாக இந்த பொது சுகாதார மாநாடு நடைபெறுது. 4வது மாநாடு சேலத்தில் நடைபெறுது. நிறைய 200 பேருக்கு மேலே வந்து இந்த பேப்பர் போடுறாங்க. ஸோ இதெல்லாம் வந்து சிறப்பாக நம்ம பொது சுகாதாரத்துறை வந்து நடத்தி கொண்டிருக்கு. தலைமையேற்று நடத்தி கொண்டிருக்கும் பொது சுகாதார இயக்குனர் அவர்களுக்கும், கூடுதல் இயக்குநர்கள், இணை இயக்குநர்கள், டிஹெச்ஓஸ் எல்லாருமே இதை வந்து சிறப்பாக செய்து நம்ம டிபார்ட்மெண்ட் பேரை மேன்மேலும் மக்களுக்கு ரீச் ஆகும், பொதுமக்களுக்கு யூஸ்ஃபுல்லாக இருக்குமாறு கேட்டுக்கிறேன். நன்றி, வணக்கம்.
அனைவருக்கும் வணக்கம். நூற்றாண்டு கடந்த நம்முடைய பெருமைமிகு பொது சுகாதாரத்துறையின் 2025ஆம் ஆண்டிற்கான 4வது ஆண்டு பன்னாட்டு சுகாதார மாநாடு நமது சேலம் மாவட்டத்தில் செப்டம்பர் 25, 26 மற்றும் 27ஆம் தேதிகளில் பெரியார் பல்கலைக்கழக வளாகத்தில் நடைபெற உள்ளது. இதில் நம்மளுடைய பொது சுகாதாரத்துறையின் மருத்துவர்கள், செவிலியர்கள் மற்றும் அனைத்து பணியாளர்களும் கலந்து கொண்டு சிறப்பிக்க உள்ளனர். மேலும் பல்வேறு மருத்துவ நிபுணர்கள் மற்றும் இளங்கலை, முதுகலை படிக்கும் மாணவ மாணவிகள் அவர்களுடைய ஆய்வு கட்டுரைகளை சமர்ப்பிக்க உள்ளனர். எனவே இந்த நிகழ்வில் அனைவரும் கலந்து கொண்டு நம்மளுடைய திறன் மேம்பட்டு நம்மளுடைய பொது சுகாதாரத்துறை மென்மேலும் சிறப்புடன் விளங்கிட அனைவரும் சேர்ந்து உறுதியேற்போம். நன்றி.
அனைவருக்கும் வணக்கம். தமிழ்நாடு பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறையின் சார்பாக தொடர்ந்து 4வது ஆண்டாக ஒரு சர்வதேச பொது சுகாதார மாநாடு இந்த ஆண்டு சேலம் மாவட்டத்தில் பெரியார் பல்கலைக்கழகத்தில் இந்த மாதம் செப்டம்பர் 25, 26, 27 தேதிகளில் நடைபெற உள்ளது. இந்த மாநாட்டில் பொது சுகாதாரம் மற்றும் சமூக மருத்துவம் தொடர்பான பல ஆய்வுக் கட்டுரைகள் தேசிய அளவில் மற்றும் மாநில அளவில் உள்ள சிறப்பு நிபுணர்களால் சமர்ப்பிக்கப்பட உள்ளது. மேலும் இம்மாநாட்டில் இளங்கலை மற்றும் முதுகலை பயிலும் மருத்துவக் கல்லூரி மாணவர்கள், குறிப்பாக சமூக மருத்துவம், பொது சுகாதாரம் பயிலும் மாணவர்கள் தங்களுடைய ஆராய்ச்சி கட்டுரைகளை சமர்ப்பிக்க உள்ளார்கள். மேலும் இந்நிகழ்வில் விவாத மேடை பேனல் டிஸ்கஷன் மற்றும் குவிஸ் ப்ரோக்ராம் போன்றவை நடைபெற உள்ளது. எனவே இதில் அனைவரும் கலந்து கொள்ளுமாறு அன்புடன் கேட்டுக்கொள்கிறேன். நன்றி.
அனைவருக்கும் வணக்கம். சேலம் மாவட்டம் பெரியார் யூனிவர்சிட்டியில் நம்ம பொது சுகாதாரத்துறை தரவாக பன்னாட்டு மாநாடு நடைபெற உள்ளது. இந்த மாதம் செப்டம்பர் மாதம் 25, 26, 27 தேதிகளில் நடைபெற உள்ளது. தாங்கள் அனைவருமே இதில் ரெஜிஸ்டர் பண்ணி கண்டிப்பாக இதில் கலந்துக்கணும். இந்த கான்ஃபரன்ஸில் நிறைய பேப்பர் ப்ரெசன்டேஷன்ஸ் ப்ளஸ் இம்பார்ட்டன்ட் டாபிக்ஸ் சம்மந்தமாக நிறைய டிஸ்கஷன்ஸ்லாம் நடக்க போகுது. நிறைய ஸ்பீக்கர்ஸ் இன்டர்நேஷ்னல் ஸ்பீக்கர்ஸ் கலந்துக்கிறாங்க. அவங்களோட வியூ என்னங்கிறது எல்லாமே அதில் இருக்குது. ஸோ அனைவரும் இதில் கலந்துக்கணும்னு அன்போடு வேண்டுகிறேன். நன்றி, வணக்கம்.
அனைவருக்கும் வணக்கம். செப்டம்பர் 25 to 27 ஆகிய 3 நாட்களில் நடைபெறும் பன்னாட்டு பொது சுகாதார மாநாடு சேலத்தில் பெரியார் யூனிவர்சிட்டியில் நடைபெறுகிறது. இதில் பங்கு கொள்வதில் நான் மிகவும் மகிழ்ச்சி அடைகிறேன். ஏனென்றால் தமிழ்நாடு ஹெல்த் குறியீடுகளிலும் மற்றும் பொது சுகாதார சேவைகளிலும் முதன்மையாக விளங்குகிறது. இதை எடுத்துரைப்பதிலும் மேலும் ஆராய்ச்சி மற்றும் அதனுடைய அறிக்கைகளை சமர்ப்பிப்பதிலும் பெரும் மகிழ்ச்சி கொள்கிறோம். இதில் அனைவரும் பங்கு கொண்டு பயனடையுமாறு அன்போடு அனைவரையும் அழைக்கின்றேன். நன்றி.
எல்லோருக்கும் வணக்கம். நம்ம பார்த்தீங்கன்னா DPH ஐகான் கான்ஃபரன்ஸ் இப்போ 4th இயராக நம்ம கண்டக்ட் பண்ணிட்டு இருக்கோம். யூஸ்வலாக நம்ம டிபார்ட்மெண்ட் பார்த்தீங்கன்னா கிரைசிஸ் டிபார்ட்மெண்ட் சொல்லுவோம். ஒரு டெங்குவோ இல்லை ADD அவுட் பிரேக்கோ இல்லை மழை வெள்ளம் காற்று புயல் எதாக இருந்தாலும் நம்ம தான் ஃபஸ்ட்டு முன்னிருந்து நம்ம பண்ணுவோம். பட் அந்த மாதிரி நம்ம பேப்பர்ஸ் போடுறதோ இல்லை லிட்ரேச்சர் இதெல்லாம் பார்த்திங்கன்னா நம்ம கொஞ்சம் பின்தங்கி இருந்தோம். இப்போ இந்த கான்ஃபரன்ஸ் நடத்துறது பார்த்திங்கன்னா நம்ம வருஷம் பார்த்திங்கன்னா நம்ம சைடில்
Good afternoon. Welcome to the afternoon session. Now we call upon our speaker, Mr. Kannadasan, who is the Manager Projects, ECHO India, New Delhi, who's worked as a counselor, TI Tansax Madurai, 2010, as social worker, and PMR Department CMC Vellore, as Head Program, the Spinal Foundation, Delhi, as District Coordinator, REACH, Chennai 2020. As Technical Expert, TI Tansax, TSU, Noida. As Program Manager, the Ganga Foundation, Chennai. He is an expert in leading projects, mentoring teams and engaging with public health systems and civil society. He is here to give an insight in leveraging digital health tools for strengthening health systems of Tamil Nadu.
Thank you. So, good afternoon, everyone. Hope I am audible. So, I would like to start with this quote. So, it was said by Satya Nadella, CEO of Microsoft. Microsoft, we all know that giant in IT infrastructure. And he said that the greatest achievement of technology is not how it changes life, but how it improves it. So that is very much important. That technology has just not changed our life, like it has to improve, as he clearly mentioned that. So I know that it will be very much difficult having a post lunch session, that to have a good lunch. So I don't want to take much time, just 10 minutes I'll complete my presentation, and I take this opportunity to thank DPH sir and DPH officials and the scientific committee for providing this opportunity to me. So since morning we have seen that all the senior officials are here, and they are presenting their data and epidemiology and health financing, lot of things. And when it comes to technology, you can see some junior colleagues like me, and there was another presentation happened, Aishman Bharat Digital Mission. So you can see some young faces in this presentation, because this technology is new to this entire ecosystem. So we are learning this technology, things are here. But though this technology is young, but this technology is very smart. This technology is learning from past and planning for the future. So my topic here is like leveraging the health tools for strengthening health systems, particularly in Tamil Nadu. So first of all, we would like to see how this health evaluation is happening. So 100 years back, so when we want to take a treatment, we have to travel. We have to travel certain place, and otherwise the medical fraternity has to come to the patients and have to treat the ailments or the patients. So later what happened, some technology came in, and we no need to travel. Somewhere we can be there, and we easily connect with the medical fraternity, and we got the treatment, and the knowledge also shared over technology. So everything was smooth, and whatever technology available, 2G, 3G, 5G, smartphones. So whatever is coming up one by one, we are just using these things, and everything slowly, phased manner it was moving. But suddenly what happened, everything stranded, everything stopped. We are clueless what to do, how to move forward because of this one virus called corona. So everything stopped. Whatever the digital things we have, that is not enough to communicate or to disseminate the knowledge what we have, or to treat the needy people. So now totally the globe is changed. Earlier we used to mention before Christ, BC and AD. So now totally it is BC and AC, means after corona and before corona. So a lot of things have changed. So how the future is going to be is like this. So we have to coexist with the technology. So whatever technology may be, it may be AI, it may be a robotics, or any other form of technology, we have to coexist. So when I say coexist, it is not to one layer, it has to penetrate the deep down. From the medical officers to ASA level workers, VHNs, they all have to learn technology. So without technology, it will be very difficult in the future. So what is digital health? So this is the digital health. So any digital equipments, from the smartphone to computers, laptop, whatever, even our wearables now, smart watches are there, smart rings are coming up, smart specs are coming up, anything that helps to leverage the health. So that is all called digital health. So digital health. So I just want to share some of the points about global trends, how it is. So there was a market analysis report is saying there is a huge market for the global health. If you see that 2024 prediction is 288 US billion. It is not only from the private sector, it is kind of both private as well as the government side. So, and they are projecting that it will be go high in 2030. If you see, it is going to be touch billions of dollars, and it is the compound growth of 22% over the years. And currently this North America is very prominent in their digital health market. So what happened in the 73rd World Health Assembly, they also endorsed the global strategy for the digital health, how we have to go into that. And they're saying that digital health definitely will enhance and complement the work, whatever we are doing it and whatever we are going to do. So that is the future health networks also. So digital health will enhance the efficiency. Definitely it is going to be enhanced our efficiency, sustainability of the health systems, and delivering a quality service and affordability also. So they're saying that it definitely strengthens the health promotion. Definitely it will help us to prevent the diseases and management, and especially the rehabilitation components and into the palliative also. So, and they're saying that digital health can improve efficiency and cost effectiveness of care, allowing for new business models. So that in upcoming slides we can see how it will be the delivery of services. So another report of Deloitte, they have recently conducted a research in Western and European countries, and they have come up with the reports like their Deloitte Center for Health Solutions, and they are saying that in 2025 the digital means this year the digital transformation impact is going to be very much high. And they are saying that many health systems still they are relying to the old way of approach, and they are saying that they have to move into the new era, and they have identified the many countries a decade ago they have moved into new they have adopted the health systems, digital systems, and some of the countries are very advanced. They have started using AI, emotional intelligence and everything into their system, and some of the countries slowly coming into the system. So this is the graph how this market is going to be boom. So in another 10 years, so there is a lot of investments are coming in startups and existing technological company. Everything is like another 10 years the market is going to be very high. And this is the Indian trend. It is not only global, it is in India, in our country. So we are also like growing up. In another 10 years the market is like 106 billion US dollars. Okay, so this growth is exponentially coming up. Here are we ready to take it into action? So if you see, the action is not what already is booming up, especially if you see the workforce. So workforce is like there is a lot of challenges are there. So there is a shortage is there, there is upskilling is there. So there is like action, the need is 80%, but the action taken is 67%. I think this morning also the first panel discussion, there was a question came up like how to train the healthcare professionals in the ground level. How can private partnership can engage with the training digital technology? So that question will be answered in this session, because I'm going to tell how an organization collaborate with the DPH and doing the capacity building of healthcare workers, since that is the very major point and it is need of the hour. 88% of workforce needed retraining or capacity building, and only we are equipped with 67% currently we are into that position. Okay, so I think we are all know that what India have taken steps for the digital mission. Yeah, so Ayushman Bharat, we have the detailed session, and we had UWIN, we had CoWIN, Telemanas of everything. And there are some private partners also into the market. They are also providing a lot of health technologies in the even in mobile wearables and all those things. So when it comes to a digital, it is a major thing. It is very much important is governance, because in digital everything in the air. We don't know who is taking what. Data privacy and data is very much important, and globally even WHO also saying that it should be ethically, we have to create the governance system. If you see Europe Union, they have their GDPR law to protect the data, and US HIPAA compliance is there. And like in US also, beyond the HIPAA compliances, they have the state-wise law, that is one Washington's My Health My Data Act, which is covered, which is not into the HIPAA compliance. And whereas India also into it. So recently the Digital Personal and Data Protection Act 2023 is going to be come up, and it is the major highlight in that it is any data violation, any data breach is happened, then the fine is going to be huge. Even if it is done by an individual, the fine is the penalty is going to be in crores. So this is the digital governance what India is planning to do. And the last is DISA, this digital information security in healthcare. It is now in public opinion, and once it will be rolled out very soon. So we know that Tamil Nadu is pioneering using in data and digital things, and so in that lot of things we know that Makkalai Thedi Maruthuvam, in last session also we discussed in detail Makkalai Thedi Maruthuvam, our pygmy system and everything. Along with that, in 2018, DPH graciously accepted our proposal from Echo India using this Echo platform for the capacity building. So I belong to this organization called Echo India. It's based out of a Delhi non-profit organization, providing a digital platform for capacity building and training for the healthcare workers. Healthcare workers means not in the first layer, and it is into the last mile of healthcare workers, including VHNs and ASAs. So this model of capacity building is very replicable model. It is having hub and spokes model, and we are using ABCD model, amplifying the technology with the best case-based practice and data-based evidence. And this is the papers published used by the ECHO model because of the capacity building. So this is there are regularly we are doing our classical training where we invite the people and we have the training and whatever modules we are going to do that. Along with that, now this ECHO model also there, so we can do a hybrid model of training. There are both plus and minuses are there for the online training and that classical mode of training. So ECHO model is very much easily replicability in anywhere you can use it. You just take a laptop and a smartphone is enough to connect with the people for this training. So we use the digital infrastructure called iECHO. iECHO is developed by Echo India and for the video conferencing. So you can use it. It is a web-based, app-based application. So it is easily replicable. Anybody can, smartphone is enough to download this app and then you can use this platform. So it is very much scalability, and there is no geographical barriers for this. Anywhere you can connect with the resource person across India. You can sit to one place and connect globally easily. So what we have done so far in Tamil Nadu is we have implemented 5 major projects based on the state's need. So first program is for the cardiometabolic syndrome. We have selected 5 states, 250 medical officers, and the training is ongoing. We have completed 100 medical officers. The third batch is going on. And the CPHC is very much important program, comprehensive primary healthcare training for the healthcare workers like ASHAs, means ANMs and VHNs we are training. Two phases of CPHC training we have done. First phase in Kallakurichi, second phase is in Madurai, and third phase is going to come again in Kallakurichi. So we are going to take 500 frontline workers. So we are going to take that. And Cancer Care at Bharat project is a 6-year ongoing project where we are training the medical officer under the family care. So it is a new concept for the medical officers, because usually we are in diagnosing and treatment, and this is the training we are giving along with the Cancer Institute Adayar. So how to cater the family needs when they are undergoing a terminal ill. So yeah, sorry. This is a women's health program. Again, we have focused on women's health. So we have completed this training program. So all the training is virtual mode, and we have reached to the ground level, and they are our board of trustees, backbone of our organization. They are helping us to move forward. Thank you.
Thank you, sir. That was a very informative session. Now we cordially invite our additional director. Sir, stay back, sir. We invite our additional director, Madam Vijay Lakshmi, onto the dais to felicitate our speaker. Now our Vijay Lakshmi Madam will felicitate Mr. Kannadasan, Echo India, New Delhi. Thank you, ma'am. Now going to the next session about evidence-based protocols, building blocks for resilient NCD care systems. We warmly welcome Dr. Amol Vankate, who is a National Professional Officer, Cardiovascular Disease in WHO India Country Office. He is a public health expert with more than 20 years of experience in various organizations. He has done field epidemiology training program, fellowship from NIE, ICMR, and CDC. He has also published 7 scientific papers in reputed journals. Welcome, sir.
Respected Dr. Soma Sundaran, sir, Dr. Gerard, dignitaries, experts, friends and colleagues. It's always difficult to present a topic in the afternoon, and better to have one screen at the mess hall also. This will increase participation by 3 times. So thank you for being here in the hall. So my presentation is on evidence-based protocol. So you guys might be working in hospitals, PHCs, health and wellness centers. So NCD is not an independent vertical. So it will influence all the health workers. Can we go to the next slide? So Dr. Gerard in pre-lunch session has given a pretext regarding what is the burden of NCD. So like we are in country like India, sometimes back it was 63% of the death due to NCD, but some data suggests that now NCD is responsible for almost 70% of the death. If you look at the first sustainable development goal, 3.4, which is directly related to NCDs, so that says that by 2030, we have to reduce premature mortality by 1/3 through prevention and treatment, and mental health and well-being is part of that. So a small question to audience, what do you feel, whether we will be able to achieve this SDG target or not? Yes or no? Any answer? So most probably we may not be able to achieve this target. So there are some reasons, we'll be discussing that also. So there are certain other global action plan targets which are mentioned and which has been accepted by many countries. One of them is 25% relative reduction in risk of premature mortality. 80% of the individuals in public and private facilities should have access to affordable technology and medicine. WHO also promotes protocol-based treatment. We also encourage member states and countries to adopt drug therapy, which will help in treatment control and maintenance of patient on treatment. Next slide. So I happen to go through this document. Most of you might be aware of this document. This is the Tamil Nadu State Health Policy, and which has endorsed the global target and the SDG goal, which were customized for India. And this document clearly emphasizes on basic components and the topic which I am presenting here, that is early detection and treatment of NCDs, as well as regular follow-up and improving control rate. Next slide. So we were discussing about SDG, and whether we'll be achieving or not. But if you look at our country, when we look at the prevalence and the control rate, so globally we can say the control rate in the NCD programs is almost around 50%. But in India, we are barely touching 17%. So although we have been enmassing so many patients, but the control rate or the control of patient basic parameters is not achieved. So all this patient, like almost 83% of the patient, are exposed to complications like stroke, STEMI, kidney diseases, and that's how we are not contributing to prevention of deaths among NCD. Next. So what is the mean age of premature death in India because of ischemic heart disease? Can you push the tab? Yeah. Next. Yeah. So 55.6 years. So this is much lesser than the global target. So in India, NCDs, ischemic heart disease, complications of hypertension and diabetes, they arrive early. So definitely we need to intervene as early as possible. Next slide. So how to address this particular issue regarding treatment management, to be very specific, sticking to the treatment protocol. So WHO has developed technical package which has major components, which includes next. So these are the major components, HEARTS package, which includes healthy lifestyle counseling. The most one which we are discussing right now is evidence-based treatment protocol. Also, it is important to have access to medicine and technology. Then risk-based management of, for CVD. Then engaging all staff in care and management of hypertension, diabetes complication, that is treatment-based care. And we were discussing about the digital technology. So it is very important to have a system of monitoring, and digital technology helps a lot in developing those system of monitoring. So why, coming back to the topic, why we should have evidence-based protocol. So whenever, when we think of evidence-based protocol, so protocols are, they are based on certain evidence generated over a period of time. So it helps in standardization of treatment. So all patients get similar treatment, whether it is in village, rural, or private or urban areas. It also helps in improving the patient outcome. Since the protocols are simplified, it can be implemented at the lowest healthcare facilities. Equity is also taken care of, whether it is rural, urban, or tribal areas. All the patient gets a similar quality of care. So the issues of under treatment or over treatment can be avoided. Since we have limited numbers of drug patients, parameters are standardized. It also helps in monitoring and accountability of the system. And when we compare with the more than 250 drugs which are there for treatment, and what we have in a protocol are just limited numbers of drugs. So this also helps in cost saving, cost effectiveness, reduce the cost of treatment among patients. So usually in a public domain, we usually have a guidelines, and we also have a standard protocol. So sometimes in a public health system, what happens, these guidelines are distributed even to the peripheral health system. But there is a clear demarcation between what is a guideline and a standard protocol. So guidelines summarizes all the recommendation. It is a comprehensive document. It helps in clinical judgment. It is used by policy makers as well as specialists to frame policies as well as to frame the protocol. So example is World Hypertension, WHO hypertension guidelines, which has been used for states and other countries to formulate their protocol. While protocol are step-by-step instruction, they are very specific, standardized, based on evidence, which can be used at the PHC level. They are well formulated, rigid, so uniformity is maintained in using those protocols. So examples are WHO Hypertension Management Protocol, HEART strategy, and the protocols which we use in our state. So these are some of the examples of standard treatment protocol. So this is how guidelines and standard protocol differs. And in framing those guidelines and protocols, usually all these documents are used. I'm not going into details of that. So there are certain guidelines such as JNC 7, American Heart Association guidelines. These are used as a reference for development of protocol. There are many studies which have supported standardized hypertension and diabetes protocol, that how it has improved the system of management, patient care and management. So in India also, India Hypertension Control Initiative project was implemented in 2018, and the standard treatment protocol was the first time it was introduced in India, and this has shown great results. It has helped in improvement of patient treatment, quality of care, then management of drugs, supply chain management of drugs. And in a long run, it has helped system in improving the care and management of hypertension and treatment. And simultaneously, these protocols have been also adopted in the national program. How WHO is supporting? So WHO supports in facilitates in development of this protocol, working in conjunction with the states. WHO staff also helps in capacity building. They also help in guidance on drug forecasting and manager. Like in Tamil Nadu, we have Dr. Gopinath and Dr. Emmanuel. They are part of the WHO team. They supports the state NCD cell in improving the quality of care of NCD program implementation. So in India, currently, majority of the states have adopted hypertension and treatment protocol. This protocol, which we started developing way back since 2018, so they have all the new evidence, but over a period of time, there are certain new evidence which have been generated by studies and various things. So most of the states like Jammu, Kashmir, Assam, Telangana, West Bengal, they have modified that protocol, and we'll be going shortly through what are these evidences which we can include in the protocol. So this is the Tamil Nadu hypertension protocol. If you see, it has most of the element or most of the evidence included in the protocol. Example, we use drugs like CCB, ARBs and diuretics, which have been recommended by many evidences. They are safer drug, they have a good bioavailability, they can use once in a day. Apart from that, we have a cutoff guideline of 140/90. So that has also helped in standardization of the control rate or how we can monitor the patient continuation. So some of the protocols, some of the evidence are already there in the protocol. We'll see what are the new evidence which can be included. Similarly, if you look at the diabetes protocol, many of the evidences like what is the cutoff point, drugs to be included are part of the protocol. So what are the new recommendations which we can include in the protocol? To begin with, so there are new evidence which suggests that inclusion of statin can prevent mortality in long term. So, and use of statin doesn't require monitoring of cholesterol over a period of time. So some of the suggestions are for hypertension, like patient with hypertension and diabetes should be started on statin as early as possible. Patient who are smokers with hypertension and above 50 years, should be provided with statin. For diabetes, all patients above 40 years should be given statin. So there are evidences which suggest that in India, infectious ischemic heart disease, they arrive early. So it's better to treat such patient with statin. Statins are safer. Studies have shown that the side effects are less compared to what was evident. So definitely it has a benefit in reducing the mortality by almost 15%. So although there are certain risks associated, but when we compare in a programmatic setting, the risks due to statins are less. Then this is how statin can be included. Like we can include statin along with amlodipine since majority of the patient may require statin on a longer run. So protocol modification can be taken up by states like Tamil Nadu to include statin. So other recommendations are like in diabetes, this is the World Global Diabetes Strategy which has been adopted so that majority of the patients should receive correct treatment. And it has been seen that the diabetes control is less than 23%, statin use is lesser than that. But when we look at the newer guidelines, like drugs like SGLT2 can be also included in the protocol. So this SGLT2, like drugs like dapagliflozin can replace glimepiride. And the evidence what we have is Drugs like SGLT2, example dapagliflozin or semaglutide, they help in reducing heart failure, mortality due to cardiovascular incidences. They have a protective effect on kidney, weight loss, and also has shown that reduction of mortality is beneficial when we use SGLT2 and GLP drugs. Right now we use metformin and glimepiride. So glimepiride can be replaced by SGLT2 and GLP-1 drugs. So this is a Kepler-Mayer curve which shows that the survival rate by using SGLT2 is better than sulfonylureas like glimepiride. So definitely this is a huge recommendation why SGLT2 can be used. The third recommendation is fixed drug combinations. Like we usually have generic drug in our system, but if fixed drug combination or combinations of 2 or 3 medicines is available in the system, it simplifies the regime, it reduces side effects, it reduces the number of episodes when patients are having treatment or taking the treatment, and it also will reduce the cost over a long run. So fixed drug combinations are the third recommendations for the treatment protocol. If you look at the newer updates like WHO Essential Medicine list have included SGLT2, GLP drugs, as well as previously in 2023 thiazide groups were also included in the WHO Essential Drug list. If you look at the Tamil Nadu EDL list, we have almost majority of the drugs. Rovastatin 5 milligram tablets are not there, but FDCs are not yet part of the EDL list, which we if recommended, I think that would be a good addition if FDC was supposed to be included in the protocol. So suggested approaches based on the newer evidence, inclusion of statin for hypertension and diabetes protocol. For diabetes, inclusion of SGLT2 and GLP-1 drugs can be included in the protocol. Definitely fixed drug combination is another area where we may have to work. And all these drugs, if they are included in the EDL, definitely they can be part of the protocol. So it's very important that to build a resilient health system which is not affected by ups and downs, it's very important to have a standardized treatment protocol. Apart from standardized treatment protocol, it is very important to have systems, a digital health system which tracks patient registration, patient control. Control rate can be a good addition to the MTM software, which will help us to understand how many patients are taking treatment from government, how many of them are controlled, how many are taking from private, and what is the control rate among them. And the other aspects can be inclusion like multi-sectoral action plan. This is another area where this will help in expanding the coverage of the treatment as well as our control over how many patients are taking treatment. Out of that, how many are under control, and in the long run will reduce the mortality among hypertension and diabetes. So thank you. I'm Dr. Amol, I'm National Professional Officer, and I'll be happy to answer any queries if you have. Sorry, I have to run through the slide because of the time limit. If any queries, you can please share with us.
Thank you, Amol sir. I know Amol for the past 2 years. He is a very hard working person, right? We should adopt your advice. நம்ம பார்த்தோம்னா ப்ரோட்டோகால் கைட்லைன்ஸ் சொன்னார் இல்லையா, ப்ரோட்டோகால் வேறு, கைட்லைன்ஸ் வேறு, ஜிஓ வேறு, டெய்லி நம்மளா ஒரு ஓன் கைட்லைன்ஸ், சம்படிஸ் ப்ரொடியூஸ் ஓன் கைட்லைன்ஸ் வேறு. ஸோ வி ஆர் ஆல்ரெடி புட் அன் சம் 2 protocol. We will think convene next meeting. So statin 40 milligram available in Tamil Nadu, but 10 milligram 5 milligram not available. So statin 40 milligram may be added into the hypertensive patients group. We will take in that. And next one drug is not in EL list, right?
Right.
We are write a letter. We are planned to write a letter to TNMSC. We will get into touch with. Thank you.
Thank you for extending that support. We'll work on this thing. Thank you. Yeah.
Please stay back, sir. Now we warmly welcome our Joint Director NCD, Dr. Krishnaraj sir, onto the dais to felicitate our speaker. Dr. Amul Wankate, National Professional Officer, WHO. WHO. Thank you, sir. Now we warmly welcome Mrs. J. Kamini Charles, who is a Vice Principal and HOD at Sri Gokulam College of Nursing. She has published 8 research articles in the Nursing Journal of India and Nightingale's Nursing Times and 3 papers. Several community health services such as conducting camps, surveys and counseling. She is here to talk about nurturing resilience, the unseen pillar strength in the health profession.
A early good evening to all of you present here. So I come from Sri Gokulam College of Nursing. I bring greetings from Sri Gokulam Hospital and College of Nursing. So I feel so much delighted to be as a part of this DPH Icon 2025. As soon as I received the call from the official, I was so happy about the topic what they have chosen, resilient public health system, because I am teaching to my nursing students for more than 2.5 decades. More than 25 years I am teaching about the community health nursing to the students. So I am very much happy to be a part of this international conference. So coming to the topic, actually this has to be presented yesterday itself since I was busy with my examination, and I take apology from all of you that I have come today to present this topic. So the topic given to me is, it is nurturing resilience, the unseen pillar of strength in health profession. So the topic itself is, says that the healthcare professionals are so much burdened with lot of responsibilities, roles. They have lot of extended roles, expanded roles, everything, and they are so much with the burnout state. So where they should learn or they should practice with the resilience. So today we are going to see with very few slides, as they have already intimated that I should present only for 10 minutes. So I will be finishing within 10 minutes whatever I have prepared for you. So this is the outline what I am going to tell you. So here we know already what is meant by the resilient and how it has to be nurtured, and what are the challenges and why this resilience is essential for the healthcare professionals, and what are the strategies for nurturing the resilience, and what are the organizational strategies, and what is meant by ripple effect we will see, and finally we will be concluding with the topic. So coming here, the terminology, the resilience. So you all would have learned by this time, since yesterday from pre-conference, you are hearing the term resilience and all that. It gives you the meaning of bounce back. Okay, so any item which is just, whether you compress it or you crush it or something like that, when it comes back to its position, we call it that as the resilient. The same way the healthcare professionals, you know, as I told you in the beginning of my talk, like they are compressed with lot of roles and responsibilities, where they are so much impressed, they are so much crushed, and so many things happens. So they have to bounce back here. So that is, here we term it as the resilience. So the bouncing back happens for all the difficulties, from all the stress levels, and they have to adapt, and they have to come up with all their challenges. That is called the resilience. The second term you must learn here is, it is the nurturing resilience. So it is very, very crucial for the healthcare people. Okay, so it is we can talk on the stage and go, but to adopt anything is very, very difficult. So here we need to cope up with the stress and we need to maintain our well-being. That is very important because we are overloaded with all our works and everything. And finally, what happened, our mental well-being and our emotional well-being is so much affected. So finally, we ourselves will end up with all the problems. The previous speakers were speaking on so many non-communicable diseases. As we know, we have moved from communicable to non-communicable diseases. Nowadays, it is the biggest health problems which are seen in all the areas. So we may end up with those problems when our mental and the emotional well-being are not well maintained. And next, it is about the crucial challenge. So what is the challenges? We have long-term works. Okay, either when we are working in the hospital or when we are working in the healthcare field, we are working for long hours and we have lot of emotional strain is there and we have high stakes and we have a consistent evolution of many things. So doctors and medical persons are with the medicine and we are with our nursing protocols and other things. So we are with the consistent evolution where we have to take up lot of challenges. In the future slides, we'll be seeing about what are the ways where we can find the remedial measures for all these challenges. And why resilience is essential for the healthcare professional. So here are some of the problems as I have told you beginning. The first one is the burnout. So how are we going to combat the burnout? Okay, so if we are going to maintain with the same burnout, see what happens to our job performance, what happens to our the performance, what we are going to do. We are going to have some errors, whether we are following the medical field or in the nursing field or any other field, we are going to have some errors we have. So when we are going to combat this burnout, then only we will be having the increase in our efficiency and we can excel in our work. And the second one is it is going to improve the performance. Okay, so high resilience, the people, those who are able to adopt resilience and they are able to have high performance in their field. So when we are happy to see some people, no, they will be continuously giving the good outcomes and also we will be very happy how it is possible only for them. So we must know where we are lacking. So these are all some of the small things where we will be lacking. We ourselves should encourage, or the self-motivation must be there where we can have or where we can reduce our burnout and we can improve our performance. And the next one is it is going to enhance the patient care. So if it is in the hospital scenario, it is going to enhance the patient care, or otherwise in the public health system, it is going to give a good environment to the people, those who are living in the urban community and in the rural community. So this is very important. So as I told you, taking care of our own mental and the emotional well-being is very important. Always don't stick on to the protocols only, or don't stick on to the targets what you have. Timely you have to think on yourself to take care of your emotional and the mental well-being. And the last one is it is supporting the well-being. So whatever the stressful, whatever the trauma we have, everything we have to manage ourselves. We have to find out how we can overcome all this stress and trauma so that we will be able to have the good well-being. And some of the strategies we are going to follow how to nurture this resilience. We can call it as a path to resilience. The first one is the self-care. So we have lot of choices are there. We can come out. Our working time is from this time to this time. Of course, we are working beyond that also. But you have to make up the time for yourself to think on you, like from the mindful practice to the physical exercise. You have to plan something so that periodically you regenerate your physical health, you regenerate your mental health so that you are not ending up with the previous told problems. So that's how the self-care rituals plays a very important role. And the second one is it is the emotional intelligence. So we must understand what is the problem, how it can be sorted out, how it has to. So the main thing here is understanding and managing one's emotion is the foundation of the resilience. So try to understand yourself. You sit for some time, you spend time for yourself and you try to have this emotional intelligence so that you will have a good well-being. And the third one is the support networks. Of course, we are all moving with all type of people from the high level to the till the grassroots level. So we can find the time with spending with colleagues or with our family members, or once in a way you can go out of your work area so that you will have a very pleasant time, so that all your burdens will be coming down and you can again restart your work with the fresh energy. So that is the main role of the supportive networks. And the fourth one is, it is the adaptive mindset. So always we must have a growth mindset. Okay, so we have to think on next what we are supposed to achieve everything, but the growth mindset also is very essential. The same way you have to take care of your well-being also. So the adaptive mindset is very essential. So here the major role played is by attitude. So the attitude which will later on convert into behavior, and the behavior will be later on converted into action, and finally you will be having a successful end. Then the next one is, it is about the setting boundaries. So we need to have a boundary, setting clear boundaries between your job and your family. So the job is different and your family is different. Have a clear boundary so that you will be able to manage both the things successfully. And what is the organization role or strategies which can be given for building up the resilience is, the first one is training. So wherever we are working, so we have heard about lot of trainings in the previous sessions. So there are many online trainings and offline trainings are there, where people have to be put up with all such type of trainings and they can be updated with all that. And the supportive culture, have good supportive system both in the work area as well as in the family, and we will have a good system where we will be able to do both the areas in a good way. And the third one is, it is the work-life balance. So try to balance yourself. Of course, we are put up with lot of work and we have the life on the other side. So we have to balance both work and the life. So this is called as the ripple effect. Okay, so what is this ripple effect? Of course, we are all doing great things in our own areas, but still I wanted to tell, we are reacting to so many unexpected situations. Sometimes we need to communicate empathetically to the patients and the relatives and their families, and we need to adopt everything, but in spite we have to have our own well-being also, and furthermore we need to have the power to inspire the patients, their family and their community. So that's how, when we are going to develop this is called as the ripple effect. And to conclude my topic, now this is the time for a calling of recognition. Here lot of legendaries are there, they are doing excellent job, and to hear about in the DPH and in the public health, they are doing so much tremendous work and wonderful job. Now I request here, I think the students will be present here. I think all the students, those who are present here, to request you to give a round of applause to all our dignitaries, those who are doing a great job. Thank you so much.
Thank you, ma'am. Thank you for sharing your valuable insights. Now we welcome our Joint Director, MCH, Dr. Nirmal Sen sir, to felicitate ma'am with a memento. Thank you, sir. Moving on to the next session, it's a plenary session on improving community processes and health service delivery to achieve better health outcomes. DPH Icon 2025 cordially invites Mr. Devesh Verma sir, Head of Ola Foundation, to the dais.
An AI-powered decision support tool.
Welcome you, sir.
Just hang on. Good afternoon. First of all, I want to thank DPICon for having us here. It's a privilege to be here and talk about what we at Ola Foundation have been doing in the district of Krishnagiri. Before I start, I just wanted to go back and touch upon what DPH Director Dr. Somasundaram sir had said. He spoke about resilience, and I think when we talk about resilience, it also comes with various dimensions. Resilience also means that is the system aware enough about its own self? Am I not? Is this audible? Sorry, just doing a quick sound check. Am I audible? Am I audible in the back? Let's do a quick presence check. If you can hear me, raise your right hand if you are left-handed. All right, it's a close enough receptiveness, I guess. Cool. So, as I was saying that I wanted to touch upon resilience because one is the theme, and second, in order for us to look at resilience, we have to look at from both the sides, as to the supply side and demand side. We started working in the district of Krishnagiri almost in the last year and a half. We have had some good support from the DM sir, from Ramesh sir, who helps us in many ways across the 6 blocks of Krishnagiri that we are working in right now. What we want to present today is not just from one aspect of the health system, but I think for us it's important to see where the supply and demand side converge, because it's important to see when these two sides meet together, that's where music happens. What I want to start with is a short video of a program that we run in the district of Krishnagiri across 6 blocks. The idea is to bring together both the supply and demand side. The idea is to see how can we create a community-centered solution which is owned by the community, and how empowering those 2 or 3 critical community processes, typically focusing on Village Health Nutrition Day and Patient Support Group, we can leverage a lot of community movement across the spectrum of 6 blocks. May I please have the video?
வாருங்கள் பயன்பெறுங்கள். அன்பார்ந்த மக்களே, உங்களுக்கு வணக்கம். நாங்கள் ஓலா ஃபவுண்டேஷனில் இருந்து வருகிறோம். 18 முதல் 42 வயதுக்கு உள்ள பெண்களுக்கு ஹீமோகுளோபின் பரிசோதனை, 100 வயதுக்கு வணக்கம். என்னோட பேர் பிரியங்கா. நான் ஓலா ஃபவுண்டேஷனில் 2024 மார்ச் மந்த்லேருந்து தளி பிளாக்ல ஒர்க் பண்ணிட்டு இருக்கேன். ஸோ எங்களோட ஒர்க் மோஸ்ட்லி பார்த்தீங்கன்னா ஃப்ரண்ட்லைன் ஒர்க்கர்ஸ், அது விஹெச்என், எம்எல்ஹெச்பி அவங்க கூட தான் இருக்கும்.
என்னோட பேர் அமரேஷ். நான் தளி பிளாக்ல ஃபீல்டு அசோசியேட்டாக ஒர்க் பண்ணிருக்கேன். நம்ம மோட்டோ ஆரோக்கியம் எம்எல்ஹெச்பி, டபிள்யூஹெச்பி, ஆசா ஒர்க்கர் இவங்க கூட சேர்ந்து தான் நம்ம அரௌண்ட் 120 வில்லேஜஸ் கவர் பண்ணி ஒர்க் பண்ணிருக்கோம்.
நாங்கள் இது ஹில்ஸ் ஏரியா. இங்கே ரொம்ப வசதியெல்லாம் கம்மி, பஸ் வசதியெல்லாம் கிடையாது.
இதுக்கு முன்னாடி நாங்கள் லிஃப்ட் கேட்டு போவோம். இந்த சார் 1 இயராக வந்ததுனால கொஞ்சம் ரொம்ப ಹೆಲ್ಪ್ಫುಲ್ಲಾಗಿ இருக்குது ಎங்களுக்கு.
ಮಕ್ಕಳಿಗೆ ಇಂಜೆಕ್ಷನ್ ಎಲ್ಲ ಹಾಕ್ಸೋದು ನಮ್ಮ ಕೆಲಸ. ಹಿಂಗೆ ಮಾಡಬೇಕಾದ್ರೆ ನಮ್ಮ ಜೊತೆಯಲ್ಲಿ ಓಲೋ ஃபவுண்டேஷன் சார் ನಾವು ಕೆಲಸ ಮಾಡೋವಾಗ ಬರ್ತಾರೆ அவரும்.
ஸோ இப்போ என்னென்னா எங்ககிட்ட மோட்டோ ஆரோக்கிய கிட் இருக்குது. ஸோ மோஸ்ட்லி நாங்கள் ஃப்ரண்ட்லைன் ஒர்க்கர்ஸ் கூட தான் போயிட்டு ஸ்க்ரீனிங்லாம் பண்ணுவோம். அப்போ எங்கள் மோட்டோ ஆரோக்கிய கிட்டை வச்சு நாங்கள் பிபி பார்ப்போம், சுகர் பார்ப்போம், ஹீமோக்ளோபின், யூரின் ஆல்பமின், டெம்பரேச்சர் செக் பண்ணுவோம், ஹைட்டு, வெயிட்டு.
எங்ககிட்ட இருக்கிற மெட்டீரியல் வச்சு நாங்களும் பார்ப்போம். நாங்கள் பிபி பார்த்தோம்னா அவங்க ஒரு சைடு அவங்களும் சுகர் பார்ப்பாங்க.
எப்பயுமே வீக்லி விஹெச்என் நடத்துவோம். ஓலா ஃபவுண்டேஷனில்
மோட்டோ ஆரோக்கியம் வந்ததுக்கப்புறம் அம்பரீஷ் எங்கள் கூட வந்து எல்லா விஷயத்துலையுமே கலந்துக்குவார்.
ஓலா ஃபவுண்டேஷன் மோட்டோ ஆரோக்கியம் அவங்க வந்ததுக்கு அப்புறம் வந்துட்டு பார்த்தீங்கன்னா நிறைய கேஸ் எங்களால் வந்து ஐடென்டிஃபை பண்ண முடியுது. இவங்க வரும்போது மலையில் இருக்கிற மக்கள் எங்கே வேலைக்கு போயிருந்தாலும் அந்த இடத்துக்கே போயிட்டு எங்களால் பார்க்க முடியுது.
மோட்டோ ஆரோக்கியத்தினால வந்து நிறைய பேருக்கு வந்து நியூ என்சிடி வந்து ஃபாலோக்காக நிறைய யூஸ்ஃபுல்லாக இருக்குது.
பீப்புளோட டோர் ஸ்டெப்பில் நாங்கள் ப்ரொவைட் பண்ணுறோம். இதனால் அந்த மக்கள் எப்படி பண்ணுவாங்கன்னா அவங்களுக்கு டிரான்ஸ்போர்ட்டேஷன் இருக்காது. ஸோ இந்த பேசிக் ஹைட் வெயிட் கூட அவங்களால மெஷர் பண்ணிக்க முடியாது. ஸோ இந்த மாதிரி சர்வீஸ் பண்ணுறதுல நாங்களும் ஒரு பார்ட் ஆஃப் இருக்கிறது ரொம்ப ஹாப்பியாக இருக்குது.
Thank you. Can I go to the slides? Right. So that vehicle goes into all the remote areas across 6 blocks in Krishnagiri. We have seen some amazing uptake in terms of people coming and getting themselves screened. When we talk about health systems, the 3 prominent things we always keep hearing is accessibility, availability, and affordability. And at times you also think of, how systems are comprehensive, continuous, and complete. What gets missed when we talk about accessibility and availability is the aspect of mobility. Now that applies on both the sides, from a supply side and the demand side as well. How soon a person can reach to the health facility and how soon a person from the supply side or provider can reach to the person at the village level who is trying to seek help for. Now that's the gap which Moto Arogam solves for. But our topic is slightly broader. We want to talk about how various community processes, specifically 2 as I mentioned, has helped us in getting the community start taking ownership of their health. Case in point, VHNDs and PSGs. But a short snapshot on who we are. So we are Ola Foundation. We are 9 years old. We have been working in this space of public health, livelihoods, education, and culture and heritage. Our focus district is the district of Krishnagiri, which we want to build as the model district. Presently presented in 6 blocks right now out of 10. That's the district snapshot. When we first started looking at Krishnagiri as a district, while there is a lot that needs to happen from a health point of view, Krishnagiri also offered a lot of good things to us as well. We started thinking about what's the best approach to solve the health problems. What are the models that have been established? Some worked, some have not worked. Our approach in looking at any health problem from a public health point of view was to see how soon we can give it back to the community or build a model which is built around the community processes. Hence, that's the framework we came up with. We said that we are going to focus on 4 things. Community remains the center of our universe. Then we look at what is the level of literacy and awareness that we need to create. Third, we need to also understand what are the schemes that is there an lack of uptake of schemes. But eventually, what all of it should lead to, engaging the community, making them aware, and giving them enough knowledge of schemes, it should lead them towards self-care. That's where we want to be. We want to be in a system where people own health, people seek health, and people are not kept away from health. Now, in order to do that, there are a lot of interventions that they are listed down there. But these are key interventions which fall under 2 primary community processes. One is VHND or Village Health Nutrition Day, and the second is a patient support group. Now, you will also see an intervention called Samuga Iyakam. The objective is to create a community movement around everything that we do in the village. The more we involve the community, the better it is. Give them enough for them to start owning their own health and the demands for their own health. That's how the 2 systems will start acting. Typically, in a perfect world, no foundation should come and help the people. They should be aware enough to take care of health, and the system should support what they are. Our job is to be the catalyst. Our job is to be the nudge creators. Our job is to be the complementers of what the government is doing. And that's exactly our story. Now, when we started looking at what we need to do in Krishnagiri, we started with what can we do with the community. Then we narrowed it down to what can we do in women's health and maternal health. And then we narrowed it down to that, can we look at high-risk pregnancies, because there are a lot of high-risk pregnancy cases, but the contributing factor for high-risk cases will be covered or will get covered under VHND. Hence we chose HRP as a focus on maternal health. We chose our demonstration in 6 blocks, and we said that we will keep doing VHND and we'll keep doing patient support group to get to our objective of achieving women's health and well-being. Now, what does that entail? It entails working on these 6 or 7 key specific interventions and not looking at what VHND traditionally offers, which are more than 17, 18 interventions. We said we'll focus on these, and once we start focusing on these, what does this give us? And there is also an element, one element I forgot to talk about. There is also an element of tech. We've been hearing a lot of AI, we've been hearing a lot of tech and digital today. What we will present today, or I will present today during the course of this presentation, is the tool that we feel which is needed by the frontline health workers. It is not 100% decision support, but its ability to decide and act upon. So it's an action assist tool as well. It's an AI-enabled tool which we will present, but that's called Saheli. Now, what is the nudge that we created? The nudges were VHND and PSG. We added 2 more nudges. We added the Moto Aragyam project, as you saw, and you guys can visit outside. There is a stall, you can view the vehicle, leave your comments. Would love to hear from you how you feel, perceive about the program. And then the community gatherings. What we started doing every 15 days is started bringing community. If we are missing out men in the community, we will do evening sessions. If we are missing out adults and girls, which are missed out at majority of the VHNDs, we will go into the community through Moto Aragyam and we will engage there. We will also engage them in the school-based program as well. So the idea is, how do we saturate the population to achieve what we want to achieve from a health awareness point of view and well-being point of view. Now these nudges basically cover these 6 interventions which I touched upon earlier, which give us a very holistic coverage, ending with counseling and referral, which gets missed out because we don't see those people. Now, what does this give us as an output? The nudge gives us an output from a demand side point of view of increased service uptake, of increased presence. Our presence, what we have seen in Krishnagiri in every VHND now has gone from very few to 25 to 30 to 35 people and women coming into these VHNDs. That's a good sort of output from a demand side point of view. But if I look at the supply side, because these 2 sides are needed to build resilience, we did work with the district health officials and especially Dr. Ramesh to start retraining of the health workforce. That has helped us in reinstating the whole SOPs around VHNDs. That has also helped us in putting in a lot of rigor in patient support group as well, which brings in again a lot of people to these 2 sessions. What is the ultimate idea? The ultimate idea is that a message that has to be repeated multiple times, starting from a Monday session at a HSC, which is AN clinic, to a Saturday session, which could be a PSG session. How frequently we repeat the same message over and over again, it starts getting ingrained in the community. They start reacting to the health messages. And that's a win then. It's a time-taking process, I get it, but then that's how you win community, by giving them the right messages. Leading to what I said as nudges, eventually where we want to be. Where we want to be in these 6 blocks, maybe by the next 2 years, is to achieve certain outcomes which are listed here. I'm not going to be reading them, but those are the eventual outcomes that I want to achieve, or I want us as a foundation to achieve for the district when we set it up as a model district. Now, these are both supply and demand side activities, which are the nudges which we have created. In order to do this, like I said, I wanted to reiterate, when we looked at VHND and PSG, we said we will look at 6 key interventions of VHND. And when we look at PSG, beyond what happens on NCD, these are the folks who come to PSGs are senior citizens, are citizens or people who are either seniors in the house, who have the ability to influence the topics or discussions around health in the household. So what is the message we want to give them around while we are doing a patient support group. Can early breastfeeding be a message? Absolutely. Can adolescent health be a message? Absolutely. Can family planning be a message? Absolutely. So like I said, finding the opportunities or the right opportunities to solve for is what we are trying to do in Krishnagiri. And we are not trying to reinvent anything. We are trying to just put rigor to what exists. We are trying to complement in terms of achieving those goals, which the district, in our belief, we feel that Krishnagiri should become a model district in the next year and a half or two. And that's what our goal is. But there is some journey ahead where we have to go to. That's one intervention which we have been testing out right now. We've created one Nutri Garden in the community. We are now trying to create dietary diversity in the community. The idea is that we will promote kitchen gardens and we will create barter system at the community garden for them to increase the uptake of various dietary practices. Now, just a quick snapshot of why VHND and why PSG. With so many sessions that have happened in the last 1.5 years, VHND gives us the ability to become hyper-local. It's one of those platforms which has been least exploited, but which needs to be overexploited. Similarly, a patient support group is also a platform which needs to be overexploited. There is a lot of peer support. It has to be hyper-local. Unless we not think of being hyper-local, we will not be able to do that. But what is the loop back? Can we link PSGs back to VHNDs and tell people to bring their family or their daughters and daughter-in-laws to VHND? That's also how you improve the messaging. And that's how you improve people's ability to own their health, which we have seen. Now that's for the people's part, which is the demand side. What I want to also talk about, the program that we have been running for the last 8 months has seen a lot of uptake. This program also gets associated with a technology system which I want to touch upon quickly. That program is called Saheli. You can also see the live demo of Saheli outside if you visit our booth. But here's a short video of Saheli that I want to play, which will give you the ability to understand how it helps the health workers with actionable insights. It is not just a decision support. It solves for one critical problem with the health workers is the ability to act on. Most of them are trained to be data collectors. They need to be nudged. That is a system which nudges them to act upon. Can we play the video, please?
Ola Foundation presents Saheli, an AI-powered decision support tool. Saheli enables frontline health workers to carry out early screening and detection of high-risk factors like anemia and other ailments. With this tool, health workers can conduct door-to-door screenings. Equipped with a tablet, the health worker can visit each patient and use the AI-powered context-aware decision support system. The health worker begins by entering the patient's details, asking her age, pregnancy status, and dietary preferences. The system then prompts the health worker to observe physical signs such as pale inner eyelids, tongue, or nails, and to record any other symptoms like dizziness, fatigue, or rapid heartbeat. Next, Saheli guides the health worker to note vital signs, check compliance with iron folic acid tablets, and enter the gestational age. All of these details are processed by Saheli's AI engine, which is trained on National Health Mission and ICMR protocols. Using advanced retrieval systems, the engine interprets the inputs and provides context-aware recommendations, which the health worker uses to counsel the patient on clinical advice, dietary guidance, lifestyle changes, and medication adherence. If required, it also suggests referrals to higher healthcare education facilities and schedules follow-up visits. Saheli further supports two-way interaction, enabling the pregnant mother to ask questions and receive trusted protocol-driven guidance instantly. In this way, Saheli streamlines the entire screening process, empowers health workers with actionable insights, and ensures pregnant mothers receive the right care at the right time.
That's what Saheli does. It makes their job a lot easier for them to act upon. Now, what we have seen is if we apply these two things, one is the ability to access remote areas and ability to give them the right appropriate technology to solve for, it can create wonders in the community. There is a lot of uptake that happens. Where do we see ourselves in the next year? This is where we want to be. We build on the strengths that we see, which the people have provided, which is leveraging VHND and PSG. but we also want to get deeper into the tribal community. That's where the issues of access and availability is. That's where the issue of sickle cell anemia is. We want to get into that as well. And then we really want to look at what is the technology. The key focus from here on and to the next year would be, how can we saturate the population? The more we saturate the population, the better we know about the population. And then it becomes easier for us to act on what we have gathered as insights. So with resilience in mind, bringing these two systems together is what we at OLA Foundation have been doing for the last year and a half. Please do visit the stall and learn about the program. Please do reach out, more than happy to collaborate as well, because we, and I honestly believe that a single organization or a single intervention cannot solve the health problems that we as a country face. It has to be a collective effort of everyone coming together and solving for it. So hoping maybe by next year, we'll be in a better position to actually come closer to the claim of, with the support of district health officials, Dr. Ramesh and everybody, to take Krishnagiri, make it reach to that point which is closer to being a model district. Model district not only in Tamil Nadu, but also in the country of India. Thank you.
Thank you, sir, for providing wonderful services towards the betterment of health outcomes. We cordially welcome Dr. Ramesh Kumar, sir, District Health Officer, Krishnagiri, to honor the speaker. With a memento. Thank you, sir.
Courage isn't only fighting your circumstances. Sometimes making peace with your circumstance requires
அனைவருக்கும் மதிய வணக்கம். வெல்கம் பை டான்சாக்ஸ் தமிழ்நாடு ஸ்டேட் எய்ட்ஸ் கண்ட்ரோல் சொசைட்டி. The topic is the last mile challenges towards elimination of HIV. Last mile. With the resilient public health system, we will cross the last mile. We will reach. HIV facts, everybody knows. It's an weakening the immune system. There is no cure, but we got treatment, antiretroviral treatment. It is a manageable chronic condition like diabetes. That's the world scenario. Nearly 4 crore cases, 4 crore PLHIV, people living with HIV are in the world. In India, 25 lakhs. Trends in Tamil Nadu, we are in the decreasing trend. That's why the topic is a last mile challenge. It's a prevalence rate. We are in the verge of elimination from 0.84 to 0.2. It's a prevalence rate in adult. We are nearing the elimination phase. So ANC clinic attendance, it will be taken as a proxy indicator. Compared to national level, we are in the very low. There is 0.16% in the antenatal attendees. That's a proxy indicator for general population. It's a national AIDS control program. We are in the 5th phase. These are the program NACP goals, reducing the annual incidence of HIV infection 80%. Mortality, death rate should be reduced by 80%, eliminate the vertical transmission of HIV syphilis, promote quality access to RTA, STA service, then eliminate stigma. இதில் என்ன அப்படின்னா நம்மளுடைய டார்கெட் வந்து 95 95 95 95ங்கிறது யார் யாரெல்லாம் ஹெச்ஐவி இருக்க பாசிபிலிட்டி இருக்கோ அவர்களுக்கு 95% we should have a diagnosis. We should test for HIV positive people and we have to identify the 95% of the estimated target. And all the diagnosed HIV எல்லாருக்குமே வந்து we have to start antiretroviral treatment. அதில் treatment success, that is the suppressed viral load. Viral load எடுத்து பார்க்கும் பொழுது it should be suppressed. That is a 95-95 target. இதில் தமிழ்நாடு எங்கே இருக்குது அப்படின்னா ஃபஸ்ட் 95ல 94, செகண்ட் 95ல 90, தேர்ட் 95ல above 95. We are in the verge of elimination, we are in the last mile of elimination. இந்த டார்கெட் அச்சீவ் பண்ணுறதுக்கு நம்மளுடைய ஃபஸ்ட்டு டார்கெட் அச்சீவ் பண்ணுறதுக்கு கம்யூனிட்டி பேஸ்டு ஸ்க்ரீனிங் அண்ட் டெஸ்டிங். அடுத்து இண்டெக்ஸ் டெஸ்டிங். இண்டெக்ஸ் டெஸ்டிங்கிறது பாசிட்டிவ் பர்சனுடைய கான்டாக்ட், அவருடைய பார்ட்னர், அவங்கள டெஸ்ட் பண்ணுறது மூலமாக அந்த 95% அச்சீவ் பண்ணணும். நெக்ஸ்ட்டு வந்து ஏஆர்டி. அதில் என்ன அப்படின்னா டெஸ்ட் அண்ட் ட்ரீட் பாலிசி. யார் யாரெல்லாம் வந்து பாசிட்டிவ் ஐடென்டிஃபை பண்ணியிருக்கோமோ அது உடனடியாக வந்து அவங்களுக்கு ஆன்டி ரீட்ரோவைரல் ட்ரீட்மெண்ட் கொடுக்கணும். இன்டென்சிஃபைடு எல்எஃப்யூ ட்ராக்கிங், லாஸ்ட் டு ஃபாலோ அப். யார் யாரெல்லாம் வந்து ட்ரீட்மெண்ட் எடுத்துகிட்டு வரலையோ அவங்கள தேடி பிடிச்சி வி ஹவ் டு ஸ்டார்ட் ஆன் ட்ரீட்மெண்ட். எதற்கு? டு சப்ரஸ் தி வைரல் லோட். வைரல் லோட் சப்ரஷன். வைரல் வந்து அதனுடைய லோட், வைரலுடைய காப்பீஸ் டு பி சப்ரஸ்டு. அடுத்து வந்து டிஃபரன்சியேட்டட் கேர் டு இம்ப்ரூவ் ரிட்டென்ஷன். டிஃபரன்சியேட்டட் கேர் மீன்ஸ் வி ட்ரீட் தி சப்ரஸ்டு வைரல் லோடு பேஷண்ட் அஸ் அண்ட் விஐபி இன் ஏஆர்டி சென்டர். அவர்களுக்கு வந்து வந்த உடனே 3 மாதம் மாத்திரை கொடுத்துட்டு அனுப்பி வருவோம். அதுதான் டிஃபரன்சியேட்டட் கேர். அதாவது சப்ரஸ்டு வைரல் லோடு இருக்கவங்க வந்து விஐபி பேஷண்ட்டு. திஸ் ஆர் ஆல் தி சர்வீஸ் டெலிவரி பை டான்சாக்ஸ். அதை ஒரு 87 சிபிஓ கம்யூனிட்டி பேஸ்டு ஆர்கனைசேஷன், அடுத்து 17 லிங்க் ஒர்க்கர் என்ஜிஓ, இவர் எல்லாமே வந்து ப்ரிவென்டிவ் ஆஸ்பெக்டாக தே ஆர் ஒர்க்கிங் ஃபார் ப்ரிவென்ஷன் ஆஃப் ஹெச்ஐவி. அண்ட் ஸ்க்ரீனிங் 3163 ஐசிடிசி சென்டரில் வி ஆர் ஸ்க்ரீனிங் ஃபார் ஹெச்ஐவி. தென் 80 ஏஆர்டி சென்டர் ஃபார் ட்ரீட்மெண்ட், 658 கவர்மெண்ட் ஹெல்த் இன்ஸ்டிடியூஷன், 22 ப்ரைவேட் காலேஜஸ் அதில் வந்து ஃபார் ட்ரீட்மெண்ட். தென் 172 லிங்க் ஏஆர்டி சென்டர் for treatment nearer to the place of residence. This is all service delivery by TANSACS. Then tracking back defaulter. ART ஆரம்பித்து வராதவங்களை தேடி பிடிச்சி வைக்கிறதுக்காக 32 CSE. அதுவுமே வந்து it is run by the positive people for the positive people. Then 34 drop-in center அவருடைய சோசியல் வெல்ஃபேர் ஆக்டிவிட்டீஸ்க்கு லிங்க் பண்ணுறதுக்காக 34 drop-in centers we are having in Tamil Nadu. These are other lab, state reference lab for viral load testing. National reference lab we are having in our Tamil Nadu. Then U equal to U. This is a concept we are promoting for IEC. It means undetectable viral load means it is untransmittable infection. When we achieve undetectable viral load, viral suppression, then the disease will not be transmitted. That's all. That is we want to break the chain of transmission. That is we want to have a zero HIV. These are all challenges. We are having many challenges. Many of the patients are identified only in the hospital in the inpatient. We need a field identification we have to improve. In the hospital, later stage, we are diagnosing only in the later stage. Then there are issues in partner identification. For index testing, we have to identify the partner. Due to stigma, we are having issues in index testing, partner identification. And another challenge is a surge in MSM activities. MSM means man sex with men. இதில் என்ன ஒரு ஃப்ளானா people have a heterosexual contact மூலமாக தான் ஹெச்ஐவி பரவுது. எம்எஸ்எம் சேஃபர் அப்படிங்கிற ஒரு தாட் இருக்குது. The recent evidence suggests that HIV positives more in the MSM persons. Then social media addiction. There are so many dangerous apps for the MSM activities, for the sexual activity. There are so many dangerous apps. We have to restrict our this generation and future generation with the apps, dangerous apps. Then linkage losses. Linkage loss means screening site to confirmation site. We have some loss. ICT center to ART center. Treatment aspect we are having loss. We have to follow the loss to follow up. Even after starting the treatment, there are some patients are lost to follow up. And after out, they are diagnosed, they started the ART, then we don't want treatment. And the treatment in private sector. The after-out cases may have got treatment in private sector. The treatment protocol in private sector, we are not whether it is up to the national protocol or not. And the reporting, there is a backlog. We have no report from the private center. And follow-up of the last follow-up cases, we are facing very challenges in the private sector. These are all the services towards the HIV elimination. The intensified IEC campaign. We are with so many materials, medias, social media, mid-media. We are having the intensified IEC campaign for promote awareness. Then targeted intervention. Very many NGOs are involving in the targeted intervention. It means so many groups, migrant, drivers, truckers, and female sex worker, male sex worker, everybody, we are having separate NGO, they are working for diagnosing, for giving awareness. The link worker scheme, that's a rural based high risk group, we are having 17 NGOs working for that. We are having mobile ICTC and Sambhurna Suraksha Kendra. There's a one-stop center for delivering all such HIV services. Then integrated health camp. We are conducting the integrated health camp in remote areas. Then convergence with the TB, RCH program, NCD program for better life of the PLHIV. The next is the early HIV screening in pregnant women. For preventing the vertical transmission, we have to do a early screening for pregnant women for HIV. Then we have to ensure the prophylaxis for newborn. Then community empowerment through PLHIV network. We are empowering the PLHIV people through NGOs. And so stigma and discrimination reduction. HIV is a stigma, having its own stigma. So we are sensitizing all the healthcare provider for stigma elimination. The workplace policy. Workplace policy means workplace there should be a complaint officer. Then community campaign to normalizing HIV screening. Then involvement of PLHIV and peer support. We are having even in our ART center, community care coordinator, this is the PLHIV. We are involving the PLHIV in day-to-day work. Then legal and policy framework. In 2017, we have a HIV Act to promote to protect the rights of HIV affected people. We are having the HIV Act 2017. And we are having, these are intensified IEC campaign for promoting the IEC activities. We have started the intensive IEC campaign with our Honorable Health Minister and respected Health Secretary sir and DPH sir attended this intensified IEC campaign activities. These are the awareness materials we have prepared. These are also the awareness materials we are for displaying in the public health institution. We have conducted an online quiz program. For every district we have conducted an online quiz program for HIV AIDS, and we are conducting the intensified IEC campaign in village for village level awareness creation. For HIV affected and infected children, government of Tamil Nadu is giving ₹1,000 per month this is a way forward. We have to ensure every child the best possible start in life. That is, we have to prevent the future generation from HIV. So we have to sensitize all women of reproductive age group, especially for the PLHIV women, regarding the HIV treatment, viral load suppression. Then strengthen the last mile service through integration of HIV program with other public health platforms. Then sustain high ART coverage and viral suppression. Then we have to extend the community ownership through NGOs, network and peer educator. With these efforts, we will definitely, with the coordinated effort, we can achieve the target of 95 by this year end and eliminate HIV as a public health threat by 2030 with all our sustained efforts. Thank you all. Nandri. Any question, please?
Thank you, sir, for your insightful words. I invite Dr. K.C. Seran, Additional Director, Urban. Dr. K.C. Seran, sir, onto the dais, please. Require Dr. K.C. Seran, sir, to honor the speaker with a memento. Thank you, sir.
DPH Icon 2025 cordially welcome Dr. A.K. Puttaraju, sir, Regional Team Leader, WHO South Regional Office, to speak on transition of VPD surveillance with IDSP, status, concerns and way forward. A few lines about Dr. A.K. Puttaraju, sir. Sir has previously worked as Epidemic Intelligence Service Officer in CDC and WHO. Expert in vaccine preventable disease surveillance and major role in polio eradication and MR elimination. We welcome you, sir.
Good afternoon. First of all, I thank the department, the government of Tamil Nadu, also DPH sir, for inviting us to participate here and also speak on the today's topic, the VPD surveillance system, which is going to be transitioned to IDSP in the coming days in the entire country. So this is the outline that I will be speaking about, little bit about what is the vaccine preventable disease surveillance in India that is happening, and a little bit about how it all started with National Polio Surveillance Project, and also the IDSP which is going to take over that, and little bit on the transition itself, and what are the concerns and challenges of this transition that is going to take place, which is being supported by WHO and PSP for almost 3 decades now, and what is the way forward. So if you look at the VPD surveillance system in India, it mainly encompasses, of course, it started with poliomyelitis, and then measles and rubella, then diphtheria, pertussis, neonatal tetanus, and also the outbreak investigation that happens for all these diseases. And just from this year, as per the request of Government of India, we are also supporting typhoid surveillance. As far as the poliomyelitis surveillance is concerned, this is how it began, way back in 1997. The conventional acute flaccid paralysis surveillance system which is there, and we are also supporting the IVDPV surveillance. VDPV is vaccine-derived poliovirus, and the long-time excretors of poliovirus because of the immunocompromised children. That is something which we are supporting to track. And of course, the environmental surveillance. There are definite identified points in the entire country where the sewage samples are collected, and we are supporting that system also. Before I go into the other systems, I must mention here, it is Tamil Nadu which had this system much before the country. The country started in 1997, but Tamil Nadu state actually had this system, the polio surveillance system, much before WHO started it in India. So just a little bit background, Government of India in collaboration with WHO started this National Polio Surveillance Project way back in 1997. The basic idea was to initiate the acute flaccid paralysis system in the country and support polio eradication. This is how it all started, the vaccine preventable disease system in India. And after India was certified along with other countries as polio free in 2014, NPSP started supporting other surveillance like measles rubella surveillance, DPT surveillance, and now the typhoid surveillance also. So this is the structure till recently. The Government of India and WHO had put up. The system was there in the entire country, and as you can notice, most of these field offices were mainly in the northern part of the country, UP and Bihar, with minimal presence in the southern part of the country. And this was supported by the WHO accredited laboratory, both for poliomyelitis, measles, rubella, and also DPT, and in the recent times for typhoid also. So which are the key areas that this system was supporting? First and foremost, of course, is the VPD surveillance system. The idea was to sustain polio-free status of the country, which it has achieved already, and implement the polio endgame strategy in India, accelerate the measles rubella elimination strategies. India has stated that it is going to eliminate measles rubella by December 2026, which we are supporting, and conducting lab supported diphtheria, pertussis, and neonatal tetanus, which we are already doing. So this is the main support that we have been providing as far as the VPD surveillance system is concerned. And just to give you an idea what is the scale of operations in a huge country like India, definitely I'm just want to show that FR cases is fever rash cases. If you look at last year, there were more than 1.12 lakh fever rash suspected measles rubella cases, and this year also there are almost 66,000. So I mean, each of these cases get reported from different levels, right from the field, from A&M level to the the higher centers, and maintaining this system, nurturing this system is something very, very important. And once the cases get selected, go and investigate these cases, write a case investigation form for these cases, whether it is timely, whether it is complete, look at the quality, and also see that this entire data is entered into a system, and then do the epidemiological analysis and provide evidence for decision making for the policy makers. This is the very critical thing that that is going on. I am just showing you here the measles. This happens for the polio also. This happens for diphtheria and many other vaccine preventable diseases. So this system is also supporting for routine immunization. I will not get into the details of this, and in many other areas. Now ministry has decided to transition this to IDSP. IDSP, all of you know, it is there, it is pan-India, started sometime in 2004, and it has a system, inbuilt system, which goes down to the primary health center level. They have their own laboratories, their own systems, who can definitely take over this, this additional responsibility of vaccine preventable disease surveillance. So there is a background for this transition. It was actually being, discussed, way back in 2018, how to really go about, this transition, because basically India wanted, this to be integrated into IDSP. So this is being going on for a very long time, and since, January of this year, this has taken prudence, and it is going on in a fast track mode. So as I told you, transition is a decision of Government of India, and WHO India strongly supports this. And funding for this, which has been given to this NPSP, it is going to end by March 2027. And after that, it is the state governments which will have to take over the entire functions of VPD surveillance system. And all the functions will be, of course, will be taken over by the IDSP. And there is a system to enter this. There is a surveillance information management system which is being operated by NPSP for all these vaccine preventable diseases, which will be integrated into IHIP in the coming days. It will start with VSIMS, and finally it will get integrated into IHIP. So this is the transition plan. As I told you, it will happen in 3 phases. The first phase is already over. This August, we have already transitioned almost 1/3 of these, units. Almost, 280 districts in this country have already transitioned, and some of the states have completely transitioned, and some of the states have, partially transitioned. And, the end will come in March 2027, wherein the state governments, the IDSP, will be individually handling this surveillance system from then onwards. Just to give you an idea, this is the first phase that has already happened, and the highlighted districts are those where the transition has already happened, and many of them which are there in green have completely transitioned. So there is no presence of WHO and NPSP who are there in the field level, and others are in the process of transition. And in the south region, I can quote that, Telangana and Kerala, they have completely transitioned. They are managing the system on their own. And in other states, the transition is in progress. So what was the process? A system which was built almost, 3 decades back. How is this, this was transitioned? Basically, there were, training materials that were developed. There was capacity building that was done in each of these districts, and handling over of all the surveillance related documents for all the last 30 years related to polio, measles, and diphtheria, they were all handed over. And as I told you, the VSIMS, which is the surveillance information management system, the credentials were also handed over, and many of the districts have started operating this system on their own. And post-transition, we are also supporting them in identifying what are the gaps there, and supporting the state and the districts to, for a smooth transition. So, this has started, and the phase 1 is already over. And what are the challenges that one can see? What are the concerns and the challenges? The major programmatic challenge, comes, from the polio program. If you know that, the entire Southeast Asia region is already free of polio. One of the things that, comes to anybody's mind is maintaining the polio-free status. Will our surveillance system be sensitive enough to really pick the cases if the wild polio virus gets imported, or if there is a vaccine-derived polio virus, if it emerges within the country, or if it gets imported? So, that is something, which the program managers at the state level should be, concerned of, and see that the sensitivity is maintained. And the second thing, of course, India has, MR elimination is a flagship program in India, and, that is something where, we should be really, focused. The other thing is, transfer of these skills and the knowledge that has been there for the past 3 decades to, some, personnel who are dedicated to do this within the system is something which, we see as a challenge. And, not all states are in the same phase. Like, for example, Tamil Nadu is at a better stage, the transition may be very smooth here, but, there are many states which still need some support, and there may be some issues which needs continued support from Government of India and WHO. And another thing is about the loss of independent technical support and feedback that was being provided by WHO and PSN for this program. Some of these surveillance are very, very sensitive. They are targeted for eradication and elimination, which really requires some independent body to look at it and, support the states and the nation. Probably that is something which is, which will not be available. So with this, what is the way forward? WHO India fully supports VPD surveillance transition and strengthening, the domestic systems. And different states are at different levels of transition based on the public health capacities that are there in those states. IDSP will have to quickly take over this responsibility and mitigate the programmatic risks that I have mentioned. WHO India would continue to support this both at the state level and the national level. And the polio network, which is already there, it is supporting the country in the Gavi HSS3 in bringing down the zero-dose children, mostly in the northern part of the country, and also keep supporting the VPD surveillance in the country. And also there are discussions with some states, what would be the support that is expected or required at the state level from WHO. These discussions have already started. So, this is the way forward that we see, and we really, from WHO India, we really, thank for this opportunity, and also wish all the best to IDSP, to take it forward. Thank you.
Thank you, sir, for sharing your valuable insight. We cordially invite our additional DP head, sir, Dr. P. Sambat, sir, to honor the speaker with a memento. Thank you, sir.
DPH Icon 2025 takes immense pleasure in inviting the pioneer, the forerunner, the precursor, the trailblazer, our Director of Public Health and Preventive Medicine, Dr. A. Somasundram, sir, on the dais to moderate the session on CRS approach. Dr. A. Somasundram, sir, we welcome you onto the dais. I invite the speakers, Dr. Grace, Technical Officer, World Health Organization, Country Office for India, to join on the dais. Dr. Chalapati Rao, Associate Professor, National Center for Epidemiology and Population Health, will be joining us online. Dr. V.N. Manju, WHO Country Office, District Health Coordinator, CRVS, WHO India, invite you to join on the dais, ma'am. Dr. Anand Krishnan, Professor, AIIMS New Delhi, I request you to join on the dais, sir. Dr. Prashant Mathur, Director, National Center for Disease Informatics and Research, Bangalore. I invite you to join on the dais, sir. Dr. Prashant Mathur will be joining us in an online session.
Good evening. Dr. Anand Krishnan sir, Dr. Manju, Dr. Grace, we welcome you on behalf of the DPH ICON. So it is definitely a privilege to have some, and Dr. Prashant Mathur has joined. So let him join. In the meantime, I will just brief on what is this session about. Definitely a privilege to have some experts on any topic. Now, we have experts who are working on improving mortality statistics across the world and across the country, and particularly in Tamil Nadu. So what we have been experiencing is the mortality data in Tamil Nadu is relatively stronger when compared to other states in India. But however, we have some challenges in the form of medical certificate of cause of death. So we wanted to address this issue, and we took up one district CRS approach with the support of WHO. Mortality statistics with a digital innovation is an enhanced, and it was titled here as Beyond Numbers. Over the past presentations, we have many insights ranging from strengthening civil registration using verbal autopsy and leveraging national collaborations. They are not numbers, they have some information behind each number. Reliable mortality data allows us to allocate resources, formulation of policy, changes or amendment in the policies, and improvising the health system. Definitely, in the past 100 years of public health, and also in the Tamil Nadu health system, we have been changing or innovating new programs. Allocations have improved, but not to the expected amount, but the prioritization have been done. In order to commit for building a strong data system, we have collaborated with institutions like NCDIR, WHO, and also we have associated with many related departments. We have improvised a lot, as I said, but the real number, that is the quantum of death records, which a definite medical cause, is only 45%. The registration is 100%, whereas the medical records we have is 45% on an average. So this is definitely a significant gap in mortality surveillance. To bridge this, we piloted a CRS approach in Krishnagiri and Karur districts, and we had a first-hand experience on how to improve or what was the output. That is what we are going to discuss in this plenary. And also here we have Dr. Anand Krishnan, who has large and vast experience across the states in India regarding the mortality statistics. And we have Dr. Grace, who is working as a lead in WHO country office for health financing, and also we will have a perspective on how this health financing will support the digital data systems or mortality statistics in India or in Tamil Nadu. So I will request Dr. Manju, I think you can present what happened in Karur and Krishnagiri and what was the output, please. Thank you.
So, good morning everyone present here. I'm Dr. Manju from WHO. I work as a district health coordinator. So this, as already our director sir mentioned, we have 100% of death registration that is happening in Tamil Nadu. But there is only 40% of MCCD that is available. And when we talk in terms of MCCD, there are two types. One is a Form 4, another one is a Form 4A. Form 4 is something that has been collected in the institutions. Whereas the deaths that happen outside the institution, there is this Form 4A where the cause of death is being documented. So in our state, the documentation of Form 4 is 100% because all the medical officers, any death that happens in the institution, the medical officer is supposed to provide a cause of death certificate for the death. So the main challenge we had is that to cover or to ascertain the causes of deaths for those happening at the road or at the home. So these were the major aspects that we were looking into. So when we look into the major aim of this district CRS approach that was piloted in district of Krishnagiri and Karur, the aim was to ascertain, to estimate the proper causes of death for all the deaths that is happening in the district. So, and when we look into the objective, we had three major objectives. One is to integrate the verbal autopsy system into the existing CRS system. The second is to the second objective is to collect the reliable cause of death information system, and the third objective is to improve the analysis and the data collection process in the district level. So with this, if a model is being formed, then this would help us to this would help us to scale up the project at the state level. So this is the picture of the existing CRS system, where the black and white are the system that was already existing with the state government, and the ones highlighted in green is the intervention done. So when we look at this, all the hospital deaths, we do have MCCD, we do have the cause of death certificate which is being documented in the CRS portal, whereas for the home deaths, let it be a MLC or an unnatural death and MLC, or let it be a natural home death, the availability of MCCD was a challenge. So for those deaths which did not have MCCD, we happened to do a verbal autopsy. So who does a verbal autopsy is that the health inspectors and the sanitary inspectors of the district were trained to be a verbal autopsy interviewer, and these people went to the field, collected data and So these people collected the data. So from the, using the verbal autopsy WHO questionnaire. So from this data, the medical officers of the respective PHCs determined the causes of death using the PCVA web portal that was designed to ascertain the causes of death. So these information were again integrated into the CRS portal that is already existing with the state government. So our major role here was to ascertain the causes of death for those who did not have an MCCD, and in addition to that have an entire analysis, a comprehensive analysis of all the causes. So with this, in 2023 our achievement was at the first level, we did strengthen the existing human resources. The capacity building of the existing human resources was strengthened. So the one positive thing with this is, for a sustained process, you always need to integrate into the existing system rather than bringing in new resources. So that was a major intention, and we did achieve. So from the training part, as a first, in respect to verbal autopsy, we did have around 80 master trainers on verbal autopsy. So with the help of these 80 master trainers, we did train around 155 health inspectors and SIs, interviewers in Krishnagiri, and around 87 interviewers in Karur. So in addition to that, we also did have a PCBA training, which is Physician Certified Verbal Autopsy, where the medical officers were trained on how to give the causes of death using the data collected by the health inspectors. So we happened to successfully have 51 master trainers in both the districts, and with the help of these people, we did train around 106 and 84 medical officers in each district. So in addition to that, the methods that we used to train these people were, we had lectures and we did have role plays, we had hands-on training for them, and the output from this is that we now have at least one interviewer per PHC available in the entire district of Krishnagiri and Karur. And we also have at least one medical officer available in every PHC of Krishnagiri and Karur to ascertain the cause of death. This is on a minimal level. Depending on the caseload, we did have more than one interviewer or medical officers also. So when you look at this, of the total death, 42% of the deaths only had cause of death information in Karur, whereas 27 had cause of death information in Krishnagiri. So with this verbal autopsy intervention, we did achieve a 98% cause of death for the year of 2023 in both the district. So when we talk about cause of death over here, it is not just cause of death that has been ascertained for the sample. The entire district population was covered with the process. So coming into the results, it's a very short time that has been provided. So I'm not going to get into the depth of the results. I'll just give a picture of what is all present in the mortality report that has been released. The report is available in the DPH website, that can be accessed by anyone. So the blue line indicates the sex ratio, whereas the orange line indicates the male is to female death ratio. So here we can observe that even though the sex ratio is at around 1, you could see that there is a strong peak between 15 to 60 years where there are more male deaths compared to female. So for a long time we have been more focused towards improving women's health, more attention towards women has been more prevalent. I think we also need to give more attention towards men's health also. So coming to this slide, you could see that again the number of male deaths are more when compared to the female deaths. So that explains the reduced life expectancy of male deaths compared to your female. So this is something we actually had which actually had a very big impact on the analysis and the results that we had. So initially, let it be Krishnagiri or Karur, we had only around 40 to 50% of the causes of death were ill-defined. In the sense, we were not able to find any specific cause for the death that were associated. So ill-defined causes were aging, cough, fever, all these things were mentioned as causes of death. So with this intervention of verbal autopsy and with the recurrent process of recoding and analysis of the data, we did bring this 40 to 50% of ill-defined cases to less than 10%, around 8 and 15% in both the district. So the blue line and the orange line represents a different, blue line is the Krishnagiri district and orange is the Karur. So in our report, we did have the outcome, we did have all these outcome indicators. So the we are having leading causes of death by age, leading causes of death by sex, cause specific, chapter specific causes, in the sense what are all the leading causes among NCDs, what are all the leading causes among infectious diseases, what are all the leading causes among injuries, all these categorization is being done. We also did have a non-communicable disease indicator. We did a comparison between the WHO indicator, and we also estimated the years of life lost. So this is an example of your age specific and sex specific causes of death that is being, an example is being provided for the district of Karur. So this is the age standardized death rate. So when you look into this age standardized death rate, we can very significantly see that the road traffic accident among male population, specifically in the district of Krishnagiri, is way too much higher than the deaths that is happening in Karur. When compared to male and female, the RTA deaths are more in male, but rather the male population in Krishnagiri has a very significant higher number of deaths. So all these things indicates that we need more targeted intervention towards these specific components. So the major importance of this report is that we did always have all these indicators and all these values at the state level. A consolidated report of each and every indicator, death information at the district level for the entire district covering a year was being generated. So district being considered as an unit level, these information will be very useful for the DHOs and the block medical officers to plan targeted interventions in their specific areas. So these are the complications that were associated with diabetes that we observed with our analysis. So we could see that there are so many preventable complications that are existing in the field. So these complications, these were the immediate causes of death. So when I say complications, though diabetes was the underlying cause of death, these complications were the immediate causes of death. So if we had prevented these kind of complications, maybe the person would have lived even more longer. So these are how we are supposed to utilize the report and the data that has been available to generate a targeted intervention and policy making. So this is the comparison of the NCD indicator with the WHO. So you can see that in 30 to 69-year-old, the major risk or the major cause is your NCD that is occurring. But when we looked into the report even more deeper, we also found out that there are major causes of NCDs where this cancer, diabetes, cardiovascular disease and COPD, and these were more common in Krishnagiri rather than in Karur. So these indicators will also help us in as a way to progress towards our SDG. So the years of life lost. We could see that the major causes of deaths in younger age group were more towards suicide, birth asphyxia, and in the middle age group it was more towards cirrhosis, RTAs, and all these things are something that could be easily preventable, and it would increase the life expectancy of people. So finally, this is one major initiative, first of its kind, that was initiated to cover the entire district. So these reports in detail were discussed with the DHOs of the respective districts, and there are follow-up actions in terms of gap analysis and intervention, targeted intervention that has been in discussion. And this report as such will help the state to formulate policy decisions and targeted interventions. And this is something that is an evidence-based report where the medical officers can access the causes of death, the percentage of death mortality loads up to their PHC level. It is not just specific to the district, but up to the PHC levels they have an access to the mortality statistics of their respective villages, for which they can have a targeted intervention. Thank you.
Thank you, Dr. Manju. Probably you have not added any emotions to your results because lot of work have been done. The one point to note is this started in the year 2022 and nearly 1 year was spent on planning, not on execution immediately. So during the phase of planning, we did a pre-pilot in Krishnagiri and Karur. In the Krishnagiri alone, we did a pre-pilot. During the pre-pilot itself, we learnt many lessons. For example, one practical lesson is, we used to do similar to maternal mortality, we were using infant mortality verbal autopsy during the monthly collectors conference meeting. So many of the deaths which were discussed in the IMR reviews, in the collector's review, were found to be unregistered in the system. So again, this similarly many surprises we were able to capture, and we incorporated such information to the pre-pilot initiative. And another point to note from Manchu's presentation is, this was not a sample. The verbal autopsy pilot in Karur and Krishnagiri is not a sample. It is for whole universe. So taking all the deaths which did not occur in institutions, because 60 to 70% of the deaths have been found to have occurred in home rather than institutions. Because one practical thing in Tamil Nadu, probably in other states also, what we do is, when a patient is dead, the hospital will record it as against medical advice or absconded for want of avoiding these postmortem issues. So what they used to do is, or probably in the last minute while the patient is gasping, we will send the patient to home. You can take the patient to home. So similar cases where the deaths occurred in home are found to have recorded as home death, we did not find any data for cause of death, because they used to get a fake certificate or a certificate partially truthful certificate. So these were, so we decided, initially we thought of taking a sample, but finally we decided to have all the universe as a sample, and this we have presented in an international forum called Verbal Autopsy Reference Group. It's a social group throughout the world they are keeping, and we have presented this. And no country, to my knowledge, has done this PCVA and verbal autopsy in the universe, that is without for the whole population. And taking this as a success, we applied for a grant in ICMR, and recently we have got a grant for nearly 6 crores for the Directorate of Public Health to expand this project in few more districts, probably 8 to 10 districts. Abhishek, 8 to 10 districts, isn't it? So now this is a news for you, and we are very thankful to all the stakeholder departments, right from WHO to MMC to NIE, for having this pilot as a successful one. So now we are skipping to another topic where the NCDAR contribution for Tamil Nadu for improving the mortality statistics will be presented by Prashant Mathur sir, who is present online, and Dr. Abhishek will be introducing him for the participants. Please. Sir, welcome you, sir.
Thank you very much. Good evening. You can hear me?
Yes, sir.
Can you hear me?
Yeah. Please.
Okay, thank you.
A hearty welcome, Dr. Prashant Mathur, sir, Director, National Center for Disease Informatics and Research, Bengaluru. Professor Mathur is the Director of Informatics, ICMR, NCDIR, Bengaluru. He is a member of several state and central committees on policies on screening and prevention of cancer, HPV vaccines. He is also a member of the Scientific Council of WHO, Fellowship Selection Committee of International Agency for Research on Cancer, IARC. Welcome, sir.
Over to
good evening,
Mathur, sir. Thank you.
Yes, good evening, everyone, and thank you to the organizers of the DPH and to the Director of Public Health. This is a short intervention that I am making in our journey and our collaboration with the Tamil Nadu government in improving the medical certification of cause of death. As was stated that since Tamil Nadu achieved 100% death registration in 2013, but the MCCD coverage was around 43 to 45% only by 2017. So this gap was prioritized by the state of Tamil Nadu, and a information communication technology solution was being explored. During the same time, at our institute, we had recognized this gap because we run the National Cancer Registry Program for India, and we realized that cancer as a cause of death was not being recorded to the extent that it should be. We had already started work on improving MCCD way back in 2015, and we developed the application known as electronic mortality, or EMOR as I would be referring to, which would help in recording and reporting ICD coded cause of death for use by hospitals in India. The Tamil Nadu government had shown a lot of interest in this software, and we collaborated with them. In 2016 to 2018, we worked around how to plan it, implement it, and also worked around software solution. And in 2020, we pilot tested this in 6 hospitals and 3 registration units in Tamil Nadu. And by the end of 2021, this was implemented in all local registration units and hospitals of the state of Tamil Nadu. The features that our software EMOR brought to the table were many. Amongst them, the few ones are use of SNOMED CT terms, which could help us in arriving at cause of death, incorporating ICD-10 list as per the national list of mortality codes, which was mapped to the SNOMED CT terms, and application programming interface, or API, to record ICD-03 terminologies and topographies for malignancies. The EMOR software also brought in a lot of prompt messages to the user by bringing out that this is not a cause of death but a mode of dying, like respiratory arrest, and that to encourage the underlying cause of death. A prompt was also asked to verify whether this was actually an underlying cause of death, and encourage the person filling up the death certificate online to fill in part A, B, C, lines A, B, C in part 1, and also record the ICD-10 code. There were quality checks which were built in within the software, and summary tables could be generated. Within a short span of 2 years, we were able to ensure that 100% coverage of MCCD happened across all institutional deaths in Tamil Nadu, and that the average time taken for completion of death registration was 19 days, and which had 10 days for institutional deaths, 29 days for domiciliary deaths, and other deaths, place deaths, were 44 days. And so that we could submit within the legal time limit of 21 days. We also took care of completeness of information by reducing the missing data, data quality, range checks, etc., and provided a template for reporting MCCD. I am reminded that 4 years ago, 5 years ago, when in a Ministry of Health meeting in Delhi, when I proposed this, I was come back to the committee so that this can be that experience to scale it up. Through the MCCD is to improve the non-institutional death also into the CRS system, and the integration of the WHO DORIS tool as an important step for standardization of cause of death recording and reporting. I am sure that with all these efforts being made by the state government under the leadership of the Department of Public Health Systems in the country should be shaped up so that they are user friendly, and when combined it will give us a sense of direction to measure our progress towards the sustainable development goal targets and be able to identify the gaps where we are not able to perform. So I would like to again end by congratulating the state government for being so proactive and all the team members, and a special thank to my colleagues at NCDIR who have been working tirelessly with the state government to make this happen, and we would really like to see much greater heights being achieved. Thank you very much.
Thank you, sir. Thanks for contribution to Tamil Nadu and sharing your experiences now. Now the audience can understand that this is the first experience, and what he mentioned was, and again, this is mortality statistics is for the population, not for the institution. So when you get the data for population, you can formulate policies, and this data will help in definitely a population based. Sir, thanks for your time, and I hope this deliberation will be much
shortly with DDICMR.
Yes, sir. Yes,
Thank
sir.
you.
Thank you. Thank you very much. So now for the audience, I, on behalf of DPH Icon and now for all the participants and experts, I welcome our respected Health Secretary who has graced this occasion, and also our Mission Director NHM for this meeting. It's a surprise, and thank you, sir, for both of you, sir. So we'll continue. So the next one is what is the importance of mortality statistics? So what Dr. Mathur mentioned is the population based data. Now we have to see what is the implication or what importance the population data is given, and also now we have listened to the experience of Tamil Nadu with respect to Krishnagiri and Karur. Now across the states we need to know what is happening. So we have All India Institute of Medical Sciences. We request doctor to give her insights, sir. Thank you.
A few words on Dr. Anand Krishnan, sir. Professor AIMS. He is the faculty in charge of Clinical Epidemiology Unit and member, Dean's Research Committee at AIMS. He is a member, School Board of School of Health Services, Indira Gandhi National Open University. He was the chair of Scientific Advisory Committee, ICMR NIRE team.
And we saw some very good examples. HIV. If you want to monitor whether we are achieving SDGs, we need to have data and see what is happening. So without any doubt, mortality data is an extremely critical piece needed for public health planners. And what do we do in any mortality system? First is you have to count all deaths. And as recently as Dr. Somasundaram said, our systems currently don't even count all deaths, right? Even counting all deaths is a challenge. Next step is if you count them, then you ascertain their cause of death. And then you put them in a database which is amenable for analysis, analyze and then use it for action. So any good mortality system should be doing not count all of deaths, though we are improving. Therefore we have sample registration system which counts and then does verbatimopsies in all of them, and I will come to that again later. But use of data for mortality data for planning is still almost non-existent in most parts of India. Nobody looks at data, mortality data, because it comes too late. If you have a data which is 3 or 5 years behind, what is the use of that data for planning? So not only do we need to do it well, we need to do it timely. That is the challenge to all of us. So if you look at India, occurring for registration and even for cause of death, but only about 25% of deaths in India occur in hospital. 75% don't occur in hospital. We saw those almost similar statistics, 40% and 27% in Krishnagiri and Karur. So our challenge is twofold. One is how do you capture deaths which occur outside. SRS captures only 0.6% of all deaths, so it is not a good way to, it's a sample, it is not a universal method as you are saying. And even if you capture, we don't have one database, everything goes to separate databases. MCCD goes somewhere else, CRVS data set goes somewhere else, they don't talk to each other. We are trying to find, I will come to that project, in one district, does anybody have a list of deaths? So all these challenges are still there, which if you are saying that we are going to be a developed country, this is something that we should not do. So what we should be doing is that every death should be counted, every cause of death ascertained. For those which occur in hospitals, we should do MCCD. And I could not hear Dr. Mathur very well, but we all think that medical certification of cause of death is good. It is doctors who are filling cause of death. It is very good information. I can assure you MCCD data is not at all good. Its quality, if you do, almost 25 to 30% is cardiac arrest, completely what we call as garbage codes. Almost 30% of deaths certificates are given garbage codes. They are completely useless. So we need to improve MCCD. We need to cover people who die outside the hospital through verbal autopsies, of filling people who die outside through a VA based system. And we will have to employ digital VA solutions. So this is an excellent example of solving a problem which is very important. We have been doing on this in others. We work with SRS system, which was previously called as the million death system. We code about 50,000 deaths a year through our partners in all states. In Tamil Nadu, our partner is SRM Medical College. And the SRS cause of death data is released because we prepare the report. And we have been doing it for last 10 years, more or less. But we work with Prashant Mathur's team to improve. We assess 6 states MCCD, medical certification of cause of death. Lot of challenges. One of them was Rajasthan, and Rajasthan has now asked AIIMS Delhi to start training its. We are developing digital solutions, and along with other partners, we are working with medical colleges and health and demographic surveillance networks to develop a district level model surveillance. We are doing it in Faridabad and South Delhi. Largely doing same things that you are doing. So we strongly urge every medical college to support this activity and maybe adopt a district and help them. And Tamil Nadu has many district-based medical colleges. So I think it's a model that, so it's a model that Tamil Nadu can lead with, where medical colleges work with districts in training, in data analysis, in all sorts of things, which I have listed here. So we are developing a digital platform which is completely free. It will give training for verbal autopsies. It will provide training for doctors to do coding. It will provide a platform on which coding can be done. So physician coding will occur. It will give you a platform by which physicians can code the forms. So all of this will provide free of cost to anybody who wants to do it. This is currently being developed. In a couple of months it should be ready. And this uses WHO VA tool, but we are open to using other tools as well. So like what you did in Karur and Krishnagiri, we have adopted 6 districts in India, in 6 states, and trying to do exactly the same. How do we get a universal, what is the model which will enable India to get a universal cause of death? We are looking at 3 models. First model is exactly what you did, is asking them through ANMs. The second model is a nurse model. Hire 2 models whose only job is to do VA. They are not actual part of the health system, but they will go to each house and do the VA of the identified deaths. Third is a call center model. We are trying to see whether it works. Same, but VA is done through telephonic, through a distance model. So we are trying 3 models to see which works better in achieving universal coverage of cause of death. We are planning a meeting with Dr. Chalapati in Delhi next year on a national symposium on strengthening mortality system. And I would definitely invite Dr. Somsundaram and your team who is working in it to present and share your experience with the others, so that other states in India can also move ahead with it. Thank you.
Thank you, sir. Thank you, sir. It's very heartening to note that this is being taken up in other districts also. Probably if we have a countrywide mortality, now lot of in-migration, so definitely there will be mutual learnings when we interact. So now we invite Dr. Introduce Dr. Chalpati Rao before we hear from Dr. Grace.
Dr. Chala research academic collection and validation as well as secondary data analysis for countries in the Indo-Pacific region. India includes verbal autopsy validation in Delhi and subnational mortality estimation. His work...
Listen to Dr. Chalpati Rao. We will like to hear from you, madam. Sir, good evening, sir. I'll request you to wait till the Grace finishes her
I'll wait
turn.
for Dr. Grace's presentation
Yes, sir,
to be
yes, sir.
completed.
Nice to have you join with us. Thank you.
Good evening, everyone. Dr. Rao, I understand the time in Australia must be very late. I will make it very quick. Good evening. My charge today is to contextualize the data that Manju and Dr. Adnan have presented in terms of what does it mean for financing? What does it mean for funding of health systems? I hope I am audible. Am I audible? Okay. All right, so I have very few slides. So I'm going to touch a little bit, next slide. Oh, I'm the one, okay. I'm going to touch a little bit on the mortality data and SDG monitoring, because SDG monitoring is, the SDGs are really the determinants for how the money is being sliced, not only at the global level, but at the country level. Secondary, the use of mortality data in high-income countries, and what we see is autopsy in LMICs and how that has affected resource allocation, mortality data and quality monitoring, as well as mortality data targets that are reliant very heavily on good quality data. By good quality data, I mean that it is complete, it is intelligible, as Dr. Adnan had spoken about, and the third thing, that it is disaggregated. So as you could see from Manju's presentation, we are able to get even age standardized data. We are able to get disease-specific mortality data. That is very useful for countries as they are doing their SDG monitoring, but also resource allocation. When we see high-income countries, countries like Australia, Estonia, Sweden, United Kingdom, these countries have matured in terms of their civil registration on vital statistics systems. In terms of governance, they have very clear stakeholders that have been identified to run the vital the CRVS data, and have and this has enabled them, for instance, in Estonia, this is embedded in the health insurance scheme, and it has helped them to adjust their payment models to be sensitive to the disease patterns in terms of mortality. It also is fully digitalized, although in countries like Australia, being a federal country, these ones vary by the states, and in the UK, theirs is still a bit fragmented. In terms of planning, equity, and data access, these states have used them. So in Australia, it is used for informing the primary health network planning and financing. In Estonia, like I said, it is used for funding allocations. The mortality data is used to inform funding allocations for the National Health Plan and the Estonian Health Insurance Fund. In Sweden, for regional budgeting and performance monitoring, as well as in the United Kingdom. And we shall see a little bit more of that later on. Countries that have implemented automated verbal autopsy, by that I mean have taken it to the digital level. No country has fully automated their verbal autopsy. In Sierra, we have a bit of Bangladesh. All these have been financed by the Data for Health Collaborative financed by Bloomberg Initiative. And so you can see that for low middle income countries, the biggest challenge for achieving full automation of verbal autopsy is financing, and has been heavily driven by external financing, which is a good thing that we are seeing now in India. The government is beginning to take this on. For example, with Tamil Nadu, ICMR is going to be the one that is financing this. That bodes very well for sustainability and ensuring scalability. But where it has been used, so for instance in Bangladesh, Brazil, China, these have been more at the subnational level. None of them has done it countrywide, and for some it has only been some pilots within the districts. But without fail, where it has been used, it has been used where verbal autopsy has been automated. That data has informed resource allocation, decisions, and budgeting. In countries like Australia, Canada, Netherlands, New Zealand, and United Kingdom, verbal autopsy data, CRVS data, mortality data coming from their mature CRVS systems has been used for informing quality of care monitoring. The UK has a very mature quality of outcomes framework that has been used to monitor performance, and part of that is mortality data, 30-day mortality data that they use to score providers and the regional health boards in terms of performance, and later on this also feeds into their reimbursement model. Now, in health financing, and this is something that India is beginning to look at directly through PMJ, we have what we call strategic purchasing. Strategic purchasing is where you are using information to guide how you pay your providers, you design the payment model, how much you will pay them, and for what purposes. And so that is where now performance incentives come in, where the purchaser is using bonuses, for instance, to guide the behavior of providers in a particular way. Now, in some countries, like in the United States of America, there are centers for medical Medicaid services, which looks at the main health insurance scheme for the poor, the vulnerable, and the elderly, has been using mortality data for their hospital value-based programs. These programs reimburse providers not for the number of patients that they see, but for the outcomes of care. And so, for instance, in some of these programs, particularly for myocardial infarction, stroke, diabetes, and the like, they provide different, that is charging you for more than you need. And that payment method, we have realized, can drive up health expenditure markedly because it is dependent on the physician to charge as he wishes. With the diagnosis-related groups, it's a payment modality that enables you to reimburse for the amount of resources consumed, but also according to the severity of the disease. So for countries that have implemented mature systems that are using those payments, they use mortality data, especially that which is age-adjusted, to guide the design of those payment modalities so that patients and providers, a doctor that is seeing a patient, for instance, kidney disease and the like with complications, with that, sir.
This is a newer insight when we compare with the different countries, how different countries use mortality statistics for varied purposes. So, thank you, Dr. Grace, and now we can listen to Dr. Chalapati Rao. So, he was very instrumental in conducting the guide during the whole process. And now we can listen to Dr. Chalapati Rao. Sir, over to you, sir. Are you able to hear us?
Yes, I am Dr. Somasundara, and I hope I am audible too.
Thank you, sir. Please, sir. Over to you, sir.
Yes, thank you. So at the outset, I would like to thank Dr. Somasundaram and the Directorate of Public Health for inviting me to participate in today's session. Since when we had started these sessions, when we were deliberating as to how more daunting to an extent, but nevertheless, we actually, it's a matter of great satisfaction at this point in time, or in fact, even earlier this year by April 2025. Am I not audible?
Audible, sir, but a little unclear. So, inge the problem.
Okay. I'll try and speak a little bit slower and a little bit less.
Yes, sir. Yes, sir.
If that could help. So, as I was saying, it was a pleasure for me to be invited to participate in this program since 2022 August, and we did think it would be a challenge to tackle the strengthening of mortality district for a whole statistics for a whole district, but still we took up that challenge, and it gives us great satisfaction to now have reached this stage where we have the complete cause of death statistics for these two districts for the year 2023 as presented by Dr. Manju. I would like to highlight three key points as to the drivers at the level of the state government with the support of the Madras Medical College, developing the tools and materials of health intelligence with Dr. Sumati and Dr. Abhishek had a very important role to play. At the next level, I think the success of this project is largely due to the intensive efforts in capacity building that were provided to all the functionaries across all the PHCs, and with the role of the local district medical colleges as well in providing the necessary refresher training and the on-the-job, on-site supervision, which was instrumental in ensuring the data quality. Which also brings me to the third aspect in regard to the meticulous monitoring and supervision activities and follow-up that was implemented at the local level, and for which the role of the district health offices and the district health officers and various block level medical officers was also very much valued. It is the interest in the subject and the academic spirit in undertaking this work which was largely a factor in ensuring that the quality of the data was collected to the best possible level. Now, I would urge everyone present in this room to take an intensive look at the statistical report that has been published. It has large, I think about 35 or 40 tables of data in it, as well as 15 or 20 illustrative sites into the epidemiological underscore the need to guide local area. One aspect that still needs to be addressed, and I would request Dr. Need for analytical capacity at both the state level as well as at the district level, which is something that will help speed up the production of the statistical reports as well as improve the utility of the data. I will stop here. I would just again like to once again say thank you very much to the Director of Public Health and the state government and everyone for this opportunity, and I wish the Tamil Nadu government and all the districts the very best in continuing on this journey to collect and use mortality statistics for public health development. Thank you.
Sir, thanks for your contribution during our pilot project, and now we could hear a little from you regarding the design plan and also the training of district health officers. That was what he was mentioning, and this has given us different insights, and surprisingly, to be precise or to cite an example, that we found drowning to be the cause of death, but the cause of death as drowning was not found out in the records. So now people are interested to introduce a program for prevention of drowning. So this is what is the outcome of this verbal autopsy exercise, and Dr. Chalapati Rao sir was very much guiding through and into the whole 2 years or 2.5 years program, and we hope to get continued support from you, sir. Thank you. Thanks for your insight, sir. Thank you, sir. So I request the audience, if you have any queries, or if there are no queries, we can give a big round of applause to the speakers, because this is going to take a break in Krishnagiri and Karur. Thanks, madam. And Dr. Manju, who is consultant in Karur, consultant WHO for Karur and Krishnagiri, and she is very eager to introduce and expand this into all the districts. And already Tirunelveli, Tirunelveli is into it. Tirunelveli, you know, training. We have started already the activity before the funds have flown. Gerald, sir.
So just for understanding, I just wanted to ask one doubt to Dr. Grace. This 30-day mortality, because normally we want to reduce the infant mortality rate. So that means that the services are good and that we have prevented infant deaths. Same thing applies to the other deaths also. But whereas in 30-day mortality, we'll try to look at anybody dying within 30 days of a specific disease or a thing. Now, this how is it actually looked at? It's because they might have been diagnosed in a hospital, but they may die at home, or some will die in a hospital. How we grade the services and death based on this criteria?
Mortality which you presented, and also for clinical care quality, you have mentioned as 30-day mortality. Probably is wanting some clarity in that test.
Okay. So from what I've gathered from the UK, from the EU, cutoff that they have determined is the 30 days. Now, once a patient goes home, there should be mechanisms for follow-up to ensure that the patient is not deteriorating. Now, and that's within the protocols, the standard protocols of the country. However, where patients have been either discharged in the hospital or situation is, and the patient dies before the 30-day mark, then the hospital is penalized because to quality of care within the hospital. And then if it is beyond the 30-day mark, then that is okay. And so what happens is that for some, depending on how the scheme, in some cases the hospital loses funding, or if they had gotten funding prior, that funding returns.
So, thank you. Thanks to all. And thank you, sir. Thank you, ma'am. Thank you, Dr. Manju. Let us close for the day, so at least this session. Thank you, sir. Thank you.
I now request our Director, Dr. A. Somasundram, sir, to honor the speakers. Dr. Anand Krishnan, Professor, AIIMS, New Delhi. Dr. Grace, Technical Officer, World Health Organization. Dr. V.N. Manju. She leads a pilot initiative to strengthen mortality statistics through district CRS approach in Krishnagiri and Karur districts. Her work focuses on improving data quality and system integration to support evidence-based planning and policy. Thank you, sir. Thank you, ma'am.
Now we come to the last session of the day. DPH Icon 2025. Warmly welcome Dr. Shivakumar sir, CEO, and Mr. Ramji Raghavan, Management Consultant, Poultry Farmers Regulatory Committee for Tamil Nadu, to speak on role of egg and poultry in human nutrition. We welcome you, sir, to the dais.
Thank you. I would like to thank the Department of Public Health for giving us this opportunity. I know that this is the last presentation and you're all eagerly awaiting for the cultural programs to begin, so I will not stand in between your good times to come, but I will take the 10 minutes to present the most important aspect when it comes to public health is food. And within that category comes the eggs and chicken, and we represent the poultry industry in Tamil Nadu. So the Poultry Farmers Regulatory Committee overall represents the entire poultry production. So all the chicken, all the eggs you eat, we produce. So we come from that, and we also quite near to Salem, Namakkal, which is the egg producing capital of India. So that's our background, so taken back for the meat production and then retail sales, etc. So what are we going to talk about today is how this poultry plays a significant role in the human nutrition is what we are going to present. So as the slides can keep moving on, and I'll be talking about that. Context setting as to why we are that 90% of population are really not aware about the daily protein requirements. If you randomly pick up anybody and then ask them that, do you know how much protein you should eat? They may not be aware of that. Whether you should take 50 grams and where do I get that 50 grams of protein, which plant or animal source will give me that? People are generally not aware of that. And 73% of Indians are protein deficient. Can you imagine 73% of our population is protein deficient, and 10% in the children group aged to 5 to 9, and then in 10 to 19 are pre-diabetic. I was just sitting there and watching all the technical reports states about the mortality causes. Diabetes ranks among the top 3, if not, at the first. And then we as a country rank the lowest when it comes to the protein per capita consumption. We, for example, if you take a country like Taiwan, they consume about 47 kgs of protein in a year per capita consumption. We consume about 4 kgs. So you can see the big difference between the protein consumption of developed countries. The US consumes close to about 42 kgs in a year per capita consumption. If you take the nations which consume the maximum protein and that to that of the Olympic medals, there is a correlation. So the countries which consume more protein are basically performing better at the Olympic level itself. Now as far as egg is concerned, we produce maximum amount of eggs. We rank second in the world in terms of the egg production, so we have done extremely well. And in the last 40 years, with technology playing a significant role and research playing a significant role, we have come to this state. And then, as you all know, that Tamil Nadu government is a pioneer when it comes to providing egg every day to the school children as part of the midday meal program. This is the kind of production levels we have achieved over a period of time. I don't have to go really deeper into the nutritional value of egg, as I know that this is a conference of doctors. I don't have to tell the doctors what egg is actually all about. But nevertheless, for information and from the research findings, this data is presented. and it is an excellent source when it comes to, especially I was seeing that presentation on the pregnant women and then how we have to play a role in that. So this egg as a one source of protein not only provides protein but also the most crucial nutritional value, which is the iron. I'll come to the chicken production. Tamil Nadu alone places 1.4 crores of chicks every single week. Every single week 1 கோடியே 40 லட்சம் கோழி குஞ்சுகள் வந்து வளர்க்கப்படுகின்றன. நமக்கு கிட்டத்தட்ட வந்து 11.2 crore kgs per month. 11.2 crore kgs per month of chicken meat production is happening Tamil Nadu alone. So you can imagine the entire country. So this is the level of production which we are doing. And it is consumed widely. There is no restaurant, no hotel, no eateries without chicken. So why are we talking about it? Since it is occupying a very important role in our diet, we also have to understand that how this is produced, and also we can clear some of the myths and rumors people will generally associate when it comes to consuming chicken and eggs. From a chick of 42 grams to 45 grams, it grows to 2.250 grams, that is 2.2 kgs in about 40 days. So people generally associate a lot of things, that whether the chicken is given a hormone injection, whether it is given steroid injection to become, grow at a shorter duration of time. So as a medical community, we would like to establish the fact that people should be elevated from these unwarranted rumors which are playing around. Social media plays a big spoil sport. So there is no such thing which can make the chicken to grow. This is basically due to technology and advancement in the gene selection of the birds. It has taken close to about 45 years to produce the chicken as we see it today. With me, I have Dr. Shivakumar, who is an expert when it comes to the breeding of the chicken in the last 30 years. He will give you a rundown on the following slides as to what we do when it comes to production of these broiler chickens.
This is, we are having a lot of doubts about how chicken is growing very fast, how it is reaching weight 2 kg at the age of 40 days. A lot of questions were there. It is only because of crossbreeding only. We are in our breeding policy, there are 5 type of steps were there. First is pure line. In the pure line, we are selecting specific traits for each character, for body weight, for feed conversion, and disease resistance. For each and every trait, we are identifying the particular strain and we are crossing. That is called pure line. Then afterwards, there was a great grandparents, then grandparent stock and parent stock. Finally, the broiler will come out. Once we grow in your home, whatever you are purchasing in the market, if you grow in your home, at the age of 24th week, it will lay egg. But the outcome of the bird will be very less. The weight of the progeny will be very poor when compared to the 5th generation. So we are reaching a particular weight, that is 40 days 2 kg body weight, only because of crossbreeding and proper selection of birds. That is a continuous process. For the past 100 years of continuous crossbreeding, we have achieved that. Second, that is 56 days actual cycle. In the incubator, after we are keeping that eggs in the incubator for 21 days. After 21 days, we are placing the chicks in the farms again for 35 days. 35 days, the birds are reaching 2 kg body weight. Again, this is our breeder farm, well hygienically maintained, and we following all biosecurity measures to protect the birds, and all the we are following all vaccination schedules to protect the birds. Periodically, we are doing serological tests to monitor the diseases. The main difference between poultry and other large animal practice, canine practice, is we are doing diagnosing the disease only after the postmortem. like unlike in other large animal practice, by symptomatic treatment we can give. So only through postmortem only we are identifying the disease. That's why we are more proactive to tackle all the disease. We are doing ELISA and PCR test to monitor all the disease control programs. Strategy we are doing. Another thing, in the hatchery, we are maintaining in hygienic conditions and handling in a proper way. It is like ICU unit. In the advanced stage, we are doing in vivo vaccination. That is, we are doing vaccination in the hatchery itself. On the 18th day, we are injecting that vaccines, field vaccines in the amniotic fluid. Then, because of that, the birds are getting early immunity. More of a lot of misconception about the vaccination and other things. In the field also, we are giving vaccines. In the YouTubes and other things, they are misinterpreted that they are using hormone and other things. You know that hormone, testosterone is costing around 1 ml, ampule is around 250 to 300, 400 rupees. It is not affordable. But we are selling chicken at the rate of 150 per kg. How it possible? It's only through continuous breeding policies. This is our feed plant. This is one of the photograph. The birds is showing how much meat I am having. This is a rare picture. There are a lot of myths about broiler chicken. One of the myths is hormone growth promoters, and we are using. We are not using any hormones. It is over the 70, 100 years of continuous breeding policy, we reached that. During the 1930, the body weight is 2 kg. It will take 4 months, minimum 4 months to reach that body weight, and the feed consumption is 9.4 kg. Over the 195 years, now in the 2025, the 30 days the bird is reaching 2 kg and the feed consumption is 3.5 kg, and the days are reduced only because of continuous breeding policy, not because of any hormone and growth promoters. Major feed ingredients. What we are using is only for cereal parts, we are using maize and rice, and other things we are using soya bean cake, cotton seed cake, sunflower cake, that's all. That's the thing we are using. 3 type of feeds we are giving. For up to 10 days we are giving pre-starter. That is protein in that feed is around 22% protein we are giving up to 10 days of the chicks. Afterwards we are giving starter feed. In that the protein level we are giving around 20% protein and 2950 kilocalories energy. In the finisher feed, that is from 28th day onwards culling, we are giving feed with 20% protein or 19% protein with 3250 kilocalories of energy. This is because of this high nutritious diet only, the bird is reaching fast weight. Typical poultry feed, it's contain maize and rice mostly. That is for energy part we are using maize, and for protein source we are using soya bean cake. That's all. Then oils we are using. Typical poultry feed, that is broiler, we are giving complete vitamins, amino acids, all balanced. We are giving, that is vitamin A, D3, E, B1, B6, B12, with all the specifications we are giving all those things. Apart from that, we are giving trace minerals also. In that, Mr. Ramji will continue. 2 seconds. That is a lot of, we are not using any hormone. It was not approved, not used, not required, not possible. Yeah, okay.
We'll just finish in 2 minutes. This is a very important aspect. That's the reason why I just wanted to insist. The precocious puberty, there is a lot of misunderstanding in the public that, whether to consume chicken or not to consume chicken and all. We did a research. And then we found that there is absolutely no correlation, not only eating chicken, even any dietary aspect has got nothing to do with that. There is a research which was done by Ramachandra Institute of Higher Studies in Chennai, and the results we have done that. So we wanted to present this. We can send this paper also later to you. As public health professionals, it is very important that we reach the correct scientific information to the public. That's the reason why we are giving this. And another important thing is that since there is a lot of rural area, the pregnant women, what they do is they immediately, once they become conceived, they stop eating chicken. And that's exactly when they are supposed to eat chicken, because they think that eating chicken gives a body heat and stuff like that. So we work with a lot of rural areas, and then we educate them that the importance of eating chicken during their pregnancy time. I'll skip these things. I just would like to give the amino acid profile of chicken. So this is a research. This is the only research paper available. There is no other research paper available in India which has taken this information. So this is the amino acid profile of about 100 grams of chicken. So which means that I was discussing with Dr. Nirmalsan also that during pregnancy, especially between the weeks of 21 to 32, he was explaining me that how important it is to have the iron-based food sources. So providing this chicken 100 grams, even if it is twice a week, will go a long way in making sure that the deficiency in iron does not happen. So I just want to give you this information. And this is a comparison between different animal sources which are available in terms of protein. So chicken and egg is supposed to be the most affordable protein, which is most versatile for any class of people in the society. So I would like to appeal through this forum that the availability of chicken is not an issue. The affordability of chicken is also not an issue. But together, the industry, that is from our side, and also the medical community can come together and provide credible scientific information to the public and make sure that the public health through their dietary is taken care of. Thank you very much for this opportunity. Really appreciate it.
Thank you, sir. Now we warmly welcome our respected Joint Director, MCH, Dr. Nirmalsan sir, to honor the speakers with a memento. Thank you, sir.
From morning to dawn, we have been enlightened on various topics of public health today and hoping to meet you all with a bright morning smile tomorrow. Thank you.
அனைவருக்கும் மாலை வணக்கம். தற்பொழுது நேற்றைய வந்துட்டு ஏறக்குறைய ஒரு 25 கல்ச்சுரல் ப்ரோக்ராம்ஸ் நடந்துட்டு இருந்தது. ஸோ இன்றைய நாள் வந்துட்டு ஏறக்குறைய ஒரு 40 கல்ச்சுரல் ப்ரோக்ராம்ஸ் we are going to have. Almost ஒரு 25 districts are going to present today. ஸோ இது வந்துட்டு லாஸ்ட் இயர் மாதிரி இந்த வருஷம் we are organizing எக்ஸ்ட்ராவா ஒரு டீம் ஈவெண்ட்டுக்கு we are going to give the prizes for them, first, second, third, and individually the best performer also will be getting a shield. So with this, over to the stage. இது எந்த டீம்? இல்ல நீங்க டீம் பேர் மட்டும் So with this, we are going to start the cultural programs.
பல்துறை வித்தகர்களாம் நம் நிகழ்வுகள் இன்று அரங்கேற உள்ளன. பலத்த கைத்தட்டுடன் கலைஞர்களை உற்சாகப்படுத்துவோம். மேடையில் முதலாவதாக அரியலூர் மாவட்டம்
सत्य साक्षात्कारा सर्वभूताय सत्य साक्षात्कारा ओम शिवोहम रुद्रनामं भजेहम हर 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 महादेव अंड ब्रह्म कारण सत्य देव देव प्रिया वेद वेदार्थ सारा यज्ञ यज्ञोमया निश्चला दुष्ट निग्रह सप्तलोक संरक्षण सोम सूर्य अग्निलोचना श्वेत ऋषभ वाहना शूलपाणि भुजंग भूषण त्रिपुर नाश दर्शना व्योमकेश महासेन जनक पंचवक्त्र परशुहस्त नमः ओम शिवोहम ओम शिवोहम रुद्ररूपं भजेहम भजेहम त्रिनेत्र शूल त्रिशूल गात्रम् सत्य प्रभाव दिव्य प्रकाश मंत्र स्वरूप मात्रम् निष्प्रपंचादि निष्कलं मोह स्वप्रकाशोऽहम् सच्चित् प्रमाणम् ओमो मूल प्रमेयम् ओमो अयं ब्रह्मास्मि ओमो महं ब्रह्मास्मि ओमो गण 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 सहस्रगण शब्द विहरति नम 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 मनु 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 शिव नम गणान विहरति ओम शिवोहम ओम शिवोहम रुद्रनामं भजेहम वीरभद्राय अग्निनेत्राय घोर संहारः सकल लोकाय सर्वभूताय सत्य साक्षात्कारा
நன்று நன்று. வேகமான பாடலை தேர்வு செய்து வேகம் கூட்டியுள்ளீர்கள் நிகழ்ச்சிக்கு. அடுத்ததாக தனி நடனம்.
சின்ன சின்ன வண்ணக்குயில் கொஞ்சி
பாடிக்கொண்டே சொல் எண்ணத்தின் ஓசைகள் மாலை சூடி மஞ்சம் தேடி மாலை சூடி மஞ்சம் தேடி காதல் தேவன் சந்நிதி காண 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 சின்ன சின்ன வண்ணக்குயில் கொஞ்சி கொஞ்சி கூவுதம்மா புரியாத ஆனந்தம் புதிதாக ஆரம்பம் புரியாத ஆனந்தம் புதிதாக ஆரம்பம் பூத்தாடும் தேன் மொட்டு நானா நானா சின்ன சின்ன வண்ணக்குயில் கொஞ்சி கொஞ்சி கூவுதம்மா மேனிக்குள் காற்று வந்து மெல்லத்தானாடக் கண்டேன் மங்கைக்குள் காதல் வெள்ளம் கங்கை போல் ஓடக் கண்டேன் இன்பத்தின் எல்லையோ இல்லையே இல்லையே அங்கேயும் வந்ததால் தொல்லையே தொல்லையே காலந்தோறும் கேட்க வேண்டும் காலந்தோறும் கேட்க வேண்டும் பருவமென்னும் கீர்த்தனம் பாட 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 சின்ன சின்ன வண்ணக்குயில் கொஞ்சி கொஞ்சி கூவுதம்மா புரியாத ஆனந்தம் புதிதாக ஆரம்பம் புரியாத ஆனந்தம் புதிதாக ஆரம்பம் பூத்தாடும் தேன் மொட்டு நானா நானா சின்ன சின்ன வண்ணக்குயில் கொஞ்சி கொஞ்சி கூவுதம்மா சின்ன சின்ன வண்ணக்குயில் கொஞ்சி கொஞ்சி கூவுதம்மா
நிமிடத்தில் உடை மாற்றி வந்து நடனமாடிய VHN மகாசக்தி அவர்களுக்கும் அவரது மகள் பவதாரணி அவர்களுக்கும் மீண்டும் ஒரு கைத்தட்டல். அடுத்ததாக சோலோ டான்ஸ் பை கெனிஷா.
కావాలే చాలే ఇది చాలే నీకై నువ్వే వచ్చి వాడాలే ఇకపై తిరనాళ్ళే
பாட்டுனா சும்மா உச்சந்தலையில இருந்து உள்ளங்கால் வரைக்கும் சுருன்னு அப்படியே கரண்ட் பாயணும், அது பாட்டு.
அண்ணன பாச்சையே அப்பத்தி தேடே நா அப்பாத்தியா அப்பத்தி தேடே கூ அப்பாத்தி கோ அப்பத்தி கூத் 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 அப்பாச்சையே ரானோ பம்பை கி ரானோ ரானோ பம்பை கி ரானோ ఆ పిల్లగా ఎంకటేశు చూడకపోతుంటవో కానకపోతుంటవో నా పిల్లగా ఎంకటేశు చూడకపోతుంటవో కానకపోతుంటవో
இல்ல ஒரு 2-3 லைன் கொஞ்சம் வேற மாதிரி ட்ரை பண்ணலாம்.
புளிப்பா புளியங்க அவ புடவ கட்டுன வெள்ளரிக்கா
அயராது ஆடிய அரியலூர் VHN மகள் கெனிஷா அவர்களுக்கு மீண்டும் பாராட்டுகள். அடுத்ததாக அரியலூர் VHN அவர்களது பேரன் திரு கேசவ் அவர்களின் தனி நடனம்.
காற்று உன் நண்பர்களா மாற்று உன்னை போல நேசிக்கணுமே அத மாசில்லாம காக்க வேணுமே
நீர் நிலம் காற்று உன் நண்பர்களா மாற்று உன்னை போல நேசிக்கணுமே அத மாசில்லாம காக்க வேணுமே
ஏரி குளம் எதுவானாலும் உயிர் வளர்க்கும் சக்தி ஆகுது அதில் வாடும் உயிர்கள் முக்தி அடையுது
கடல் ஆறு ஏரி குளம் எதுவானாலும் உயிர் வளர்க்கும் சக்தி ஆகுது அதில் வாடும் உயிர்கள் முக்தி அடையுது
வறண்ட மண்ணில் பசுமை தரும் பாட்டும் வெயிலில் குளிர்ச்சி தரும்
வறண்ட மண்ணில் பசுமை தரும் பாட்டும் வெயிலில் குளிர்ச்சி தரும்
மழையின் பெருமை நாம் அறிவோமே அத வரவழைக்கும் கடமை செய்வோமே உப்பு தண்ணீர் கூட நல்லா நீரா மாத்தோம் இயற்கை குணம் நமக்கு வேணுமே நீராதாரம் காக்க புறப்படுவோமே நீராதாரம் காக்க புறப்படுவோமே நீர்நிலம் காற்று உன் நண்பர்களா மாற்று உன்ன போல நேசிக்கணுமே அத மாசில்லாம காக்க வேணுமே நிலமும் மாறுது அந்த விதைகள் வளர்க்கும் தாயா மாறுது
மண்ணில் விழும் விதைகள் எல்லாம் மடிவது இல்லை கருவறையா நிலமும் மாறுது அந்த விதைகள் வளர்க்கும் தாயா மாறுது
மனித உறவு மறைஞ்சு போகும் மண்ணு மட்டும் நினைச்சிருக்கும்
மனித உறவு மறைஞ்சு போகும் மண்ணு மட்டும் நினைச்சிருக்கும்
நிலத்தின் பெருமை நாம் அறிவோமே அதன் பலம் பெருக உழைச்சிடுவோமே
கொட்டும் குப்பையை கூட நல்ல உறவா மாற்றும் மண்ணின் தன்மை நமக்கு வேணுமே
அதன் வளம் கெடாம நாம பார்த்துக்கணுமே அதன் வளம் கெடாம நாம பார்த்துக்கணுமே நீர் நிலம் காற்று உன் நண்பர்களா மாற்று
நல்ல சமூக கருத்துள்ள பாடல், நல்ல நடன முயற்சி. வாழ்த்துக்கள் கேஷவ்.
அரியலூர் டீமிற்கு நினைவு பரிசு வழங்குமாறு ஜேடி இம்யூனைசேஷன் டாக்டர் வினய் அவர்களை அன்புடன் கேட்டுக்கொள்கிறேன். ஒரு பலத்த கரகோஷம் எழுப்பி அவர்களை வாழ்த்துவோம்.
Next we have a special performance by Jens Hana Afrin, daughter of Dr. B. Sharmila Banu from Tamamati. She achieved title Marvelous Memory Kit from India Book of Records at the age of 2 years. Achieved title Face of South India. Happy to have you, dear.
இறங்கி வந்தாச்சு கடல்ல கொந்தளிக்கும் சுனாமியே உண்டாச்சு மணிக்கா வெளுச்சி எதுக்கா எனர்ஜி தலைய சுத்த வைக்கும் சூறாவளி பொண்ணாச்சு பட்டுன்னு பார்த்தாலே பல்ஸ் ஏதும் பாடி கொட்டுபா மீன் எல்லாம் கூத்தாடுமே இரப கலராக்கும் ஜலேபி லேடி சால்ட்டும் நான் தொட்டா ஸ்வீட் ஆகுமே இருக்காத ஒத்தையில ஒத்தையில ஒரு வாட்டி சந்திக்கப்பா வாயங்காட்டி கண்டிக்கப்பா தயங்காத வெத்தையில வெத்தையில சாகும் நேரத்தில் புலம்பி அழுவாத பூஜா ஆட்டத்தில்
வா வா ஊது ஊது. வாங்க மோனிகா.
அருமை அஃப்ரீன், அரங்கத்தில் உங்களுக்கு ஃபேன்ஸ் ஜாஸ்தி ஆயிட்டாங்க. அஃப்ரீனுக்கு சான்றிதழ் வழங்குவதற்காக JDMCH அவர்கள் மேடையில். அடுத்ததாக திருவண்ணாமலை குழுவினரின் சிலம்பம். திருவண்ணாமலை குழுவினரில் 2 பங்கேற்பாளர்கள் திருவண்ணாமலை VHN மிஸ்ஸஸ் ஷர்மிளா அவர்களின் புதல்வர்கள். இதில் முசாமில் நேஷனல் லெவல் சிலம்பம் போட்டியில் 3 முறை வின்னராக வந்தவர். முதாசிர் நேஷனல் லெவல் சிலம்பம் போட்டியில் 1 முறை வின்னராக இருந்தவர். பாக்ஸிங்கில் முதாசிர் நேஷனல் லெவல் பிரான்ஸ் மெடல் வாங்கியவர். கராத்தேவில் முசாமில் பர்பிள் பெல்ட்டும் முதாசிர் ஆரஞ்சு பெல்ட்டும் பெற்றவர்கள். கரகோஷத்துடன் அவர்களை வரவேற்போம்.
மதுர வீரன் தானே, அவனை உசுப்பி விட்ட வீணே, இனி விசிலு பறக்கும் தானே, என் பேராண்டி மதுர வீரன் தானே. சிங்கம் போல நடந்து வரான் செல்ல பேராண்டி, அவனை சீண்டியவன் தாங்க மாட்டான் உதையல்ல தாண்டி. எத்தில்லா டாங்கு டாங்கு சும்மா திருப்பி போட்டு வாங்கு, எத்தில்லா டாங்கு டாங்கு சும்மா திருப்பி போட்டு வாங்கு. சியா ஜியா ஜினுக்கு இவனை புத்தூருக்கு அனுப்பு, சியா ஜியா ஜினுக்கு இவனை புத்தூருக்கு அனுப்பு.
சூறாவளி காத்தா சுழண்டு சுழண்டு ஆடு, கட்ட உந்த கோவில் மாட்டா திமிரு திமிரு எகுரு. கூத்த தொடங்கு தொடங்கு கொட்டாடிச்சு நொறுக்கு, கொளுத்து வெயில போல பொழுது கிளம்ப ஆடு. தந்தாங்கண்ணா பிக்கா கதைய முச்சு விடு, ஃப்ரெண்ட்ஷிப்பா வந்தாங்கண்ணா பாட்டி குத்து விடு. ரூத்லெஸ்ஸா நின்றாங்கண்ணா ஹார்ட்லெஸ்ஸாக தட்டி விடு. ஏன் ஆளத்தான் தோட்டணும்னா என்ன நீ காட்டி போடு. நக்கல்தான் நக்கல்தான் நக்கல் பவர்தான், நிக்கல்தான் நிக்கல்தான் நின்று பாரு எதிரதான். ஜபர்தான் ஜபர்தான் பஞ்சு விட்டா அதிர்தான், மட்டன்தான் மட்டன்தான் மாட்டிக்கிட்டா மட்டன்தான். GPU mame God bless you blaster. GPU mame God bless you blaster. எல்லா டூட்ஸுக்கும் சொல்லிக்கிறேன் நான் பார்த்துட்டு பல டூல்ஸ். ஸ்கெட்சா போட்ட சம்பவம் 6 மணிக்கு ஃபிளாஷ் நியூஸ். செஞ்சா தப்பா அலச பார்த்தா மாட்டாது ஒரு ஜூஸ். நீ சிரிச்சு பேசி கால வர மீறப்பட்ட ரூல்ஸ். பாக்கி வச்சு வரும் சத்தம் எனக்கு தாளாட்டு பாட்டு. கத்திய வருஷம் போது வரும் சவுண்டு மெலோடி கேட்டு. நுண்சாக் சுத்தின முன்ன கதற விட்டுவன் கேட்டெல்லாம் போட்டு. என்னதான் பண்ணாலும் என் மேல உனக்கு வராது ஹேட்டு. ஏன்னா கியூட்டு வைட்டு சால்ட்டு பத்திர செதுக்கப்பட்ட செல்ல எங்க ஆள ஊருக்குள்ள கொஞ்சம் கூப்பிட்டு மொத்தம். GPU mame God bless you blaster. GPU mame இருக்கிற வரகில எவனுக்கு முடிவுன்னு தெரிஞ்சுக்க வழி இருக்கா. இவன் பறக்கிற திசையில தெரிகிற எதிரிய முடிச்சிட்டு மன்னவ போல் சிரிப்பான்.
வந்தேன் பெண்ணை தொட்டும் வந்தேனே இந்த மண்ணில் ஏதோ ஒன்று வெற்றுமொழி சொற்கள் எல்லாம் கேட்டுக்கொண்டே வந்தேனே என் தமிழில் ஏதோ ஒன்று
பிரிந்திடும் வரை இதன் பெருமைகள் எதுவும் அறிந்திடவில்லை நெஞ்சம் மறுபடி பதத்தினை நான் பாதிக்கும் பொழுது சிலிர்க்குது தேகம் கொஞ்சம் நரம்புகள் அனைத்திலும் மரம் எனும் உரம்தான் உலகத்தின் முதல் நிறம் தமிழ் நிறம்தான் 7 கோடி முகம் ஆனால் ஒரே ஒரு பெயர்தான் அது வெறும் பெயர் இல்லை எங்கள் உயிர்தான் தமிழன் என்று சொல்லடா தலை நிமிர்ந்து நில்லடா தரணியை நீ வெல்லடா தமிழன் என்று சொல்லடா தலை நிமிர்ந்து நில்லடா தரணியை நீ வெல்லடா தமிழன் என்று சொல்லடா தலை நிமிர்ந்து நில்லடா தரணியை நீ வெல்லடா தமிழன் என்று சொல்லடா தலை நிமிர்ந்து நில்லடா தரணியை நீ வெல்லடா
பீஸா பகல் உண்டு வந்தேன் பாஸ்தா தின்று வந்தேனே இட்லியில் ஏதோ ஒன்று ராக் அண்ட் ரோல் கேட்டு வந்தேன் ஜாஸில் மூழ்கி வந்தேனே நம் வரையில் ஏதோ ஒன்று
உறவுகள் என்னும் சொல்லின் அர்த்தம் கண்டு பிடிக்க வேறு இடம் மண்ணில் இல்லை மொழி வெறும் மொழி இல்லை பழி என்று உரைத்த வேறு இனம் எங்கும் இல்லை நரம்புகள் அனைத்திலும் மரம் எனும் உரம்தான் உலகத்தின் முதல் நிறம் தமிழ் நிறம்தான் 7 கோடி முகம் ஆனால் ஒரே ஒரு பெயர்தான் அது வெறும் பெயர் இல்லை எங்கள் உயிர்தான் தமிழன் என்று சொல்லடா தலை நிமிர்ந்து நில்லடா தரணியை நீ வெல்லடா தமிழன் என்று சொல்லடா தலை நிமிர்ந்து நில்லடா தரணியை நீ வெல்லடா
சூறாவளிடா நாங்க தொட்டாலே சீரும் புலிடா ஏறி அடிடா ஊரு ஒன்னாக வெட்டு வெடிடா சூறாவளிடா நாங்க தொட்டாலே சீரும் புலிடா ஏறி அடிடா ஊரு ஒன்னாக வெட்டு வெடிடா உடம்போட அடுமடா காலு எழுதி மாலாது எங்க வரலாறு பால் எடுத்து வகுடு எடுத்து சீவும் சீமடா எங்க தெற்கு தசக்காரனுக்கு புல்லும் வாழுடா நிமிந்து நின்னா கருது நேர்மை இன்னா மருது நிமிந்து நின்னா கருது நேர்மை இன்னா மருது சூறாவளிடா நாங்க தொட்டாலே சீரும் புலிடா ஒரு ஒன்னாக வெட்டி வெடிடா
சொந்தாங்க தரலாங்க சாங்க உள்ளார வந்தானா பொல்லாத வேங்க திமிராம வாங்க பல்பாயிடுவீங்க முறப்போட நிப்பானா முட்டாம போங்க எத்தான் நந்து வரா கேட்ட எல்லாம் கண்டு வரான் வெடிய ஒண்ணு போடுதில்லால ஸ்ரீவ சுருட்டி வரான் காலரத்தான் பெரட்டி வரான் முடிய சில்பி விட்டா யாரும் உள்ளார மரணம் அசு மரணம் டப்பு தரணும் அதுக்கு அவன்தான் போற
சிலம்பத்தில் தாம் பெற்ற திறமையை நடனமாக்கி நம்மை மகிழ்வித்த முதாசிர் முசாமில் அவரது தாய் ஷர்மிளா அனைவருக்கும் நல்வாழ்த்துக்கள்.
திருவண்ணாமலை டீமுக்கு நினைவு பரிசுகள் வழங்குகின்றார்.
அடுத்தபடியாக ஆத்தூர் சுகாதார மாவட்டத்திலிருந்து குழு நடனம் பிளாசம் டீம் அவர்களை வரவேற்கிறோம். மிஸ்டர் சுசீலா, சுமதி, கவிதா.
Andali
அடடடடடடா, என்ன ஒரு டான்ஸ்! பின்னாடி திரும்பி பாருங்களேன், ஆடியன்ஸ் சேர்ந்து ஆடுறாங்க. மேம், நீங்களுமா?
இப்படியெல்லாம் ஆடினா கூட ஆடதான் தோணும். அடுத்தபடியாக ரூபி டீம் குரூப் டான்ஸ். ஆத்தூர் சுகாதார மாவட்டம்.
பங்கு புட் த சாங்.
Bye.
மாமா, உங்க ஆட்டத்துக்கு ஊரே ஆடுமே, அதுக்கு ஒரு அடிய போட்டு விடுவோம்.
வளையப்பட்டி தவில தவில சுடல் பந்தி வைக்கும் அவல மவல அடிச்சு முக்கி போட்ட மயில மயில என்ன மாய தெரிய மாய தெரிய மாய தெரிய வளையப்பட்டி தவில தவில சுடல் பந்தி வைக்கும் அவல மவல அடிச்சு முக்கி போட்ட மயில மயில என்ன மாய தெரிய மாய தெரிய
நீநாதஸ்வரம் போல வந்தா நீநாதஸ்வரம் போல வந்தா நாவே கமலம் நானா நீ ஏழஸ்வரம் போல வந்தா எட்டஸ்வரம் நானா எட்டஸ்வரம் நானா
வளையப்பட்டி தவில தவில சுடல் பந்தி வைக்கும் அவல மவல அடிச்சு முக்கி போட்ட மயில மயில என்ன மாய தெரிய
நான் கேட்டது ஆனா அவர் எனக்கு கொடுத்தது
இது சப்பா பீட்டு கொளுத்துக்கடா.
ஆத்தூர் பட்டே கிளப்பிட்டீங்க போங்க. எங்க எங்க ரஞ்சிதங்களே, ஹரி, நிவேதா, மீனா, நிவேதினி, அபிதா, நன்றிகள் பல.
கலை நிகழ்ச்சிகளுக்காக மேடை ஏறுற முதலாவது மருத்துவர், கல்லூரி காலத்திலேயே நடனத்திற்காக பல பரிசு பெற்றவர், ஆத்தூர் ஹெச்ஓடியோட டாக்டர் கவின்குமார். நேத்து கலை நிகழ்ச்சிகள் தொகுத்து வழங்கும் போது ஆட ஆரம்பிச்ச இவரோட கால்கள் இப்போ மேடையில நமக்காக.
கண்ணிறைந்த காதலனை காண
நம்மளை பத்தி தெரியல. அபி தேக்கோ చూపిస్తాను.
से चाह से मिटा मुकाबला
most importantly, rules and regulations. எங்களுக்கு இல்லை.
அப்புறம் நான் உங்ககிட்ட விளையாட்டா பேசுற புறாடிக்கு நம்பிட்டீங்க. ஐயோ ஐயோ.
இல்ல ஒரு 2-3 லைன் கொஞ்சம் வேற மாதிரி ட்ரை பண்ணலாம்.
ரைட்லா ரைட் இருந்தா ஊருக்கு இல்லைன்னா சாமிக்கு. என்னடா அங்க சத்தம்? இந்த கிளம்பிட்டேன் இந்த கிளம்பிட்டேன்.
கவின் பட்டையை கிளப்பிட்டீங்க போங்க. டாக்டர் கவின் அவர்களுக்கு இன்னும் திருமணம் ஆகவில்லை. இப்பொழுதுதான் வீட்டில் பெண் பார்த்து கொண்டிருக்கிறார்கள். ஒரு சுவாரஸ்யமான தகவல்.
2 மணி நேர பயிற்சியில இவ்ளோ ஆட முடியுமா?
ஆத்தூர் டீம் இருக்கு.
Applications invited.
ஆத்தூர் DHO யோகானந்த் ப்ளீஸ் கோ டு தி ஸ்டேஜ். ஸோ இந்த டீமுக்கு நினைவு பரிசனை வழங்குமாறு JD டான்சாக் டாக்டர் போஸ்கோராஜ் அவர்களை அன்புடன் அழைக்கின்றோம். ஹோஸ்ட் டீம் கொஞ்சம் பார்த்து பண்ணி கொடுங்க போஸ்கோஜி.
அடுத்ததாக வரிசை எண் 3 கோயம்புத்தூர் டீம் தயாராக இருக்கவும்.
நன்றி நன்றி நன்றி. அடுத்த டீம்
அடுத்ததாக கோயம்புத்தூர் டீம் ஃபியூஷன் டான்ஸ் ஆட வருகிறார்கள். துர்கா, நிஷாந்த், ரகுநாத், மணிகண்டன் அண்ட் பவேயா.
அலை கடலான திரண்டு வந்து ஆர்ப்பாட்டமே இல்லாமல் இங்கு அமைதியாக அமர்ந்திருக்கும் என் ரசிக பெருமக்களே, உங்கள் எல்லோருக்கும் என் அன்பார்ந்த முதல் வணக்கம். அம்மா தாண்டா அந்த வீட்டுக்கு மெயின். டெல்லியில போய் படிச்சுட்டு வருது.
மொத்தத்துல பொண்ணுன்னா அவதான் அடையாளம். அதுதான் ஹைட்டு, அதுதான் வெயிட், செஞ்சு வச்ச சிலை மாதிரி.
இங்கே இங்கே ஒரு மழலை மன்றோடான் உன் கையின் காம்பில் போனான் நம் காதல் யாவும் தீர்ந்தான்.
பூவே பூவே நீ போதை கொள்ளும் ஆடும் மரம் காற்றை போல ஓடும் உரை காதல் கண்கள் தேடும். உன் சில அழகை விழிகள நான் வியந்தேன் இவருடன் சேர்ந்த ஆடு சென்றல்லா.
ஏன் நிறுத்தி விட்டாய் நீலவணி? உலக்கை உடையும் முறையாடு, உரல் உருள் முறையாடு, வீடு இடியும் முறையாடு.
இறங்கி வந்தாச்சு கடலை கொந்தளிக்கும் சுனாமியே உண்டாச்சு. மணிக்கா வெளுச்சி எதிப்பா எனர்ஜி தலையை சுத்த வைக்கும் சூறாவளி பொண்ணாச்சு. பட்டுன்னு பார்த்தாலே பசேக்கும் பாடி கொட்டுபா மீனெல்லாம் கூத்தாடுமே. இரப கலராக்கும் ஜலேபி லேடி சால்ட்டும் நான் தொட்டா ஸ்வீட் ஆகுமே.
ரசா நவுறா இப்ப பர்றா.
Red and white, ready to dance. என்ன மாசு பண்ணிட்டீங்க போங்க.
கூடுதல் இயக்குனர் விஜயலட்சுமி அவர்களை நினைவு பரிசு வழங்குமாறு அன்புடன் கேட்டுக்கொள்கின்றேன்.
ஒரு அறிவிப்பு. மேலே கேலரியில் அமர்ந்திருப்பவர்களுக்கு LED பேனல் அமைத்திருக்கிறார்கள். வயர் சப்ளைலாம் இருக்கனால கொஞ்சம் பின்னாடி தள்ளி நில்லுங்க. உங்களோட பாதுகாப்புக்காக தான் இது.
அங்க மேல இருக்கிற ஸ்டூடெண்ட்ஸ் அண்ட் பார்ட்டிசிபென்ட்ஸ் கொஞ்சம் அப்படியே அந்த ஃபர்ஸ்ட் ரோலே வராதீங்க, அதில் டச் பண்ணாதீங்க. தம்பி தம்பி அந்த கடைசியில் இருக்கிற தம்பி அப்படியே கொஞ்சம் பின்னாடி போங்க. மேல கேலரியில் உட்காந்துருக்கிறவங்க அந்த ஃப்ரண்ட்டுக்கே வராதீங்க, கொஞ்சம் பின்னாடி போய்க்கோங்க.
கோயம்புத்தூர் டிஹெச்ஓ மேடைக்கு வருமாறு அன்புடன்
கோயம்புத்தூர் சிஹெச்ஓ கோயம்புத்தூர் சார்பாக சிஹெச்ஓ ப்ளீஸ்.
அடுத்ததாக தர்மபுரி டீம் தயாராக இருக்கவும். Dharmaburi fusion dance by Maria and Vinci Jamuna Rani.
கதகளி கதகளி கண்களில் பார்க்கிறேன், காதல் கதகளி கண்களில் பார்க்கிறேன், திருவோணம் திருவிழா இதயத்தில் பார்க்கிறேன், வாக்கு மரங்களை கழுத்தில் பார்க்கிறேன்.
नगाड़े संग ढोल बाजे हाय धाय धम धम धाय, नगाड़े संग ढोल बाजे हाय धाय धाय धम धाय। ये धिन तड़ाक आजा उड़ के सराट पैरों से बेड़ी जरा खोल, नगाड़े संग ढोल बाजे हाय धाय धम धम धाय, नगाड़े संग ढोल बाजे हाय धाय धाय धम धाय। ஏடளவு எண்ணத்தில எடுத்தளவு சிக்கல் மச்சான், அளவு கோலே இல்ல அதுதான் ஊரு மச்சான், நாம 4 பேருக்கு நன்மை செஞ்சாலே அதுவே போதும் மச்சான், நாடளவு கஷ்டத்தில நகத்தளவு இஷ்டம் மச்சான், அளவு கோடே இல்ல அதுதான் நேசம் மச்சான், நாம மாண்டே போனாலும் தூக்கி தீ வைக்க உறவு வேணும் மச்சான். ஸ்வீ ஸ்வீ
ஒன்ன போல முத்து நாணி முத்து மூடாத என்ன பார்த்து
ஜமுனா ஜவு மிட்டாய் ஜந்துன்னா துள்ளாத நீ லவனா என்ன சொல்லு லாவாவா சுமாரிலே.
ஐயோ நீ பொறியடி அல்வாவும் தரியடி.
தன்னானே தாமரப்பூ மாமா தள்ளாடும் தண்ணியில, தாமர பூத்திருச்சே மாமா தாவணி வாங்கி வாங்க, ஊரெல்லாம் கூட்டிக்கிட்டு வந்திடுங்க மேளம் கொட்டி.
ஏதம்மானே தாமர பூக்குள்ள தள்ளாடும் தண்ணீர், தாமர
பச்சை பூவும் ஆடிடுச்சே போடி நான் வாழ்ந்து கெட்ட செய்தி இது தாண்டி வடக்காத்து இழுக்குதடி வாச தாண்ட முடியலடி வடக்காத்து இழுக்குதடி வாச தாண்ட முடியலடி என்ன செய்வேன் நான் என்ன செய்வேன் ஒரு ஒட்டச்சி நான் என்ன செய்வேன் என் ஒண்டி வீர இல்லாம என்ன செய்வேன் காட்சி கருங்காடா காலெல்லாம் வழிதான் பேச்சு வெறும் பேச்சு வேகம் எங்க போச்சு நீ உடச்சு கிளம்ப வேணும் வசக்கா பறக்க வேணும் ஒட்டச்சி எழுந்திரி எங்கோண்டி வீர நீ தாண்டி நீ தாண்டி நீ தாண்டி நீ தாண்டி 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 நம்ம கொண்டி பறக்கிற காலம் வந்தாச்சு வெற்றி வெட்டி வெட்டிக்கிற நேரம் வந்தாச்சு நம்ம கொண்டி பறக்கிற காலம் வந்தாச்சு வெற்றி வெடி வெடிக்கிற நேரம் உண்டாச்சு அட ஆடியா
அருமை அருமை தர்மபுரி அருமை.
அடுத்ததாக தர்மபுரி குழுவினரின் சோலோ டான்ஸ், மரியா அவர்களின் சோலோ டான்ஸ்.
நீயும் நானும் சேர்ந்தே செல்லும் நேரமே நீலம் கூட வானில் இல்லை எங்கும் வெள்ளை மேகமே போக போக ஏனோ நீளும் தூரமே மேகம் வந்து போகும் போக்கில் தூரல் கொஞ்சம் தூரமே நச்சம் ஆசை எல்லாமே தள்ளி போகட்டும் இந்த இன்பம் துன்பகல் இரவு நீ கதை நிலவு என் வெயில் மழையில் உன் குடை அழகு நான் பகல் இரவு வேண்டுமே இந்த நிலையிலும் எனக்கென நீ போதுமே. கொஞ்சம் மைனக்களே கொஞ்சம் மைனக்களே என் குரல் கேட்டு ஒன்று கூடுங்கள் கொஞ்சம் மைனக்களே கொஞ்சம் மைனக்களே என் குரல் கேட்டு ஒன்று கூடுங்கள் கொஞ்சம் ஆசை கொஞ்சம் கனவு இவை இல்லாமல் வாழ்க்கையா நூறு கனவுகள் கண்டாலே ஆறு கனவுகள் பழிக்காதோ கனவே கை சேருவா கொஞ்சம் மைனக்களே கொஞ்சம் மைனக்களே என் குரல் கேட்டு ஒன்று கூடுங்கள் பிச்சிப்பூ மலக்காடாங்காடா நான் பித்த கண்ட பூ காடா காடா வச்ச பூவும் வாடிடுச்சே போடி நான் வாழ்ந்து கெட்ட செய்தி இது தாண்டி வடக்காத்து இழுக்குதடி வாச தாண்ட முடியலடி வடக்காத்து இழுக்குதடி வாச தாண்ட முடியலடி என்ன செய்வேன் நான் என்ன செய்வேன் ஒரு ஒத்தச்சி நான் என்ன செய்வேன் என் ஒண்டி வீர இல்லாம என்ன செய்வேன் காட்சி கருங்காடா காலெல்லாம் வழிதான் பேச்சு வெறும் பேச்சு வேகம் எங்க போச்சு நீ உடச்சு கிளம்ப வேணும் வசக்கா பறக்க வேணும் ஒட்டச்சி எழுந்திரி எங்கோண்டி வீர நீ தாண்டி நீ தாண்டி நீ தாண்டி நீ தாண்டி 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 நம்ம கொண்டி பறக்கிற காலம் வந்தாச்சு வெற்றி வெட்டி வெட்டிக்கிற நேரம் வந்தாச்சு நம்ம கொண்டி பறக்கிற காலம் வந்தாச்சு வெற்றி வெடி வெடிக்கிற நேரம் உண்டாச்சு தீ வச்ச கோபத்தை நீ நட்டி பொட்டுல உருட்டு உன்ன உதய உலகத்தை நீ உள்ளங்கையில சுருட்டு வரப்போ தோணி இல்ல துணி ஜாலை எது எல்லை எட்டுது வானம் எட்டுது வெட்டி கதை தேவையில்ல வெக்கம் கெட்டா ஒண்ணு விட சுத்தாங்கல்லு பொட்ட புள்ள சரண கெட்டா குத்தவில்ல பொத்தி பொத்தி வளர்ப்பாங்க பொண்ணு கொண்டு புதப்பாங்க அங்க இங்க முளைச்சாலும் ஆணி வேற அறுப்பாங்க வெடிக்கிற நேரம் வந்தாச்சு நம்ம கொண்டி பறக்கிற காலம் வந்தாச்சு வெடி வெடிக்கிற நேரம் உண்டாச்சு தீ வச்ச கோபத்தை நீ நெத்தி பொட்டுல உருட்டு உத உதையில் உலகத்தை நீ உள்ளங்கையில சுருட்டு வரப்போ தோணி இல்ல துணி ஜாலை எது எல்லை எட்டுது வானம் எட்டுது
உங்க வீட்ல பெண் குழந்தைகளுக்கு வீரம்னா என்னன்னு சொல்லி கொடுங்க. வீரம் இருக்கக்கூடிய பெண் குழந்தைங்களை மதிக்கிறதுக்கு ஆண் குழந்தைங்களுக்கு சொல்லி கொடுங்க. எந்த வீட்ல தாய் தன்னுடைய மகனுக்கு பெண்களை மதிக்கணும்னு சொல்லி கொடுக்குறாளோ அந்த உலகத்துல அந்த வீதியில அந்த தெருவில் இருக்கக்கூடிய பெண்கள் எல்லாம் எந்த பயமும் இல்லாம இருப்பாங்க அப்படின்னு சொன்னார். பெண்களுக்கு ஏதாவது உதவி செய்யும் பொழுதோ ப்ளீஸ் ரிமெம்பர் எனி கண்ட்ரி தட் ரெஸ்பெக்ட்ஸ் விமன், எனி கண்ட்ரி விச் செலிப்ரேட்ஸ் விமன், எனி கண்ட்ரி விச் ஹோல்ட்ஸ் விமன் as very big part.
யாரும்மா நீங்க எங்களை ஆடவும் வைக்கிறீங்க அழுவவும் வச்சிட்டீங்க போங்க.
தருமபுரி DHO and MHO please be on the stage. தருமபுரி டீமுக்கு நினைவு பரிசு வழங்குவதற்காக நமது கூடுதல் இயக்குனர் எவர் ஹேண்ட்சம் அவர் one and only Dr. Gerald sir, please come over to the stage sir.
நமது LED கன்சோல் ஆபரேட்டர் மிஸ்டர் சுரேஷ் அண்ட் டீம் அவர்களுக்கு ஒரு பிரம்மாண்ட கரவொலி கொடுக்கலாம். ஏன்னா பேக்ரவுண்ட் வீடியோ கிராபிக்ஸ் மிக அருமையாக கொடுத்தாங்க இந்த பாட்டுக்கு. வாழ்த்துக்கள் சார், வாழ்த்துக்கள்.
அடுத்ததாக தர்மபுரி மாரண்டஹள்ளி A&M ஸ்கூல் குழு நடனம் தயாராக இருக்கவும். வரிசை எண் 5 தர்மபுரி மாரண்டஹள்ளி A&M பள்ளியின் குழு நடனம். மார்கரெட் சாந்தி, லக்ஷ்மி, வான்மதி, கோமதி, லக்ஷ்மி, சாந்தி, லீலா காஞ்சனா, சத்யா, மலர், வெண்ணிலா அவர்களின் குழு.
நடனம் அழகுன்னா அவங்க உடை அலங்காரம் அழகோ அழகு.
ஏஎன்எம் மாரண்டஹள்ளி ஏஎன்எம் பிள்ளை ஏஎன்எம் ஸ்டூடெண்ட்ஸ்க்கு நினைவு பரிசனை கொடுப்பதற்காக கூடுதல் இயக்குனர் டாக்டர் நாகராணி அவர்களை அன்புடன் அழைக்கின்றோம்.
அடுத்ததாக வரிசை எண் 6 திண்டுக்கல் குழுவினர் குழு நடத்துவதற்கு தயாராக இருக்கும்.
எளிமையான பாடலை
அடுத்ததாக திண்டுக்கல் குழுவினரின் குழு நடனம் மிஸ்ஸஸ் அனிதா, மிஸ் திவ்ய பாரதி, மிஸ்ஸஸ் கமலா, மிஸ்ஸஸ் கவிதா மேரி, மிஸ்ஸஸ் ரேவதி, மிஸ்ஸஸ் சத்யா, மிஸ்ஸஸ் சிவானி, மிஸ்ஸஸ் டோனி விண்ணரசி, மிஸ்ஸஸ் கிளாரா.
திண்டுக்கல் DHO BMO தாடிக்கொம்பு.
திண்டுக்கல் டீம் தூள் கிளப்பிட்டீங்க போங்க. உங்களுக்கு பாடல் தேர்வு செய்து கொடுத்தவர்களுக்கு ஒரு தனி பாராட்டுக்கள்.
அடுத்ததாக ஈரோடு குழுவினர் வரிசை எண் 7 ஈரோடு குழுவினர் குழு நடனத்திற்கு தயாராகவும். ஈரோடு குழுவினர் கோசலை ரமணி, கௌசல்யா, மலர்கொடி, பிருந்தா, ஜெயலட்சுமி.
வணக்கம் வணக்கம், நான் வாழும் பூமிக்கு வணக்கம். இருக்கோ இல்லையோ தெரியாது, ஒருவேளை இருந்தா சாமிக்கு வணக்கம். குத்த வச்சு கூத்து பார்க்கும் உங்களுக்கு வணக்கம். உச்சியிலே வந்து பார்க்கும் நிலாவுக்கும் வணக்கம். பரம்பரை சொல்லி தந்த பாட்டுக்குந்தான் வணக்கம். நான் பறை கொட்ட தோல் தந்த மாட்டுக்குந்தான் வணக்கம். வணக்கம் வணக்கம் வணக்கம். சன்னல் வழி தாண்டவ கோனே, என் பழைய காலம் தெரியுதடா தாண்டவ கோனே. புத்தம் புது பாட்டு வந்தா தாண்டவ கோனே, என் ரத்தம் எல்லாத்தையும் குடிக்கும் தாண்டவ கோனே. தப்படுத்து அடிக்கையிலே தாண்டவ கோனே, என் நெத்தியிலே கிடுகிடுக்கும் தாண்டவ கோனே. மாட்டு வாழை புடிச்சி மாட கோளம் கடந்து தாமர பூ பறிச்சு தந்தேனையா எம்மச்சினிக்கு. ஆமஞ்சி வீரட்டுக்குள்ள மயில கால அடக்கி தங்க செயின் எடுத்து தந்தேனையா என் தங்கத்துக்கு. ஏன் ஆனந்திக்கு பிடிக்கும் முன்னு ஆலமர பொந்துக்குள்ள ஆதியில புடிச்ச கிளி ஆதியிலே பறந்துருச்சே என் பச்சை கிளி. அது பறந்த பின்னே நான் ஒத்த கிளி நாள செத்த கிளி.
ஈரோட டீம் உங்க புன்னகை அழகா உங்கள் நடனம் அழகான்னு குழம்பிட்டோம்.
ஈரோடு அணியினருக்கு நினைவு பரிசனை வழங்குவதற்காக எவர் யூத்
அடுத்ததாக வரிசை எண் 8 கள்ளக்குறிச்சியை சார்ந்த சத்யா தனி நடனத்திற்காக.
அருமை அருமை சத்யா, அருமையாக ஆடினீர்கள்.
அடுத்ததாக வரிசை எண் 9 காஞ்சிபுரம் டீம் ஃபியூஷன் டான்ஸிற்கும் கரோக்கிக்கும் தயாராகவும்.
சேர்ந்து உத்திரமேரூர் பேரூராட்சிக்கு வழங்கப்படுகிறது.
The best performing town panchayat, the first place is awarded to Uttiramerur of Kanchipuram district.
திருச்சிவனல்லே திரிக்க விட்டான் மன்னல்லே திருத்தி வைக்கான் மன்னல்லே திட்டம் உண்டல்லே சேட்டன் மன்னல்லே சேட்ட செய்ய மன்னல்லே பேட்ட துளான் மன்னல்லே வேட்டையனல்லே.
தங்க நேரத்துக்கு தான் தமிழ்நாட்டை எழுதி தரட்டுமா, உன் கண்ணு அழகுக்கு தான் கன்னட நாட்டை வாங்கி தரட்டுமா. தங்க நேரத்துக்கு தான் தமிழ்நாட்டை எழுதி தரட்டுமா, உன் கண்ணு அழகுக்கு தான் கன்னட நாட்டை வாங்கி தரட்டுமா. நீ பார்க்கும் பாதைக்காக பஞ்சாபையே கேட்கட்டுமா, நீ காட்டும் அன்புக்காக ஆந்திராவை கேட்கட்டுமா. உத்தரவை சொல்லிவிடு உப்பி தேசம் உனக்குதான்.
நான் மறுபடியும் கேட்கிறேன், ராஜசேகர் சாகரப்போ தயாளு காதல ஏதோ சொன்னா, என்ன சொன்னான்னு யாருக்காவது தெரியுமா?
ஐயா அவன் பூ பூன்னு 4 தடவை ஊதிட்டு செத்தாயா.
நன்றாக ஆடினீர்கள் காஞ்சிபுரம் டீமில் ஒருவர் டாக்டர் பத்மாவதி. இவர் சாலவாக்கம் PHCயில் பணிபுரிகிறார். இவர் தன்னுடைய பள்ளி காலத்திலிருந்தே நடனத்தில் ஆர்வம் கொண்டு கலந்து கொள்பவர். பள்ளி முதல் கல்லூரி வரை நம்முடைய மேலும் துறை ரீதியான கலை நிகழ்ச்சிகளிலும் DPH ஐகான்களிலும் கலந்து கொண்டு சிறப்பித்துள்ளார். அடுத்ததாக டாக்டர் ராஜராஜேஸ்வரி அவர்களின் கரோக்கி. இவர் காஞ்சிபுரம் அரசு மருத்துவமனையில் உதவி மருத்துவராக பணிபுரிகிறார். பிறந்து வளர்ந்தது அனைத்தும் மும்பை என்ற போதிலும் தமிழ்நாட்டில் திருமணம் செய்து கொண்டு தமிழை கற்றுக்கொண்டு பாடல் பாடுகிறார்.
Good evening to all.
பார்த்து
Thank you so much.
காஞ்சிபுரத்து ஸ்ரேயா கோஷல் இன்று சேலத்தில் வந்து தங்களுடைய திறமையை வெளிப்படுத்திக் கொண்டிருக்கிறார்.
அடுத்ததாக வரிசை எண் 10 கிருஷ்ணகிரி குழுவினர் குழு நடனத்திற்கு தயாராகவும்.
அனைத்து அணிகளுக்கும் ஒரே நிமிஷம் அனைத்து அணிகளுக்கும் ஒரே ஒரு வேண்டுகோள். காலத்தின் அருமை கருதி இன்னும் 40 ப்ரோக்ராம் இருக்குது. 5 minutes will be allowed per team. சரியா? நீங்க தான் டிசைட் பண்ணணும் ப்ளீஸ். அதுக்கப்புறம் எங்க கிட்ட சங்கடப்படக்கூடாது. சரியா? மேக் இட் ஃபாஸ்ட்.
உசிலம்பட்டி உச்சிப்பட்ட சேடப்பட்டி நச்சுப்பட்ட
கலிங்கப்பட்டி கரிச்சிப்பட்ட கரியப்பட்டி வேர்த்துப்பட்ட
திருப்புவனம் சொக்கி நிக்க சிவகங்கை திக்கி நிக்க
அட வருஷ நாடு சாய வழி வாழ யூத்து சரியே புளிச்சம்பட்டி காய அந்த பூசலூரு கருக
இது கடற்கருவே காணாத தங்கம் இத களவாட போறதிந்த சிங்கம் இது கடற்கருவே காணாத தங்கம் இத களவாட போறதிந்த சிங்கம்.
நிறுத்துங்கடி நிறுத்துங்கல்ல பாடுங்கடி என்ன நக்கல. ஏய் நீ வா நீங்க வா எல்லாம் வரிசையா நில்லு. நல்லா இடுப்ப வளைச்சு நெளிச்சு ஆடணும். என்ன
இங்க கண்ட வக்கல கை வச்சுனா உனக்கு மரியாதை இல்ல. ஆமா
இங்கே வாரியா வைக்கத்த
காஞ்சிபுரம் டீம் கலக்கிட்டீங்க போங்க. காஞ்சிபுரத்தை சார்ந்த சித்ரா, யாமினி, ரமணி, ராதா, ஜெயலட்சுமி, கிருஷ்ணகிரியை சார்ந்த சித்ரா, யாமினி, ரமணி, ராதா, ஜெயலட்சுமி அனைவருக்கும் வாழ்த்துக்கள். அடுத்ததாக கோவில்பட்டி சிலம்பம் குழுவினர் தயாராக இருக்கவும். வரிசை எண் 11 கோவில்பட்டி சிலம்பம் குழுவினர் தயாராக இருக்கவும். வரிசை எண் 11 கோயில்பட்டி சிலம்பம் குழுவினர் ஹன்ஷிகா, தரீஷ், விஜய், அனோஜ், சித்தார்த், கௌதம், முகேஷ், ஹரிணி, தர்ஷினி. கார்த்திக் அஜய் எனும் HI அவர்களின் அகாடமியைச் சேர்ந்த குழந்தைகள்.
கோவில்பட்டி டீமிற்கு நினைவு பரிசினை வழங்குவதற்காக இணை இயக்குனர் டாக்டர் கிருஷ்ணராஜ் அவர்களை அன்புடன் அழைக்கின்றோம்.
கோவில்பட்டி சிலம்பம் மிகச்சிறப்பு, மிகவும் அபாரமாக உங்கள் திறமைகளை வெளிப்படுத்தியிருக்கீங்க. ரொம்ப நன்றி. பயிற்சியாளர் கார்த்திக் அஜய் ஹெல்த் இன்ஸ்பெக்டர் அவர்களுக்கும் அவருடைய அகாடமி குழந்தைகளுக்கும் நல்வாழ்த்துக்கள். அடுத்ததாக மதுரை ஃபியூஷன் டான்ஸ் டீம் தயாராகவும்.
நன்றி நன்றி.
அடுத்ததாக வரிசை எண் 12 மதுரை டீம் ஃபியூசன் டான்ஸ் ஆட வருகிறார்கள். அஜித் குமார், ஆதிலக்ஷ்மி, தங்கலக்ஷ்மி, நிர்மலா, சத்யா, கவிதா, சுபா, கோமதி, சிவசங்கரி அண்ட் தேவயானி.
சுல்தானா தொட்டவுடன் நெஞ்சில் தில்லானா தொட்டு பேசும் சுல்தானா தொட்டவுடன் நெஞ்சில் தில்லானா
அள்ளி அள்ளி கொடுத்தால் குறையாது
பள்ளி உள்ள வாடி அழகே
ஜாமத்தில் தருவேன் வாயா சுல்தான் சுல்தான்
தகதிந்தோம் திந்தியும் தொந்தனதிந்ததினுந்தோ அத்திந்தோம் திந்தியும் தொந்தனதிந்ததினுந்தோ தகதிந்தோம் திந்தியும் தொந்தனதிந்ததினுந்தோ ஆடாத செவ்வாறு மலாடிடும் பொம்மி ஆண்டவன பாலாட்டும் இசை கேளடி பொம்மி எம் பாட்டு வந்தாட மனம் துள்ளிடும் பொம்மி அவன் பாட்டு இல்லாத இடம் எங்கடி பொம்மி முத்தங்கள் முத்தாக தந்த பாட்டு படிச்சேன் பாட்டிலே பல கோடி நெஞ்ச நானும் முடிச்சேன் அத்திந்தோம் திந்தியும் தொந்தனதிந்ததினுந்தோம் தகதிந்தோம் திந்தியும் தொந்தனதிந்ததினுந்தோம். Hey, my golden sparrow!
சாங்.
அட ஆடியா
அந்த கங்கை ஆற்றில் ஒரு வண்ண பறவை மூழ்கியதே நீரோடு. அது கரையில் வந்ததே கண்கள் கோசம் வீழ்வதே.
அருமையான நடனம், பாராட்டுக்கள்.
அடுத்ததாக மதுரை அடுத்த குழுவினரின் குழு நடனம் பிரேமலதா, பழனீஸ்வரி, பாண்டீஸ்வரி, பாண்டிச்செல்வி, தங்கம்மாள் அண்ட் ரேவதி.
ஆடலுடன் பாடலை கேட்டு ரசிப்பதிலே தான் சுகம் சுகம் சுகம். மூணு முழம் மல்லியப்பூ உன்னை முட்ட கண்ணால் பார்க்கிறது. இஞ்சி ஏடு பழக
வைந்தாரே ஒரு உனப்பட்டுந்தாரே நீ ஒத்துக்கிட்டு வாடி நம்ம வட பக்கம் போவோம்.
ஆடியா
Hey!
பளபளக்க வைத்த DHO ட்ரைனிங் இன்ஸ்டிடியூட் பிரின்சிபல் இருவரும் மேலே வரவும்.
உங்கள் நடனம் போல உங்கள் பின் குசவமும் மிகவும் அழகாக இருந்தது.
அடுத்ததாக மதுரை சமயநல்லூர் A&M ஸ்கூல் மைம் அண்ட் ஃபியூஷன் டான்ஸுக்காக தயாராகவும். அடுத்ததாக வரிசை எண் 13 மதுரை சமயநல்லூர் A&M ஸ்கூல் மைம் கம் ஃபியூஷன் டான்ஸ் வாய்ஸ் ஓவர் given by சபானா. அபிநயா, ஹரிப்ரியா, மீனா, சுபானந்தனி, அனுஷ்யா, பிரஜினா.
மருத்துவ சேவை பல இருந்தும் பகுத்தறிவு பெறாத நிலை, பார்வை இருந்தும் பறிபோன நிலை. ஐயோ பரிதாபம் இன்றைய மக்களின் நிலை. அறியாமை இருள் ஏனம்மா, அறியாமை இருள் ஏனம்மா. மருத்துவ சேவை, ஆனந்தமாய் வாழ DPHின் அரிதான சேவை, இன்பம் பொங்கிட இனிதான மருத்துவ சேவை. அறியாமை இருள் ஏனம்மா, அறிவொளி காண சேவைகள் பல கேளம்மா. மனம் போல் வாழ மருத்துவம் பல இருக்குதம்மா. இருட்டாக இருந்தாலும் கண் தெரியவில்லை என்ற கவலை இல்லை இளம் சிசுவிற்கு. பார்வை இருந்தும் அறியாமை இருள் ஏனம்மா. மருத்துவ சேவையிலேயே மகத்தான சேவை மகப்பேறு சேவை. இருந்தும் வீட்டிலேயே பிரசவம் ஏன், அறியாமை இருள் ஏனம்மா. வயிற்றில் கருவாக வளரும் போதே தடுப்பூசி சேவை இருக்குதம்மா. ஆறுதல் சொல்ல யாரும் இல்லை என்ற எண்ணம் வேண்டாம் அம்மா. அன்பு காட்ட எங்கள் DPHின் அரிதான சேவை இருக்குதம்மா. கர்ப்பிணிகள் சுகமாய் நலம் பெற திட்டம் பல உள்ளதம்மா. கொத்து கொத்தாய் உயிரை பறிக்கும் கொள்ளை நோய்க்கும் தொடர்ந்து வரும் தொற்று நோய்க்கும் படையே நடுங்கும் இந்த பாம்பு கடிக்கும். வீரியமுள்ள விஷக்கடிக்கும் நடுநடுங்கும் நாய்க்கடிக்கும். உயிரையே காப்பாற்றும் உன்னத மருந்தும் இங்கு DPHில் கிடைக்குதம்மா. அறியாமை இருள் ஏனம்மா. திட்டங்கள் பல இருந்தும் சட்டங்கள் பல வகுத்தும் கண்மூடி ஆடுவது ஏன். மக்களே விழித்திடு, கண்ணை திறந்திடு, அறியாமை இருள் ஏனம்மா. அறிவு கண்ணை திறந்து பாரம்மா, அறிவு கண்ணை திறந்து பாரம்மா.
அனைத்து நல்ல விஷயங்களையும் அழகாக
குழு நடனத்திற்காக பிரியங்கா, சுமித்ரா, மணிமேகலை.
எவ்வளவு கூட்டம்!
நீலதஸ்வர போல வந்தா நீலதஸ்வரம் போல வந்தா கலலல்லா நீ ஏழஸ்வரம் போல வந்தா எட்டஸ்வரம் நானா எட்டஸ்வரம் நானா
We'll start a new movement, okay?
Yeah.
This is the hippo, okay?
Hippo.
This is the apu.
Apu.
பொன்மேனி பொன்மேனி இன்னாலும் என்னாலும் என்னை மறக்க தன்னை மறக்க
இந்த பக்கம் பார்த்தா தொட்டு பேசும் சுல்தானா தொட்டவுடன் நெஞ்சில் தில்லானா தொட்டு பேசும் சுல்தானா தொட்டவுடன் நெஞ்சில் தில்லானா
அள்ளி அள்ளி கொடுத்தால் குறையாது
பள்ளி உள்ளவாடி எழுதே
ஜாமத்தி வருவேன் மாப்பியா சொல்றேன்
இந்த பக்கம் பார்த்தா சரி பின்னால திரும்பி பார்ப்போமேன்னு பார்த்தா இது என்ன பிரமாதம்? இது விட பெசலைட்ட ஒண்ணு இருக்கு.
வட்ட வட்ட முட்டுக தட்ட தட்ட வந்ததம்மா நதி காத்து ஓ நதி காத்து முட்டு முட்டு மெல்ல மெல்ல மெட்டு விட்டு கட்டுதம்மா சூரி பார்த்து ஓ சூரி பார்த்து
பங்குத்து கும்முன்னா பொண்ண போல முத்து நாணி முத்து மூடாத என்ன பார்த்து ஐயோ நீ பொறியடி அல்வாவும் தரியடி.
ஒரு 2-3 லைன் கொஞ்சம் வேற மாதிரி ட்ரை பண்ணலாம்.
அட ஆடியா
மறிச்சு பார்த்தா நலம் தான உடலும் உணவும் நலம் தான.
கொஞ்சம் ஸ்பீட் எடுத்துமாமே.
DPH Icon 2025க்கு முதல் டீமாக ரெஜிஸ்டர் செய்து இங்கே வந்து ஹிப்பு அப்பு எல்லாத்துக்கும் விளக்கம் சொல்லிய எங்களது நாமக்கல் டீம் அவர்களுக்கும் திருச்செங்கோடு எம்எச்ஓவும் சேர்ந்து இணைந்து வாங்கி கொள்ளுமாறு நினைவு பட்டினை வாங்கிக் கொள்ளுமாறு அன்புடன் கேட்டுக்கொள்கிறோம். திருச்செங்கோடு எம்எச்ஓ வாங்க.
அடுத்ததாக பழனி டீம் மைமுக்கு தயாராகவும். வரிசை எண் 15 பழனி குழுவினர் மைமுக்காக பாலகுமார், பாலச்சந்திரன், சின்னசாமி, மனோஜ் பிரபு, அசோக், பாலமுருகன், ஆதவன், லோகநாதன், செல்வகுமார், வேல்முருகன், விஷ்ணுகுமார். குடி புகை போதையின் தீய விளைவுகளை பற்றி தெளிவாக எடுத்துரைத்தது பழனி டீமின் மைண்ட்.
பழனி டீமுக்கு நினைவு பரிசினை வழங்க என்னுடன் இணைந்து தஞ்சாவூர் CHO அவர்களையும் விடைக்கு வருமாறு அன்புடன் வைக்கின்றேன்.
அடுத்ததாக பரமக்குடி குழுவினர் குழு நடனத்திற்கு தயாராகவும். அடுத்ததுக்காக பரமக்குடி குழுவினர் குழு நடனம் பசும்பொன் சுரேஷ்குமார், அரவிந்த், செல்லப்பாண்டியன், ஹரிகிருஷ்ணன். வரிசை எண் 16 பரமக்குடி குழுவினர்.
வந்தாச்சப்பா, அப்புறம் பரமசம் வரல, ராமசாமி வரல, 5 பேர் விட்டு போச்சு, 4 பேர் விட்டு போச்சு, பேச்சே இருக்கக்கூடாது. ஏன்னா எனக்கு இது மாதிரி ஆயிரக்கணக்கான பஞ்சாயத்து இருக்கு. ஒரு மனுஷன் ஒரு தடவை வந்தாச்சுன்னா அப்படியே கப்படி யூஸ் பண்ணிக்கணும், புரியுதா?
இல்ல ஒரு 2-3 லைன் கொஞ்சம் வேற மாதிரி ட்ரை பண்ணலாம்.
அல்ல புனா பாட்டா போடுறா.
இது ஆள் பிடிக்குது, என்ன தோடு விக்குது, தோடு துடிக்குது, என்ன தொட்டா போதும் சொற்களகம் நாளால்.
பாட்ட மாத்திரா.
இது என்ன பிரமாதம்? இதை விட பெசலைட்டம் இருக்கு. பூவுடா பாருங்க.
யாருக்குமே திறக்காத இதய கதவு உங்களை பட்டு பட்டான்னு திறந்துருச்சுங்க.
அப்புறம் என்ன
படும் பொழுது சொர்க்க பூமிக்கே வந்துருங்க.
இவன் வேற என்னை ரொம்ப டார்ச்சர் பண்ணான்டா.
உள்ள கொண்ட பெரியவர்கள் கைதட்டி உற்சாகப்படுத்தி ஆரவாரம் பண்ணாரு. அன்போடு கேட்டுக்கிறோம்.
நேற்று ஒருத்தர் பார்த்தோம், பார்த்து ஒருத்தர் மறந்தோம். நேற்று ஒருத்தர் பார்த்தோம், பார்த்து ஒருத்தர் மறந்தோம். காத்து குளிர் காத்து கூத்து என்ன கூத்து, திருநாட்டுல நடக்கிற காத்துல கூட்டது பாட்டுதான், புது பாட்டுதான், தட்டத்தக கூட்டுதான், என்றதொரு கூட்டுதான், பாட்டுதான், புது பாட்டுதான், தட்டத்தக கூட்டுதான், என்றதொரு கூட்டுதான்.
வித்தியாசமான பாடல் தேர்வுகள், எதிர்பார்க்காத பாடல்கள், எனர்ஜியோட ஆட்டம்.
வரதராஜ் அவர் நினைவு பரிசனை வழங்குவதற்காக வரதராஜ் அவர்களை என்னுடன் இணைந்து SMD விழுப்புரம் முதல்வர்
அடுத்ததாக புதுக்கோட்டை பேர் நடனத்திற்காக தயாராகவும். வரிசை எண் 17 புதுக்கோட்டை மாவட்டம் ஹரிணி ஜனனி.
பெண்மையை போற்றுவோம், மடமையை ஓட்டுவோம். வகையில் அடுக்கின்ற பெண் சரிசமம் என்று சசனம் செய். தாயாதாரமாய் தோள் தரும் ஒளியாய் பூமியில் அவதரித்த தேவதை அவளே. மசகரவாண்டி வலி எல்லாத்தையும் தாங்கி தடுப்பூசி மாத்திரம் வந்து தவறாம உள்வாங்கி 10 மாசம் சுமந்து பெத்தெடுத்த புள்ள ஆண் பெண் இருவருமே தாக்கி சரி சமந்தான்.
குழந்தை பிறப்பது வரும் இல்ல, அதுக்கு நீ செஞ்சிருக்கணும்
கருவில் இருக்கும் சிசு ஆனா பெண்ணா என்று கேட்பது குற்றம். அதையும் மீறி மருத்துவர் சொன்னால் பல ஆண்டு சிறைவாசம்.
இலவச தடுப்பூசி மாத்திர மருந்து ஊட்டச்சத்து பிறகு அன்பா சுகமான பிரசவம்.
அன்னையரை காத்து ஊட்டச்சத்து தருமாக பேரு உதவி திட்டம். குழந்தையின் பிறப்பை மகிழ்ச்சி தருணம்.
அருமையாக ஆடிய புதுக்கோட்டை மாவட்ட ராமலட்சுமி ஸ்டாஃப் நர்ஸின் குழந்தைகள் ஹரிணி, ஜனனி இருவருக்கும் நல்வாழ்த்துக்கள்.
திருச்சி DHO அவர்களை நினைவு பரிசு வழங்குமாறு அன்புடன் கேட்டுக்கொள்கின்றோம். டாக்டர் ஹேமச்சந்த் கந்தி அவர்கள்.
அடுத்ததாக புதுக்கோட்டை திருவரங்குளம் ANM ஸ்கூல் குழு நடனத்திற்கு தயாராகவும். அடுத்ததாக வரிசை எண் 18 புதுக்கோட்டை திருவரங்குளம் ANM ஸ்கூல் குழு நடனம். ஜெனிலா, ஜோன்ஃபர் ராஜேஸ்வரி, சரண்யா, ஜெயலட்சுமி, சத்யா, திவ்யா.
கடமை செய்யடி, கற்றவர்கள் சமூக வாழ சத்தியம் செய்யடி. திசை மாறிடும் நதிகளை நீ ஒன்று சீரடி, திசை பாடிடும் புயல்களாக ஆகம் பாடி. நாடு வளம் பெற தட்டி கும்மி